Word document. So it's a reverse triangle sign that is basically seen in the onychomycosis. Again, jagged and spiked heads are seen. Then following are the causes of eumycetoma. Mozzarella mycetoma is a cause of eumycetoma. Then falciparum, it's the second most common cause. Pseudoalocharia boides again a cause, but streptomyces causes actinomycetoma. Type 1 is all except tocilizumab. Fimbriaceae is another name for yours. Then Samoma bodies, Samomatous, melanotic schwannomas are associated with the Carney complex. Good prognostic signs, easy one less than 10. Then Pasteur's lysa are seen in scarlet fever. And WHO declared COVID-19 is pandemic on March 11, 2020. So these were your questions. And the top 4 qualifying teams will be teams will sit on, then I'll just go down. No, I will just, after I announce the reasons, I will just come down. Uske baad phir start hoga. I am not just starting, it's off beat.
Because there should not be any confusion.
Yesterday only. हमने सारा बना के रखा है मैम.
Please, sir, carry on. Sorry.
No. So congratulations to everyone who did well, but we have to take top 4 teams only. So number 1 team qualifying for this is Osmania Medical College. Very well done. Then we have Apollo Medical College, Hyderabad. After that, we had Shadan Medical College, but they are not making it to the venue. They have some issues. Then we have Kakataya Medical College. And after that, we have Gandhi Medical College. So these are the top 4 teams. So in a short while, we'll start the proceedings of the day. This was something offbeat. So these 4 teams, just be ready. And can I just have 4 chits so that the teams can be allotted, they can pick up their teams, team A, B, C, and D.
Good morning, everyone. I'm Dr. Karthini, MD Dermatologist. We've had a very, very good, wonderful experience and response yesterday for the day 1. A very warm welcome to our respected teachers, seniors, and colleagues for day 2 of Telangana Cuticon 2025. It's a very beautiful, chilly winter morning. I hope everybody has had their warm cup of tea and coffee, as it's going to be a very exciting day with a lot of interesting topics. Like you all know, our theme for this year, Cuticon, is delivering skincare through progressive and comprehensive learning. I would like to start the session with a most awaited GSK quiz for the PGs. I would like to invite Dr. Shazia Jalani ma'am, who is the head of the National Quiz Sector for the IIDVL. Dr. K. Shravani, who is an assistant professor from Osmania Medical College. Chairpersons, K. Lakshmi Narayana, sir. and Dr. M. Gurunathan, sir. I'll now hand over the mic to Dr. Shazia ma'am. She'll take over. Thank you.
Hello. Good morning, everyone. We welcome to all quiz teams. Done, madam? 10 seconds. Yeah, yeah. Hello, good morning, everyone. We welcome Dr. Shazia Jilani as a quiz master, and we welcome teams also. Yeah. Shazia Jilani, Madam Associate Professor and Department of Dermatology in Srinagar, Jammu and Kashmir, and she presented more than 60 publications, and she guided 10 book chapters, and her presentations are more than 50. And very happy for Telangana to have such a senior person to conduct as a quiz master. And she earlier also worked as a scientific chairperson in Cuticon, Jammu and Kashmir, 2024. And she is a coordinator and worked as a scientific secretary at 13th Cuticon, 2023 in Srinagar. And she is a member of IADVL for quiz committee 22, 23, 24, and SIG dermoscopy for 24 and 25. She got best thesis award at PGRP, and she presented best paper in 3rd Onychomycosis 2014. And she is interested in dermatosurgery, pediatric dermatology, and connective tissue disorders. So, thank you, madam, for giving a wonderful opportunity to participate as a chairperson in your quiz committee. Thank you.
Good morning, everyone. Thank you so much, sir, for the kind introduction. So, we'll be starting with the teams. Team A, by means of chit allotation, Team A is Gandhi Medical College. Kindly take up your seat. Team B, we have Apollo Medical College. Team C, we have Osmania Medical College. And Team D, we have Kakatiya Medical College. Screen. So let me start with the quiz rules. We'll be having 8 regular rounds of 4 questions each and 1 rapid fire round. There will be no negative marking for wrong answers in any round. Can you just turn it a bit? Okay, done. So there will be 8 seconds and 10 points for the first team, and immediate answer and 5 points are expected from any passed on question. At the end, there will be a rapid fire round with 10 questions in 60 seconds and 3 points for each right answer. So a maximum score of 30 points in this round. So for the first 4 rounds, round 1 will begin from the team A. It will be a clockwise round. Then round 2 will start from team B, round 3 from team C, round 4 from team D. And for the last 4 rounds, it will be an anti-clockwise manner. Like round 5 will begin from D, then passes on to C, B, and A. So the structure of the regular rounds is like round 1 will be of basic sciences will be covered. Round 2, clinical dermat, then pediatric dermatology, leprosy, and tropical dermatology, then STIs and HIV will be round 4. Round 6 will be dermatopathology, then we'll have a round of therapeutics, and at the end we'll be having a dermatosurgery and cosmetic dermatology round. So I hope all the teams are ready. Just confirm. Okay, so one team member from Team D is expected to be here in how much time? So what do we do? We start with the first round or we wait? Okay, done. So just waiting for 5 more minutes. Observer has said it, no? Okay, done. So basically, for this quiz, we have observer as Sudhavani ma'am, and the observer's decision is final. We are going to start the quiz, and once your teammate joins, she can chip in, right? Ma'am, we start? Okay, done. So ready? All the teams are ready? So team A. The filaggrin mutations that have been associated with atopic dermatitis are located in which part of the gene?
Chromosome.
No negative marker.
Chromosome 1.
Ringer, 10 seconds.
Chromosome 1.
Which part of the gene?
1q21, ma'am. 1q21.
Team B? Team C? Team D? So basically the answer is third exon. It consists, the filaggrin gene consists of 2 introns and 3 exons. And the filaggrin mutations that have been found to be associated with the atopic dermatitis, they are located in the third exon of the gene, and they are loss of function mutations, mostly reported as nonsense mutation. So none of the team has answered it right. The second question goes to Team B. Team B, identify this person. He was an English surgeon and aspired to be a physician, wrote the first English language dermatology textbook. Name this famous person. Team B. If you have read your Rooks, it's there. If you have opened first few pages of your Rook textbook. Team C?
Lister,
Team D? Team A?
Paul Gerson Unna.
No, I suppose the students these days are not reading their textbooks. It's from your Rook's textbook. It's Daniel Turner. Daniel Turner wrote the first, when you go home, just open your Rooks, okay? See, it's on page 2, page 3, it's there. Daniel Turner wrote the first English language textbook of dermatology in 1712. This was a series of basically case reports and was popular, and it ran to 4 editions over the next 20 years. So this was our first textbook of dermatology. Team C. About 100 years ago, a famous young pediatrician came to be known as the creator of the idea of allergy, father of allergy. Identify this person, Team C. Team D? No negative marks. Just answer. Team A? You can just try. Team B? So, he is Clemens von Perkett, the creator of the idea of allergy. Basically, the concept was when an individual contacts with an allergen, the change in the reactivity occurs. And this change was initially called as allergy by von Perkett, and to induce a protective or a harmful response, the protective one renders the individual immune to the antigen. So that was the basic concept where the allergy came from. Team D, the fetal skin is predominantly.
Collagen 2.
Team B.
Collagen 3.
So Team B gets it right. So it's fetal collagen is generation, and we know in the adult it's replaced by collagen.
C and Team D are still at 0. All the best for the round 2.
Okay, so we will start our second round. It's a round of clinical dermatology, and it was going to start from Team B. Team B, your question. In case of dermatomyocytes, which specific autoantibody is associated with severe cutaneous involvement, amyopathic pattern, and rapidly progressive ILD? Team B, specific autoantibody. You know we have come up with these specific autoantibodies. Which one is associated with ILD, rapidly progressive? Team C?
Anti-MDA5.
Good. So, anti-MDA5, that means melanoma differentiation associated gene, is associated with the increased risk of ILD. So now we have the direct question to Team C. Team C, name the triad that consists of paniculites, erythematous, edematous tumors, carcinomas. Old hockey tumors, carcinomas. Old hockey player developed severe allergic contact dermatitis. Player developed severe allergic contact dermatitis in the shin pads. Most probably due to an EVA. Name the most probably due to an EVA. Name the most likely agent that causes. Team A. Team C. Team A. Team C.
Polystyrene.
No. So it's basically acetophenone azine. There was this 2021 because acetophenone azine was the ACDS quant testing can be done. This is a picture of the 42-year-old male with retroviral infection. And he presented with violaceous plaques, papules, nodules, history on immunohistochemistry. Which specific marker is present in this disease? Specific marker is present in this disease, in these shown in these pictures. You know the disease they are of? From pictures, can you get which disease is this? Yeah. So what are the? Can you get which disease is this? Yeah. So what are the specific markers in this disease? Team C. Team C. Team D. Team D. So most cited nuclear antigen of IADVL. Anyone in the audience? IADVL president. So we have Professor B. N. Banerjee. Professor B. N. Banerjee was the first president of IADVL. So scores at the end of second round?
So at the end of second round, Team B and Team C are scoring at 5 marks. Team A and D need to open their account.
Okay, so we are here with the third round, pediatric dermatology, and it's going to start from Team C. Ready? Yeah. Just join in. So round 3. Team C, a pediatric dermatological disorder with useless granulocytes and worthless platelets and peripheral neuropathy. You have to name the gene defect in this syndrome. Team C.
List one gene.
Exactly. Team C gets it right. So it is a lysosomal trafficking regulator protein which leads to the decrease in the phagocytosis, and the decrease in phagocytosis results in all the clinical manifestations like we have recurrent pyogenic infections. It's a case of basically a Shidak-Higashi. The picture was clearly showing the Shidak-Higashi syndrome with the slutty gray hair, albinism, and the peripheral neuropathy. Well done. So then we have Team D. Team D, the pediatric scalp disorder, characterized by a set of gall sticks on appearance on trichoscopy. Identify this pediatric scalp disorder. Team D. No negative marking. Team A.
Netherton syndrome. Common Netherton syndrome.
Team A, then B.
Triangular alopecia. Triangular alopecia.
Team C. Basically, this is a picture of bullous aplasia cutis. Basically, due to this bulla only, on trichoscopy, if we see, it gives an appearance of the golf sticks under this transparent membrane. Like you can see in this picture, the hair, they are arranged in a parallel manner. And due to the bullous nature of this bullous aplasia cutis congenita, you can see this appearance. Team B. Team C.
Erythromelalgia.
Team D. Anyone in the audience? So basically, onychomycosis, we have histiocytosis in this picture, and then we have hypertrichosis. Any guesses? Anyone in the audience? So H syndrome is basically a rare autosomal recessive histiocytosis syndrome. It consists of cutaneous hyperpigmentation, hypertrichosis, hepatosplenomegaly, hearing loss, heart anomalies, hypogonadism, hyperglycemia, low height, and hallux valgus. There are 3 pictures. They depict something. What is the gene mutated in this syndrome, Team B? Which syndrome is this? Team C?
Spink Y.
Very nice. So it was basically a picture of Netherton. Allergies was first picture, then there was a bamboo depicting the bamboo hair and ichthyosis linear circumflexa. So
Followed by team B with 5 marks. Team A.
round 4 will start with team D. This is a round. What was the theme for the World Leprosy Day 2024? Team D, Team A. Anyone in the audience? Theme for 2024, the end of the stigma that is associated. Direct question, you have to name the first leprosy hospital that was established in India.
It is in Calcutta.
Yes, good, right? You have to name the first leprosy hospital. Team C, Team D. I suppose we can give it to Team A. I leave it up to Observer. Mission Perovia Leprosy Home and Hospital. Okay, so Observer gives you full mark. Second largest in the world after Brazil. In Brazil, we have the first largest, we have the largest leprosy hospital, and second one we have in West Bengal. Vaccine, 2-dose vaccine used in monkey mpox. What's the name of this vaccine? It was in the news. Team D. So it's basically Gynecology. There were 2 types of main 2 vaccines for mpox. First one was ICAM 2000 that came. But then this came, Gynecology vaccine. It is a 2-dose vaccine that contained a weakened and non-replicating orthopox. So, Team C, your direct question. According to WHO Global Leprosy Update 2023, that was the recent one, highest number of leprosy cases in the world. No negative marks, just attempt. Team D. Team A.
Indonesia.
Excellent, it's Indonesia. Brazil, and third one is Indonesia with 16,800 disorder from the picture. What is this disorder showing? Any guesses? So it is basically latex fruit syndrome, and the people with latex allergies, they often have the food allergy, typical to the fruits that have proteins similar to found in natural rubber, like in avocados, banana, chestnut, and kiwi.
E is leading with 20 marks. Followed by Team A with 15 marks, followed by Team B with 5 marks, and Team D, 0.
So great. Any round can change the scores. 5, you know, it will start in it. anti-clockwise manner, and the questions will get passed from D to C to B to A, right? Common cause of pruritic follicular eruption affecting HIV-infected patients, MSMs, men who have sex with men. Name the most common cause of pruritic follicular eruption. Really easy one, easy question. Team D. Team C.
Papillopyrotic eruption of HIV.
Team B. Team B gets it right. So, Team C, your direct question. In case of secondary syphilis, the peripheral scale is this sign known as. Get it right. So, it's bed-colored sign, named after Laurent Theodor Bed, a Swiss-born dermatologist who lived from 1781 to 1840, way before dermoscopy came. It was there. It was first described as a thin white ring of scaling on the surface of secondary syphilitic lesions. Team B, your direct question. Team B, it's a long-acting injectable drug given twice a year, approved for the treatment of HIV in adults with multi-drug resistance. And the most important thing about this drug is that it's also being studied as an investigational treatment for HIV prevention. In studies, it has been shown, in some studies 100% and in some studies 96% reduction in the risk of acquiring HIV among the study participants. It's in news all over. Team A?
Lenacapavir.
Excellent. It is lenacapavir. So lenacapavir basically, it helps by targeting the HIV capsid, and it interferes in the with multiple early to late stage processes on the basic processes of the HIV. And in 2024, Science Magazine has named lenacapavir as the 2024 breakthrough of the year, citing astonishing 100% efficacy in one large efficacy trial conducted in women. And in other trial that was conducted in not only in women with other persons also, there was 96% efficiency. So it's a very new drug. Your direct question. Multifocal epithelial hyperplasia is a rare benign oral condition that causes white to pinkish papules or nodules in the mouth. What is the exact etiology of this condition?
It is Hex disease caused by HPV 13 and 32.
Excellent, Team A. Very nice, very well done. It is Hex disease. So I didn't mention Hex disease on purpose. I just told you the other name. Very nice. It's HPV 13 and 32. So, at the end of this round, can we have just the scores?
So at the end of round 5, the scores are Team A and Team C are leading with 30 points each. Team B with 10 marks, Team D 0.
Very nice. So, scores can change any time. One round and the scores will be turned up. So we have a round 6 of dermatopathology. Team C, your question. Name the disease based upon the histopathological appearance.
Actinic keratosis, flax sign.
Excellent. This is flax sign and actinic keratosis. Basically, it's characterized by alternating bands of orthokeratosis and parakeratosis, which is similar to the strips of a flag. Team B, your question. Name the disease based upon the histopathological appearance. Team B. Just try. No negative marks. Team A. Team D. Team C.
Sweet syndrome.
No, it is basically, what is this? This X. Anyone in the audience? Anyone from the audience? So it's basically a promontory. So it is seen in? Yeah. So basically promontory is a raised area of land or rock that extends into the body of water, and it's similarly seen as the small vessels they protrude into the larger abnormal vascular spaces in cases of patch and the plaque stage of Kaposi sarcoma. So you basically know promontory, but you don't know what it is, so you have not guessed it right. So Team A, your direct question. Name the disease and based upon this histopathological appearance. Say it on the mic.
Dermatitis herpetiformis.
Very nice. And what is this appearance?
Ma'am,
You get your marks, just.
papillary deposit.
So this sign is?
Fence.
Very good. Picket fence sign, eh? DH, dermatitis herpetiformis. Basically, this is a picket fence appearance seen as a pattern of IgA deposits in the skin that can be seen on the DIF in DH, and the deposits are granular and they are vertically elongated, giving the appearance of a picket fence. Team D, your question. Name the diseased based upon this appearance. Team D.
Gaucher's disease. Gaucher's.
Team C.
Pseudoxanthoma elasticum, raveled appearance.
Very nice. This is the raveled appearance, raveled wool appearance seen in Pseudoxanthoma elasticum due to these wavy, clumpy elastic fibers. So scores at the end of this round.
So end of 6th round, Team C is leading with 45 marks, followed by Team A with 40 marks, followed by Team B with 10 marks, and Team D still 0.
Very good. So we are having a tough competition here. We will be starting with the round 7. It's a round of therapeutics. So Team B, your direct question. Who coined the word hydroquinone? Name the person who coined this word. Hydroquinone you use right, left. Team A.
Clickman. Clickman.
No. Team D. Team C. So it is basically Friedrich Wöhler. He was the father of organic chemistry, a German, and he was first to synthesize an organic compound from an inorganic substance and named it hydroquinone. So the next question goes to Team A, your direct question. On May 19, 2023, FDA approved first topical gene therapy for the treatment of wounds in patients with dystrophic epidermolysis bullosa. Name this drug.
Derimagine Gaperpavec. Derimagine
Very good.
Gaperpavec.
So other name is?
The brand name is Vyjuvek.
Excellent. Very nice. It is basically a herpes simplex virus type 1 vector-based gene, and on May 19, 2023, US FDA approved this for the treatment of wounds in the patients 6 months of age and older with dystrophic AB as it contains the collagen type 7 1A gene mutations. So, right. Team D, your direct question. Name the first and the only FDA approved fixed dose triple combination topical treatment for acne. Recently approved. Team C.
Caprione, which is
Excellent.
composed of clindamycin, adapalene, and benzol peroxide.
Very nice. It is Captrio that was approved on October 20, 2023 by US FDA. It contains all the 3 components. It has clindamycin. C stands for clindamycin, A for adapalene, and B for benzoyl peroxide. Team C, your direct question. First line treatment option for the management of non-immune contact urticaria. What is the first line of management?
Topical calamine. Topical calamine.
Team B. Team A. Team A.
ASST.
Team D.
Topical antibiotics. Topical antibiotics.
No. It is basically aspirin and aniseeds. If you would have known the basic pathomechanism of this non-immune contact urticaria, that occurs basically with the non-immunological processes when the skin comes in contact with these substances, and these substances cause the blood vessels to dilate. So in this, we have the first line of management in the form of aspirin and aniseeds. So question for GSK people, they are just staying there. GSK people, when was GSK established? No, GSK. Any guesses from the audience? When was GSK established? GSK people are not able to answer it. So, anyone in the audience? GSK was basically established in 2000. It was a merger between Glaxo and SmithKline. It's a very old brand. Glaxo was established in 1873, then it merged with Wellcome in 1880, and Wellcome was in 1880, they merged in 1995, then SmithKline and Beacom, they were the companies established in 1830 and 1848, very old companies, they merged in 1989, and Glaxo and SmithKline then merged in 2000 to form what is called as GSK, what we call as GSKs in this, for this GSK quiz. It was for you. Okay, so next question. So scores at the end of
So at the end of round 7, again team A and C are leading with 50 points each, followed by team B with 10 points and team D at 0.
Okay. So we start with the round D. Round D is a round of dermatosurgery and cosmetic dermatology. Team A, what is Howard technique? Where is it used? You will get marks for where is it used. Howard technique. Have you heard of it? Howard.
Facelift.
Team D, it passes in an anti-clockwise manner.
Vitiligo.
Team C,
Scalp biopsy, ma'am.
excellent. So, how and what? It is horizontal and vertical. Basically, what we do in scalp biopsies for alopecia, it requires both the horizontal and the vertical. We divide it into three parts. The upper one, we divide it vertically, and the lower two portions, we divide it horizontally to see the bulb area. So, Team D, your direct question. In case of Q-switch laser treatment for tattoo removal, name the technique wherein the repeat pass is performed immediately without waiting. In case of Q-switch lasers, what is this technique called as? Team C?
R0 technique.
Excellent. So how do we do this R0? What do we use?
Perfluoroalkyl spray is used.
Excellent. So no guesses here. They know the right answer. Because the R0, previously we used to do R20. We had to wait for 20 minutes. But when we use this chemical, perfluoroalkyl, it absorbs the release gases and clears the frosting within 3 to 5 seconds. So we can immediately go for the next session, next round of in the same session. So Team C, your direct question. In case of injection of hyaluronic acid fillers, name team one speaker so that there is no chaos. One will say one answer. One speaker so that there is no chaos. One will say one answer and the other one will just choose one speaker among yourselves who will answer will give the answers. Each team will get 10 questions within a total time of 1 minute. That means 60 seconds, 10 questions. After which the rapid fire for that team will be over. Unless and until you say pass, you will not get the next question, right? If you can just go back to that question at the end if you have time, but unless you say pass, next question won't be displayed. And each question, right answer carries 3 marks. There will be no negative marks. In fact, if you say any answer incorrectly, but later on you rectify, you get the marks, full marks, no wrong answers. So we start with Team A. Team A, you are ready? Who will answer? Just you can discuss, but one person will answer. So ready, Team A? Buzzer is ready? So Team A, your time starts now. ACDS antigen of the year 2024. Michaelis-Guttman bodies are seen in?
Pass.
Renbach phenomenon is seen in?
Inverse Copnius phenomenon. When two autoimmune conditions coexist. Reverse Copnius phenomenon.
Term impetigo herpetiformis was coined by?
Pass.
Expand the acronym TRACER.
Pass.
The first dermatologist credited with the use of peels.
Unna.
Mechanism of action of sirolimus.
It is an mTOR inhibitor. Mammalian target of
Carrion's disease is caused by
Pass.
Urbach-Wirth disease, also known as
Lipoproteinosis.
Beauty and the B sign on dermoscopy is seen in time out. So how many did they answer? Which one? No, give them this one also. So here are your answers. So ACDS antigen of the year 202 was sodium disulfide. Michaelis Guttman bodies, they are seen in malakoplakia. Renbach phenomenon, I give it to you, when two conditions like alopecia areata and psoriasis exist, it's an opposite of basically Cobner's phenomenon. The term impetigo herpetiformis was coined by von Hebra. Expand the acronym TRACER. TRACER is total reflection amplification of spontaneous emission of radiation. First dermatologist who is credited with the use of peels is Ferdinand von Hebra. Mechanism of action of sirolimus is mTOR inhibitor. You answered it right. Carrion's disease, Bartonella bacilliformis. Urban-Weir disease is lipoid proteinosis. And the beauty and the B signs was very easy. It is seen in melanoma, right? So, team B, you are ready? Team B, your time starts now. Most common allergen responsible for the allergic reactions due to nail polish. Coop-Dongle sign is seen in occurrence of a different unrelated dermatological disease at the site of healed disease. Pertinix bodies are seen in example of the 4th generation retinoid. Expand the acronym CANDLE. First report of dapsone resistance was given by. Name the peel which has solid CO2 plus 35% of TCA. Which country was first documented, in which country was the first documented case of human mpox seen? On dermoscopy, tulip bulb hairs are seen in. So, we get it? So what was example of 4th generation retinoid you told us? Okay. So the answers are the most common allergen responsible for the allergic reactions to the nail polish is tosylamide formaldehyde resin. Coop-Dongle sign, you answered it right. It is in pityriasis versicolor. This phenomenon is called as isotopic phenomenon, and it's not seen in lichen planus, it's seen in the herpes zoster. On healed herpes zoster, it's the opposite of this, na, Cobner's. Healed herpes zoster, we do have the lesions sometimes. So even if you had answered herpes zoster, I might have given it to you, but you told me lichen planus. So senile lanes, Pertinix bodies are seen in that. 4th generation is triferrotine. Tazarotene is not the 4th generation. CANDLE stands for chronic atypical neutrophilic dermatosis with lipodystrophy and elevated temperature. First dapsone resistance, it was very easy, Petitent Rees. Brody's peel is solid CO2 plus 35% TCA. First documented case, I give it to you. You told me Africa, it's Republic of Congo in Africa. On dermoscopy, tulip bulb hairs are seen in trichotillomania. Okay? So you get 2 rights. Team C, you are ready? Team C, most common chemical used for patch testing to detect hydrocortisone allergy.
Pass.
Jodhpur technique is used in?
Vitiligo surgery.
Caterpillar bodies are seen in?
Porphyria cutanea.
Expand the acronym IMPACT.
Pass.
Itching purpura, type of PPD. Other name is?
Pass.
Name the peel having Jessner's plus 35% TCA. Quick.
Pass.
Mechanism of action of crisaborole.
PDE4 inhibitor.
Stemmer sign is seen in?
Lymphedema.
In which year botulinum received FDA approval for aesthetic use?
Pass.
On dermoscopy, Aurora borealis pattern is seen.
Onychomycosis.
Would you like to get back to some question?
Mon heat. Sixth question is mon heat.
Anyone else? You can answer any of these.
Impact is erythema multiforme secondary to phenytoin and carbamazepine.
So, oh, very well done. So, it is most common chemical used for past testing to detect hydrocortisone allergy is tixocortol pivalate. And Jodhpur technique, it was right. Vitiligo surgeries, caterpillar body is right. PCT. Then acronym impact is for erythema multiforme associated with phenytoin and cranial therapy. Itching purpura is Gogret and Blum purpura. Then Monheat you answered right. PDF4 you answered right. Stimmers and lymphedema. Then in which year botulinum toxin received FDA approval? It was the year 2002. On dermoscopy, Aurora borealis is seen in onychomycosis. It was your yesterday's question also, I suppose. So, Team D, you are ready? Start. ACDS allergen of the year 2023.
Pass.
Hamburger sign is seen in? Be quick.
Pass.
Heave test is done in? Hippopotamus appearance of the face is seen in which type of mycosis? Be quick, this is rapid fire. Acronym cloud stands for?
Pass.
Name the peel. Glycolic acid 70% plus TCA 35%. Mechanism of action of Liarozole. Term syphilis was coined by? The term teledermatology was coined in which year? On dermoscopy, hand glider sign is seen in? Any you can answer. You have time. Just try. No negative marks. Okay, so the answers are ACDS allergen of the year 2023 was lanolin. Hamburger sign is seen in trichotillomania. Heave test is a very old test done on tuberculosis. In conidiobolomycosis, we have hippopotamus appearance of the face. Acronym CLOUD stands for congenital lipomatous overgrowth, vascular malformations, epidermal nevus syndrome, epidermal nevus and spinal or skeletal anomalies. Coleman's peel contained TCA with 70% of glycolic acid. Liarozole is a ramba. It's a retinoic acid metabolism blocking agent. Syphilis was turned by Gyro Castro. Term teledermatology was coined in year 1995. And on dermoscopy, hand glider sign is seen in scabies. So, the final scores, any guesses? So they have already clapped. So, yes, and Team A, Team C, you are the winners here with 81 points. Team A was a close. Team A had 59 points. Team B, very well done, 16 points. So Team C is Osmania Medical College. Very well done, Osmania Medical College. Team A is?
Gandhi Medical College.
Gandhi Medical College. Team B, Apollo Medical College. And Team D is? Kakatiya. Very well done, all of you. So it was a very exciting round. Hope all of you have enjoyed the quiz, and congratulations to the winners. And our winners go into the final round of Dermacon that will be held in Jaipur. So you are going there, Team C, Osmania Medical College. Congratulations.
Thank you, Dr. Sajja, Quizmaster Cuticon TG 2024. And congratulations to Team C, Osmania Medical College, Hyderabad. And would like to thank the organizing team, particularly Dr. Sudhavani, for giving this opportunity to chair this quiz session. Thank you.
That was a very good show and quite a brainstorming session. Thank you, the chairpersons, for conducting this session. And congratulations, all the team. I request you all to move to the certificate booths there for the certification. I request Dr. Shahana ma'am and Madhavi Reddy ma'am to hand over the certificates. Mementos to the chairperson, I'm sorry. Round of applause, please. Let's start the sessions for today. So for the first session, I request the chairpersons to come on the stage. Dr. V. Ramesh sir, Dr. Ramchandar Darak sir, and Dr. Sudhavani ma'am. I would request Dr. V. Ramesh sir, Dr. Ramchandar Darak sir, and Dr. Sudharani ma'am to come onto the stage. I also call upon the moderators, Dr. P. Narasimha Rao sir,
Excuse me. Speaker details, speaker CV. Kundi, speaker CV. Details.
Okay, shall we start? Okay. Oh.
Hello.
Good morning, everyone.
Good morning to everybody.
Yes.
Well-known person, speaker Dr. Narasimha P. Narasimha is on the dais. He will speak on leprosy by 2030. So, we'll invite Dr. Narasimha. Please carry on, sir.
Yeah.
CV. Right. I request panelists, Madam Pavitra Vani, Dr. K. Sujay Sunita, Dr. Ram Mohan, Dr. Nirmala Prabhavati, and Dr. Uday Kiran. Please come on to the dais. There are 5 panelists today. And moderator Dr. Narasimha Rao. Session on leprosy, zero leprosy by 2030, and its role by IADVL, please. Well-known panelist on leprosy, Dr. Sujay Sunita, Uday Kiran, Ram Mohan, Prabhavati, and Pavitra Vani ma'am. Please carry on.
Thank you very much, Dr. Professor Ramchandra Darakji, and all the chairpersons, and thank you Sudhavani Garu for, acceding to my request and joining the as a chairperson. So today we are going to have a panel discussion on the role of IADVL and the WHO proposed target of having zero leprosy by 2030. Now its time is 9:25, 9:23, so we have about half an hour time. So I want our panelists to be quick and precise to the point. We shall start by saying these are the panel members of this team, and Dr. Anant Reddy has come, and it is Dr. Uday Kiran, who has been the chairperson, is now accepted kindly to be the panelist. So we all know that WHO Global Leprosy Strategy 2021-2030 was developed through a consultative process. I think the strategy focuses on interrupting transmission of leprosy. So the keyword here is the transmission of leprosy. WHO wants to, and IADVL also looks at how to interrupt the transmission of leprosy. So that is the focus. And of course, India is a high burden country, so India follows and implements WHO Global Leprosy Strategy. And what are the goals? The goals is by 2030 they want to reduce annual case numbers by 70%, new cases, and 90% reduction in the rate in the grade 2 disabilities, and 90% reduction rate per million children of new child cases with leprosy. So this is the targets from the 2020 projected baseline. So with this, the first question to any panelists, I would like to, all the panelists. We had COVID-19 between 2020 to 2022, and it influenced all major health programs across the world in this decade. And in your opinion, what is COVID-19's influence on WHO leprosy target of zero leprosy by 2030? Yeah. Dr. Sujay? Yeah.
Thank you, Dr. Narasimha Rao. Yes, during the COVID lockdown, people with leprosy or suspected of leprosy could not access services, both diagnostic or treatment. And therefore, the numbers showed an artificial drop during COVID, and there's been a bounce back in numbers back to what it was many years ago, about 1 lakh plus cases, new cases a year. So whether that bounce back will actually affect zero leprosy by 2030 needs to be watched. But definitely I think there was continued transmission of the disease during COVID, because a lot of new cases continue to transmit the disease. So I feel aiming for 2030 is a little utopic, considering that we had COVID in between.
Yes. Thank you, Dr. Sujay. So just looking at, yes, you are absolutely right. You can look at this graph and we can see that up 2019, this pointer is showing that thing. Pointer is showing that where it has, it was 2019. The figures were around, global figures, and also towards the right we have the Southeast Asian region, which is broadly represented by India. So, and there is even drop in both in 2019, and that trough which is again coming back in last 2 years. So between 2020 to 2024 this year, there are 4 years we have lost the numbers. There was a drop and there is correction. So do you think, Dr. Nirmala ji, that these 4 years, this correction will affect the target of 2030, achieving the target by 2030, because we lost about 4 years because of this? Can you, I want to be brief and to the point. Thank you.
So, so to say that during the COVID, sir, the reasons, as per the WHO, there is a decline of 37% of new case detection rate decline. But as per this COVID, there were
can you keep your mic to the close end?
Multiple reasons, because of the transportation was also affected, and then the
we all know the reasons. Yeah. What I am asking is, do you think it will affect that 2030 target?
Exactly, sir. So now that all those who were responsible for the decline are to be corrected. So the funds have been mobilized towards COVID-19 alone. So now that the government and the other agencies also have to concentrate on the reallocation of the funds, particularly towards leprosy, to achieve the zero transmission.
Okay.
So can I add one?
Any other opinion, please? Yes.
Actually, when the incidence has dropped down, but the reactions, the complications have increased during that 2-year period actually. So, and after that, there are a lot of cases of multibacillary cases. So they have to revise the plan, or do some modifications to active other things.
Yeah, that is true, sir. Because of the late detection, so the morbidity of the situation has increased.
Thank you. So we all agree that there has been a drop, and then probably this needs to be taken into consideration before we look at 2030 as a target. Maybe a revised target will come next year. 2025 is a mid time. By mid year between these 10 years, so there can be some correction which can happen.
So, can I say one more thing?
Please.
I think on the positive aspect, during COVID, the government established PCR testing for COVID widespread in India. So if the leprosy program, if we develop a good point of care molecular diagnostic test, and we piggyback it onto that COVID setup of machines all over the country, then I think we can detect cases earlier and maybe achieve zero leprosy by 2030. So I think that's something that we can take from the as a positive indication, but we need to develop that good point of care leprosy diagnostic test to be able to use the COVID machines.
Yeah, thank you. So there is some positive development due to COVID. So what they say is the sweet are the uses of adversity, like Wordsworth says it. So there are some always advantages when you are in disadvantaged position. So probably this can be a
and to add one more thing, sir, because of
I think we'll go to the next question. Yeah. So we have about a very short time. So India, I just want to show the audience that India is yet to achieve leprosy elimination sub-nationally. there are about 112 districts in the country with significant leprosy, and among them 25 districts have PR of more than 1 per 10,000 population, which is a 205 target. So more than 25 districts, and also there are 182 tribal districts, or districts with predominant tribal population. Of these, 43 districts have leprosy with prevalence rate of more than 1 per 10,000 population. So this tells us that leprosy is far from over in India. Okay, and of course at this time, Government of India developed National Strategic Plan 2022 to accelerate the effort towards leprosy control, especially keeping the COVID pandemic in view. So with this, also what is important is in this the Government of India mentions that it will be necessary to get into partnership with IADVL. So this is almost for the very few times that Government of India document mentioned IADVL association by name, and it expects us to support the program nationally. So it is essential for IADVL to work with Government of India in whatever way it is, which is going to be the next part of the discussion, how we can take it forward.
Can I add, sir, one point?
Yeah.
WHO Act, this time they mentioned the adding of referral centers, medical colleges,
Yeah.
also in WHO document itself.
Absolutely. So we are going to discuss that slightly. Okay. So now, yes, WHO Global Leprosy Strategy talks about interruption of transmission. Now, in your view, Dr. Ramondi, how can we, IADVL, take it forward? Please suggest 2 possible initiatives by IADVL. If you can, or at least one initiative. How can we take it forward as dermatologists or IADVL, to association or as individuals?
One is make it notifiable, because most of us don't have that knowledge. Of course, I see only 7 to 8 patients, probably 10 at the most in a year, being in a corporate hospital. But there is no clear-cut guidelines for notifying.
Notification.
And where to notify, and that it should be a notifiable disease. And preventive aspects, I was thinking that we should, apart from, I think you will be coming to that later about the preventive dose of rifampicin, single dose. And
Yes,
all
we'll
that.
come to that later.
And then vaccination. These 3 are my.
Thank you, thank you. So Dr. Pavitravani is mentioning that leprosy should be made a notifiable disease. For those of you who are not aware, leprosy as a disease is not a notifiable disease yet in Government of India. While tuberculosis and other diseases, for example rabies and COVID, are notifiable, leprosy is not yet notifiable. So that also comes in the way of elimination of leprosy across the world. Yeah. Anyone else like to take it?
We can enhance the accuracy of the treatment, because being the leprologist.
Can you say it again, please?
Being the leprologist, we can add to the accuracy of the diagnosis.
Accuracy. So we
and
can.
early detection.
Yes, absolutely. Thank you. So we have to be add to the accuracy of diagnosis, making the diagnosis correct diagnosis of leprosy and early diagnosis.
You explain the patients that the chemoprophylaxis is being given at the grassroots level.
Yeah.
But you try to convince the patients, bring the attendants so that you yourself examine the patient, not the patient, the family members, so that you can identify the cases early. Okay. That can be done actually.
Very good. So, yeah, management of contacts, looking at the contacts of each patient, and then probably identifying disease if there is early, and also providing exposure prophylaxis, PEP, whenever possible. Dr. Sujay?
Yeah, I just thought that, in the DermLab survey conducted by IDVL, SIG leprosy showed that to a great extent, dermatologists are the first point of contact for individuals with a skin lesion. And therefore, I think for dermatologists to recognize that they can play an important role in the diagnosis, in the management, as well as like others said, on the confirmation of new cases detected, I think dermatologists have a great role.
Oh.
And recognition and acceptance of that role.
Thank you.
That
Yes.
we can treat, and we should be the people
Yes.
at the front line treating.
Yeah, thank you, thank you. So Dr. Sujay is mentioning that dermatologists should own up that they are the specialists of leprosy, and they should take it forward. They should take lead in the management of leprosy and in diagnosis as well. Dr. Kiran? Yeah.
This, whatever the transmission, if we want to interrupt, the main focus should be on multibacillary cases. And in our own experience, we have found that apparently normal looking lepromatous leprosy cases are very high in their BI and MI. And one of the ways to confirm the diagnosis is by doing skin smear, as you all know. But it would be very important that we should develop skin smear testing facilities wherever it is possible, and with a certain level of accuracy. And unless we have the most important test in leprosy, skin smear, available very easily in either private labs or in medical colleges or elsewhere, and somebody should try to check their the level of accuracy. So this test needs to be given more importance.
Thank you, thank you.
Yeah,
so
I add to that.
the present, so he mentioning that there is a lack of skin smear services across India and also in our state as well. So there are very few centers where private centers are available where the patient skin smear can be done. So there should be more facilities so that we can diagnose accurately.
No, continuing on those lines, the smear facilities may be available. They say they are doing it, but most of the technicians don't know how to do it. Maybe IIDVL can send a few people to each place and train.
So IIDVL can take up initiative in training or maybe retraining the centers. Yes, thank you very much.
Sir,
with this, I think we'll. Doctor.
Sir, one sec. Because now we have 32 medical colleges all over. And another thing, as such, the patient first to come to dermatologist only. And in our state, actually, some areas are very, when I worked in Nijam, in the Dermalep survey, in 3 years we got more than 450 cases, out of which 60% are multibacillary. And this today, one of our student presenting, it is about 420 cases, last 2 years data, sir. Almost 57% are multibacillary. So through association means we can request majority of the faculty we know, screening of leprosy. So each and every patient, that also, see, every OP we get 100, it's not that difficult to screen the patients also. If you want at root level means we can suggest how we are doing Cello Patasala, we can screen for leprosy also.
Yes, coming from Dr. Sudharani, it is very, very, Professor Sudharani is very good because she is going to be the incoming president, and with the team she can work how the Telangana State IIDVL can take up this matter of screening and also supporting the program. Thank you, ma'am. Thanks for putting it. So, in my view, methods of interruption transmission can be only 3 or 4. One is early diagnosis. If you diagnose leprosy early, yes, we get interruption transmission. Second is reducing transmission by giving SDR PEP, single dose rifampicin, as suggested by Government of India. And third is effective treatment, like all of them mentioned, of especially multibacillary cases, smear positive cases. And lastly, of course, we have got preventive vaccine. If it is when and where it is available, maybe we can give therapeutic vaccine as well. We will come to that later. Now how can IIDVL support active case search campaigns? So we have got a lot of active search campaigns. Government of India suggests passive and active searches, leprosy case detection campaigns, focused leprosy campaigns, special plans. So in all this, my question is that can IIDVL, can probably what I am saying is the President Secretary of State IIDVL go to the leprosy state officer or district officer and go to the Koti and work with them, offer our services in detection. Can we do it or should we do it? Yeah, can we? I want to be brief,
yes,
because we have only another 15 minutes.
As you remember, we all went one day to our Director of Health. So that can be done, as now Madam also suggested, Cello Patashala like that. We can actively participate in active case detecting.
We should.
Yeah, we should.
So can we go and give a representation to them?
Exactly, sir.
Yes. Anyone else like to have that?
Just, I feel as dermatologists, it will be very tough to be involved in a active case search campaign.
Okay.
But I think we can support such campaigns.
Yeah, there are. I mean, I just want to just bring the attention of everybody. Not only there is case detection campaign, there is also focused leprosy campaigns. There is special plans for active cases, hard to reach areas. So various other methods are there. Maybe we can contribute one of them. For example, a team in Karimnagar can just work in the Karimnagar itself, because hard to reach areas may be there. Something in Warangal can work in that area. So probably we can devise some means which doesn't really trouble us a lot, but we can support the program within our own means, what I was saying. So any comment from the president, incoming president, or yeah.
Actually, leprosy in the beginners is neglected.
Yeah.
So they have to be, academically it should be perfect in diagnosis and early diagnosis of leprosy. That's very important. Should base at all the juniors, they are just mentioning only on the cosmetology of it. So they have to be trained clinically about the leprosy and its clinical features, perfect diagnosis, so that you can interrupt the transmission. That's my.
One suggestion, sir. Yeah. Undergraduate curriculum is very, very important. But most of the cases have been dealt by the undergraduate, the basic MBBS doctors. So we have to train them properly, and we can ask the national body to have a question in the paper of undergraduate curriculum for in leprosy, so that they'll read the leprosy.
So very good.
That is one
good way of doing it. Yes. Yeah.
And MSET also, the NEET exam also, one question is enough for them to read.
Yeah. Dr. Ramesh wants to say something.
See, I have seen many prescriptions. They have first they go to a neurophysician. They keep on seeing the patient after 1.5 years. They come to us. They think that it's a neurological problem. And I don't know why they don't diagnose, or they ignore, they are ignorant, they don't teach Hansens in their curriculum, I don't know. I think we should focus on that neurophysicians aspect also.
Okay.
So we have to consider them.
Yeah,
Most of the,
we should work across the board, across the specialists like neurosurgeons as well.
Yes.
Sensitize them about importance of early diagnosis.
Yeah, that was what I was going to come to. Have like we had during leprosy sessions in the hospitals also, so that other specialties, because very often they also in those hospitals, they'll be the first people who are approached, physicians and neurologists.
Sure. Thank you.
Many cases are being treated, fever, lepra reaction cases are being treated as a PO, and tuberculosis, several years with anti-TB treatment. So that's also focused.
Yeah.
Diagnosis of
probably
leprosy.
you mean that cases are being missed.
Yes.
The diagnosis is missed.
Yes.
So we should focus on that. Yes.
Especially infective cases.
That has to be brought to the attention of our specialists.
Yeah. Right.
Yeah. Thank you. So anyway, coming to the question, what is the acceptance of single-dose rifampicin? Government of India and WHO support single-dose rifampicin, but there is, what is the level of support of single-dose rifampicin treatment by IADVL community in general? So I just want to say yes or no from all of you. Do you support giving of PEP, starting from Dr. Vani? Yes? Yes, Dr. Ramon? Do you support giving of SDR PEP for contacts?
Yes, but not this one, sir. There is a modified.
Yeah, you don't prefer SDR PEP,
yes,
but you want a modified version. Yeah, Dr. Sujay?
Yes, but only family contact.
Family contact. What about Dr.? Yes, okay. So we are talking about single dose rifampicin should be given to all the family contact. One dose will be supposed to be given to all the family contacts as well as neighborhood contacts and social contacts. Maximum about 20 people, if I am right, 20 people around the family members and social members are to be given this single dose rifampicin. Post-exposure prophylaxis, once you make a diagnosis index case, all the patients around him, all the persons around him, all the contacts should be given this single dose rifampicin. This is Government of India's project and it is happening right now. And of course, generally I think all the panelists do agree. So what is the scope of implementing? Yes, Dr. Sujay was mentioning that there is that we can give to family contacts. So there are 3 types of contact. One is called family contacts, the family members of the patient. Second is neighborhood contacts, the people who stay neighboring houses, 3 houses either side. And social contacts are child goes to school, for example your colleagues in the college, hospital or workplace, or child goes to school, the contacts in the school. So these are the kind of contacts which Government of India looking at, but as IDVL, whom we can give? Dr. Sujay, continuing on that.
I think one thing is about acceptance also. I feel, Dr. Nasmarao, if we improve the awareness about the value of PEP with SDR, I think all dermatologists will accept it. And
So what, can you say it again? You want to have improve the acceptance of SDR by dermatologists.
Yes, by
so no, 1 minute. So what that are you implying that there is lack of acceptance by single-dose rifampicin as a PEP drug by dermatologists?
Because I don't know if there is adequate awareness among all dermatologists in this country.
Okay, I got your point. So I'll ask chairpersons. So Professor Sudharani, do you think as a professor, do you have any objection for single-dose rifampicin as a drug for contact? It is recommended and approved by WHO and NLEP.
Yes, sir. No, nothing wrong in that.
Not, so next, chairperson, please.
Yeah, can be given.
Should be given. Okay.
Should be given, I think we can impress only the family members, neighborhood and all. We cannot.
Understand. But you agree to give a single.
Yeah, I agree.
Okay.
Yeah.
I think on the same lines, a little more clarification should be there. Who should be given? Like, if it's possibly, do we still give, or we give?
As per government regulation, all patients.
All patients.
Any.
So it will be not
contact case. If it is a confirmed case of leprosy, it can be PB or MB. All the contact should be given.
Yeah, requires a lot of effort because needs a lot of patient education. Acceptance to take also is not easy. So a lot of hard work is need to put in.
A lot of patients, they are worried about their family members actually.
Yeah, can you be a little louder, please?
Yeah, they are worried about their family members. That thing is there always. Yeah. Whether my children will get, my wife, my husband will get or not. That question they ask. So that is the time you need.
But
to
are we offering? So
no,
time
you need to.
My question is that I understand.
Yes.
But may I know for all of you. So Dr. Kiran, you are a leprosy specialist. Do you give PEP for all leprosy contacts of your patients? I am asking in practice. While you approve it, but are you giving it, right?
Of late, yes.
Of late,
and
yes.
And I am also seeing that some of my patients who have to go to government to get their MDT, I have seen that their family members are also being actually supplied with rifampicin capsules to all the members of their family. So it is happening now.
Happening. Dr. Sujay?
I like Dr. Udaikiran, I am also starting to give since the last 1.5 years.
Dr. Ramo, are you practicing?
As a specialist, is our response to do?
No, are you giving it in your practice?
No,
not yet started. Okay. Dr. Nirmala, are you giving it in your practice? Are you giving to the contacts?
Giving it to all the contacts.
Doctor.
Yeah, I've started doing it.
Chairpersons, please. Are we?
Yeah, we are giving. And that's why I found now rifampicin is very difficult to get in the market. Everybody has started.
Okay, good. So it's very good. Dr. Darak?
Why shortage is there?
Yeah, giving.
You are giving
contacts.
PEP contacts.
Yeah,
wonderful.
Contacts.
Dr. Sudhavani, are you practicing in your Gandhi Medical College?
No, sir, not yet.
So do you propose to start it in short while?
Yes, sir, we'll do.
We'll do it. Okay, thank you. So I think
I had a point, sir. Actually, that is a chance to examine the contacts. First,
Yes.
you examine the contacts, see whether they are having acting. Because when you examine the contact, there is a chance that they will be suffering with the Hansen's.
Absolutely. So you brought a very good point. Giving PEP doesn't necessarily mean you have to ask all the contacts to come to your place of clinic or hospital. It gives us two chances. One, to administer PEP. Before administering PEP, examining all the contacts, family contacts of the patient to rule out if they have early signs of leprosy. So that gives double. One is checking, screening for leprosy in contacts. Second, administering the SDR PEP. Okay, I think, I don't know, I think we have about another 5 minutes time. So we'll go. So Government of India, I just like to mention, Dr. Ramon, you wanted to give extended PEP. Government of India mentions extended PEP. It also supports introduction of any newer and more efficacious improved PEP regimens. Only thing is probably you have to test it in the field. Maybe it's a time, IADVL, every conference of IADVL Telangana, IADVL Telangana state is saving crores and lakhs of rupees in every conference. Maybe once in the savings we can allocate a budget, a small budget of 15% or 20% of whatever savings for doing such a study, PEP plus with 3 drugs or 2 drugs whichever fixed and proper. So all these studies need funding, and because they need to be done over a period of 2 to 3 years, I just want to air my view that it should be taken into consideration. Maybe instead of saving all the money, 25% of all the savings of Telangana state should go to research Maybe this or some other topic. Thank you.
Thank you, sir.
I just want to go to, okay. So, okay, it should be possible for dermatologists to recommend administer PEP for all household contacts, because as mentioned by Ram Mohan, Dr. Ram Mohan, every patient comes to us, inquires, sir, I got leprosy, it's fine, but does my children get it? Or what about my wife getting this infection? So we can always encourage them to bring their family members to your clinic and administer a single dose rifampicin, which is a very simple one. Okay, so now come to the last question. I think our time is a little short. There is an increase in smear positive cases, especially in high BI cases in India. Now, Dr. Kiran was mentioning, is it time to extend treatment of MB cases till smear negativity? Because it was around 20% in 1980s, the percent MB population in leprosy in India became 30, then it became 45, today is about more than 50. And also we have got high BI cases, more than 4+ cases in the community. Do you think it's time to treat them to smear negativity? Because right now we are giving FDT and leaving the patient back into the community while they are still skin smear positive. And also I would like to bring to attention of everybody that in 1983, when WHO first came out with the guidelines of MDT, they mentioned that all the multibacillary patients should be treated till smear negativity, and it was in practice till 1993. So it is not that I am telling a new theory or something like that. So I just want a quick opinion of 5 of us, 5 of the panelists.
As the numbers have come down significantly, and as there is no burden of financial aspect, it is worthwhile to treat for a longer duration than what we have been doing before.
Thank you.
My experience with 1 year FDT, too many patients are coming with post RFT type 1, type 2, and therefore I feel we have to treat high BI cases for at least 24 months to prevent the post FDT reactions.
Thank you to that.
Yes, sir. 24 months is mandatory, and we are giving in the institute. We are giving most of the patients. We are giving 24 months because reactions have been there are many reports that 24 months is more ideal.
No, with or without reaction, with a high smear positivity,
24 months.
Thank you, Dr.
So I don't feel that MDT extension is necessary because BI concentrates only on the bacillary index but not on the viability. So there might be non-viable bacilli also. But the only thing I recommend is the smear test should be done often. To confirm. Unless until there are 3 cases, relapses.
Yes,
sir. As sir said, for under 3 conditions like any relapse or any histoid, we can continue. Otherwise, there is no need.
Dr. Vani, please. Yes.
Yeah, I think the smear negativity is a difficult thing to achieve, as we were discussing. So having a 2-year period as well, and even at the end of that, check again. And it's not the BI positivity, but the morphology. If they are broken, that means it is still completely treated. So I have to look at those. At least 16 months, 24 if possible. If you have not 1 year, 24 months.
24 months. Thank you. So out of the 4 panelists, I think
5 panelists. One point I want to add, sir. One point, sir.
Yeah.
When they 24 to 1 year, they reduce the duration. At that time, vertical program is going on.
Yeah.
So they used to surveillance were going on. So they used to pick up the cases, any relapse guys or any non-improving cases. But now that is not there. So it is better you give 24 months.
24 months. Thank you. So just for the information of all the audience here. So this is a wonderful paper by Dr. Narang et al. So it mentioned at the bottom, I think you can look at that report mentioned that study conducted by Gupta et al. To observe that viable bacilli persist up to 30% of patients even after 1 year of receiving MDT alone. So it is known. So I just like to say that majority of the panelists, 4 out of 5, suggest that we should treat MB patients longer than 12 months up to 24 months minimum. Thank you. Just before I think my questions are over, just any comments from chairpersons and we'll close this.
Yeah, in my practice, what we studied, we have practiced till now. For any MD cases, I have not stopped for 1 year. I continued up to 2 years. Then only, after negativity only, I stopped.
Thank you. Dr. Darak, please.
Yeah, it should be given minimum for 2 years' time.
Thank you. Dr. With your comments, I think we'll close the session.
Sir, it is there already in 18 months. We are giving 12 fixed doses. That's instead of that 12 doses, we can continue that 18 months perfectly, if possible 24 months.
And adherence is more important.
And HIV, we are giving post-exposure prophylaxis immediately. Students are rushing there. So all medical colleges, we can request to put one screening center. Anyway, we have leprosy center. We are focusing on the treatment aspect only. Again, we'll go back to screening aspect. So now every institute has so many PGs. We can do that part effectively if you concentrate on that.
Thank you. Thank
So
you.
just 2 points before we end. IITL, where it can do, it has already done, like my availability of drugs. For example, when there was shortage of clofazimine and all that, and getting drugs like thalidomide at a cheaper rate and consistently, that, and if possible, if the IIT can take initiative to push the vaccine, because according to the papers presented, it has a major role in reducing the damage.
You mean IIT should fund the
No.
fund the drugs?
No, to
allocate money to get the drugs?
No, availability, it has taken care. No, there were shortages in the middle. So that was taken care, and we should be taking care as before. And vaccine should be made available at a cheaper rate. So I don't know how IODL can take it up and go ahead with it.
But I think we are short of time.
I want to say, insist that when the government spends a lot of money for HIV and HIV drugs, crores of money, and why can't they allot? And we press
them. Why can't IIT will allot?
No, not IIT.
No, why can't IIT will allot? No, why I am saying no? Why can't IIT will allot? From all the money you are saving, why can't you allot 25% to
that can be done for research, sir,
funds,
but not
drugs for the poor? We can always do it. Only the Green Initiative. Thank you very much. With this, I close our session. Thanks, panelists, for
Thank you.
participation and chairperson.
Thank you, sir.
Thank you.
Thank you for the good session, moderating Dr. Narasimha. Thanks all the panelists for a valuable inputs and good discussion. Thank you very much for this organizing team.
Thank you.
Thank you. I will be after her to allocate funds.
I'll invite Dr. P. Madhavi Reddy to talk on the exemplary exosome weighing the evidence. Ramesh.
Good morning, everyone. At the outset, I would like to thank Telangana State IADVL and the organizing committee for giving me this opportunity to be here. So today, I am going to talk about exosomes, which are creating a lot of noise in the market these days. As far as exosomes are concerned, there's not much technique or skill related. It's mainly you need to know the product. So I'll be telling mainly about the product. Exosomes are a group of extracellular nanovesicles produced by almost all cells, including bacteria. The peculiarity of exosome is mainly because of the size. They are smaller in size, so they can be penetrated through stratum corneum, even through the micropores that you create. They basically deliver the bioactive molecules and the signals to the surrounding cells and help in repairing, regenerating, and influences the adjacent cell behavior. So this is briefly about formation of the exosome. Plasma membrane invaginates to form an early endosome. So as the endosome matures, it forms a multivesicular body and forms exosomes within, which are released outside the cell. The exosomes go and attach to the surrounding receptors and carry out its specific action. And some exosomes get engulfed by the adjacent cell. So the ingredients of the exosomes are entering into the adjacent cell and carry out the action. This is something which we need to remember. So exosomes are covered by the lipid bilayer And there are three main receptors which are CD3, 9, 63 and 81 which act as a markers. This is important because at the manufacturer level, these markers has to be tested and then the number of exosomes should be mentioned. Because what we see is number game that is going on 1 billion, 5 billion, 50 billion, but actually what is being told is the number of particles, not the number of exosomes. So when they tell 1 billion exosomes, the 1 billion particles should have this marking. Exosomes contain proteins, cytokines and nucleic acids and most important microRNA. These are the non-coding RNA and the composition of exosomes vary and the composition depends on the parent cell. So it is not, exosome is not a magic fairy. One fairy will go and do all the job in hair and skin. So the composition depends on the parent cell and the circumstances under which the parent cell secretes the exosomes. It helps in intercellular communication, transfer of genetic material, which we should remember. MicroRNA, which regulates the gene expression of the surrounding cell. And finally, this modulates the cell proliferation, cell death and immune regulation, wound healing and everything. There are main two sources of exosomes, autologous from the patient's own adipose tissue, bone marrow, platelets and the fibroblasts, or from the heterologous sources from the mesenchymal stem cells from unrelated donors. So the presently commercially available exosomes are basically derived from the mesenchymal stem cells of bone marrow, umbilical cord, amniotic fluid, adipose tissue and certain plants like rose, ginseng and lactobacillus. The main advantage of this is basically mass production is possible and homogeneity can be established, storage is possible, quality control can be done in mass production of exosomes. So briefly we should know how exosomes are produced at a good laboratory or good R&D lab which has good manufacturing standards. One, they will take the source. The source is cultivated in the culture media under specific circumstances. It is like basically under certain circumstances good exosomes are produced sort of. So and these exosomes are separated, purified and they are concentrated with the help of ultracentrifugation and later on they are marked to calculate the number of exosomes and the composition is checked. Infectivity and toxicity testing has to be done. So toxicity testing and infectivity testing should be done at the source and at the end also. And finally the product should come to the market. So we should understand to do this, the source from which it is being done and the place from which it is being done should have good R&D. So two main methods are basically ultracentrifugation and filtration through which it is done. Finally, as of now, exosomes obtained from mesenchymal stem cell conditioned media is considered to be more effective than the plant and the bacterial cell. Why exosomes? We have already been doing PRP for of late for more than 10 years. Then why do we need exosomes as compared to PRP and stem cells? Mainly it is stable, it has minimal immunogenicity, less tumorigenic and smaller size, so better penetration to stratum corneum and mass production is possible with for uniformity. Like if 100 people are there here, if 100 of us separate PRP, each one will have different concentration. That problem won't be there with exosomes. Exosomes in dermatology is being used in hair regeneration, wound healing, anti-aging, treatment of scars, skin rejuvenation, photoaging, anti-inflammatory and post-procedure to decrease the recovery time. In hair, exosomes mainly helps by activating the Wnt beta-catenin pathway, finally helps in proliferation of the dermal papilla cells, inhibition of the DHT and increases angiogenesis through VEGF. So there are very few studies as far as exosome in human clinical trials are concerned actually. So this study has shown adipose derived stem cell exosome has increased the hair density and thickness. This study has clearly evaluated the review of 47 studies which are there. In fact, many are preclinical, only few are clinical. And it has clearly mentioned that there are still several gaps in the knowledge and including safety, exosome source and optimal treatment delivery mechanism and dosage. So still several gaps are there to put exosome into use into widespread clinical practice. So we need to wait for more evidence to pour in. And regulation is very important. There are a lot of ethical reasons, ethical concerns with umbilical and amniotic fluid exosomes. As of now, even though we don't exactly follow FDA, but we should understand no exosome product is FDA approved. The current global approval is only for topical application or delivery through fractionated devices, like you can do microneedle radiofrequency or microneedling or fractional CO2 and then apply exosomes. It is not for injection. It is very clear, no product of exosome as of now is approved for injection. And this is the recent article in JAK which has showed foreign body granuloma caused by an injection of exosome on the face. So we can imagine somebody coming for anti-aging and develop multiple granules. This I have already spoken. The number game is not the particles. It's basically the exact numbers in the vial is actually around 10 to 20%, and rest all is vitamins, hyaluronic acid and tranexamic acid. We have to still wait for human studies to exactly know what amount of exosomes we need for good efficacy. And few studies as far as acne scar treatment is concerned with exosome with fractional CO2, and there was better reduction in the scar and shorter post-treatment downtime in this study. And this was basically rose stem cell derived exosome, improvement in the skin pigmentation, erythema and wrinkle reduction. This was topical platelet exosomes, and it has showed there is reduced senescence signaling and reduced telomere damage after topical 12 weeks of twice daily use of exosomes. So thus how is more practiced in anti-aging. How to choose the product? This is very important. See, the problem in the present day is actually lot of products are being pouring in, and we can expect much more products to pour into our clinical practice in the next 5 years. Next 5 years, exosome market is going to increase by around 25%. So we can imagine, and we should have the basic knowledge about the product. One, look at the source. Look at the manufacturing standards of the company that is maintaining. Look whether toxicity and infectivity testing was done for the source, and whether markers have been used, whether they have been counted. And check for the composition within the exosome, and check for the trials that the company has done as far as the efficacy and safety is concerned, and the registration. Even though if it is not FDA, at least the product has some registration in some country like Korean FDA approved or even European Union approved, something like that. Limitations, lot of limitations. Exactly we don't know what dose, like I feel once in a month dose should be fine, and once in a month frequency should be fine. Exact composition, very difficult. Even if you ask from the company person, they take time to give you the exact composition. Long-term safety, we have to wait. And the cost, is it really beneficial as compared to other? I would say we would have to still wait to come to that conclusion. It is a good one. I would like to conclude in saying that in science, the important thing is to modify our ideas and change as science advances. But in this process, we should not forget that do no harm to your patient. I have a small brief video. I'll just show you that. So in exosomes, as far as I have told you, in exosomes, as I have told you, there is not much skill related. You can do it with microneedling or microneedling radiofrequency or fractionated devices. I use two types of exosomes. One is amniotic fluid derived, and the second one is salmon fish derived. So it comes as a lyophilized freeze-dried powder like your botulinum toxin, and the other one as 5 ml of hyaluronic acid or any other additive. So you just add it. Yeah, we'll just play the video. And you can apply, normally what I do is basically I apply the exosome and then do the procedure, whether microneedling or derma pen. Okay, there is some little delay, so I'll just tell you. We can apply the exosome solution, and then we can either do a derma roller or a derma pen or microneedling device, and then apply the exosome once again. Or one more method is basically you can do the microneedling device and topically apply exosomes. Post-procedure care will be like any other procedure, like how we do for microneedling and all, but avoid washing of the face or washing of the scalp for that day. Yeah, I'll just play it fast actually. It has a lyophilized powder and a solution. Both have to be mixed, and then on the face, like after cleansing and all, we have to apply the exosome solution and then do microneedling in radio frequency. But here I keep at a depth of around 0.8 to 1 for about face, and I do 3 passes. First exosome solution and then 1 pass, and then exosome solution and then the second pass, as far as the face is concerned. You can do it with, yeah, paucity of time, I'll do it fast basically. Yeah, and for the scalp basically same way, you apply the solution, and I'm actually not great fan of derma roller. Probably after a long time I'm using the derma rollers and the derma stamps. As he has very less hair, I use the roller. So apply the solution, either roller the roller or the derma stamp, derma pen or something. Yeah, for the scalp we don't use microneedle radiofrequency. Thank you so much for your time.
Thank you very much for the enlightenment of exosomes. The future is for exosomes. Yeah, I thank the organizers for giving us chairperson's activity.
Thank you, chairpersons, for this session, and I request the chairpersons to move to the memento board, and I request Dr. Dibyan Murthy sir and Dr. Satyanath sir to hand over the memento. I request Dr. Dibyan Murthy sir and Satyanath sir to hand over the mementos to the chairpersons of Hall A and Hall B. I would like to proceed with session 2. I request the chairperson, Dr. Anji Babu sir, to come onto the stage. Dr. C.V. Maruti ma'am to come onto the stage. I request Dr. Shobha Reddy ma'am also to come onto the stage.
I invite Dr. P. Swapnapriya. She will talk on a talk on Trendy Threads.
Good morning, everyone. I thank Telangana IIDVL for giving me this opportunity to talk on this topic. So the trends in the threads, will go through all the advanced materials and also techniques, what is happening in threads right now. Now the threads has become a very popular treatment, one being it is giving more natural results and there is minimal downtime, and also we have good materials which are giving the results which stay for long. So in terms of advanced materials, we have now moved from PDO to PLLA and PCL, which is nothing but polylactic acid and polycaprolactone. Like how you see in the table, here we can clearly see this polycaprolactone, they stay almost for 2 years and the results are staying for more than that. And they're giving more comfort to the patient, and also they are more biodegradable, close to the body mechanism. That is when they degrade, they break down to carbon dioxide and water, which is close to the body molecules. The types of threads, like we already know, now the trend is more towards absorbable threads because of more long-staying nature when compared to the non-absorbable threads, which have almost becoming obsolete. These are different types of monothreads with different functions. This slide, I want to make a note because in choosing the threads, we can easily just choose by considering these factors. Monothreads, particularly when you are considering for the texture of the skin. Screw threads when you are considering for volume augmentation. Cork threads when you are considering lift of the patient skin. Based on the thread's length, we can even classify them into short and long, whether they are less or more than 90 mm. From the bidirectional threads, the more advanced thing is using multidirectional cork threads, because here we are, unlike the single bidirectional cork threads, the force is distributed at multiple points. So there is no mainly tensile strength acting only at one point, so equally distributing over the entire length of the thread, giving good lift to the skin. And there are different varieties of cannulas also now coming up, which helps us to facilitate easy passage through even stronger tissues and challenging areas like firm ligaments, and causing least discomfort to the patient and less damage to the blood vessels and also the nerves. This is another new advanced material in the threads, where you can see you have a cork thread and it is enmeshed in a net-like appearance also. So the cork gives us an immediate lift. Even the corks are dissolved because of the mesh nature which is on the surface of the thread. It causes encompassing of the material, the collagen, to grow inside, and persistent of the lift, which is maintained for the longer period. This is very new innovative technique now. And even, just a moment. And coming to the generation of the corks, which was just like a cutting threads, now it has moved to molding threads, where the threads are molded onto the thread, so the tensile strength of the thread doesn't come down. The density of the threads and also the direction is determined in this picture. The new technique is J technique, which means than just a straight line, the angulation of the thread gives us more anchoring and also a better lift, which is possible with double needle threads. These are the cone threads. The advantages and disadvantages when compared to barbs and cones we will discuss in the coming slides. These are the double needle threads, which have the thread with having corks in between. So what is the advantages and disadvantages? Cones, they have a 360 degree of tissue availability and also surface area, which helps in better collagen modeling. But the major disadvantage, per thread we only have 8 to 10 cones. So when we compare the total surface area comparing with the barbs, it still comes down to be less. That is the reason cones are not becoming still very popular. Another new thing is volumizing threads. We all have seen threads only for lifting, but still we have even for volumizing. There are different types, which you can see in this picture, which are mesh, spring, broom type and braid type. These are multiple monofilament type of threads, and we also have firm volumizing threads. This is the picture on the right side, which is a firm volumizing thread. So what are the advantages and disadvantages? The firm volumizing threads, they help for facial contouring, because they can resist the tissue compression and stand up and give a contour to the skin along with the fillers. But the thing is, if they are very close to the skin, they cause lot of protrusion, and also on palpation you can feel sensitivity. But firm volumizing threads give a good filling for the wrinkles, and also but the disadvantage is they're easily compressed by the tissue pressure. And these are the indications where in which parts of the skin we can use these threads for multiple areas. To start with, the brow lift. The techniques of the thread lift for any body area doesn't remain constant. It changes with the types of the threads, the indication, the direction of the lift you want to use for the tissue keeps on varying with time and the types of the threads. So we are mentioning here the most common methods and most common types of threads being used. This technique is by using cork threads, and this is the central brow lift and the lateral brow lift. So which area are we concentrating decides the entry point and the exit points, and also the results. This is the method of lift which is used by bi-needle threads, that is the L shape, which is particularly for the lateral brow lift, whereas U shape is for central brow lift. A indicates the entry points, few are the anchoring points, and some are the exit points which are mentioned in the picture. This is another area, periorbital area, where we see lot of times wrinkling, which might be difficult to go through with the lasers or some other indications. Along with the Botox, we can combine multiple monofilament threads in this area, like mentioned in the picture, which gives a good rejuvenation. The most next advanced is using multiple monofilament, not just like we have talked volumizing threads in the beginning. This here you have 14 monofilaments in the thread, where you can use in the periorbital area, and in the area of the lateral part of the brow, you can use a single cork thread, which is speculated cannula, which you can use it in the 3D, and the exit point should be in the hairline, so you will have a very good lift in the lateral brow area. This is the protocol where we first anesthetize the area, make an insertion with the needle, and then put the needles through, remove the cannulas out so that we can get the lift. Now coming to the talk on the lips by using threads. Lips margins can be very clearly elevated or give a good structure where they have a saggy corners. We can give a good structure, and along with the fillers, we can give a good volumization. So here you can see in the border where you are using PDO double curl threads of 30 gauge in the lip margins, 2 on each side. The bluer arrows or classical screw threads to correct the perioral wrinkles, and the fine threads to correct the rest of the area. This is another article which mentions using of the threads which are inserted from the lateral angle of the mouth into the lip corners along with the filler, giving a good volumization and also the appearance. Now next in the basket is nose lift. This is becoming very popular for the reason being it's a non-surgical rhinoplasty like correction which helps particularly for the dorsal augmentation and also the columella lift. This is where, and in this we use particularly cork threads. The monofilaments don't help much in this case. You can see we first give an anesthesia on the tip of the nose and make an entry point. Using the cork, we lift the nose, we lift the columella tip and also augment the dorsum of the nose. Coming to the rim, the aloe of the nose also can be corrected by using threads, but that needs more expertise and also training before we attempt onto that areas. Coming to the neck lift, in the neck lift also there are multiple techniques, but here I am speaking about one type of lift where we are using cork threads, which is starting from lateral to the medial in the superficial layer, and you can see the before and after pics of the patients where their good satisfactory result is seen. The body rejuvenation by using hybrid lift of the skin by using fillers and also threads. But here the limitation is filler is still not yet available in India because it is being a semi-permanent filler, polylactic acid collagen stimulator. Here this filler is given into the skin followed by using threads on the same day of the session or later after 1 month so that you have good volumization and also rejuvenation on the skin surface. You can see they have used very beautifully on the body surface areas like tummy and also thighs. The use of threads is not just now limited to the aesthetics of the patient, but also used in paralytic conditions like facial paralysis or post-onco reconstruction where they have an asymmetry which can be corrected by using threads, particularly bidirectional screw barbs by 50 centimeters spiral threads, which gives a good correction, and we can see that how happy the patient can be afterwards. Now the use of threads in genital areas where multiple monofilament threads can be inserted on both the sides of labia majora, almost 5 on each side, which can be either from downward to upward or upward to downward direction, and giving a good rejuvenation effect, which is seen in the picture. Now the threads have even started being involved in the department of gynecology, like where you can use it particularly in pattern baldness. This gives a good result where patients are having stubborn results, and there are multiple reports also being available now where it is being shown it has result in cases of even pattern hair loss. This particularly works on the concept of causing temporary microtrauma, collagen stimulation, and also stimulation of the bulge area. This is how the multiple mono threads are inserted into the pattern baldness areas. The role of threads in melasma is still doubtful, particularly the reason being it causes collagen stimulation and also having shown that the fibroblasts do have a role along with the keratinocytes and melanocytes in case of melasma. And these are different techniques, MR technique, JR technique for use for different areas in different methods by using double needles. Now we also have hybrid threads, which means in combination with hyaluronic acid and also glutathione, where they have an extra advantage of lightening effect, hydration, and also volume. And AI is also being used along with the threads to understand the patient assessment and also to suggest us the best lane of insertion and also to simulate results how it can be seen in the future. That's how probably AI will play a role, and threads is more now to be into the market because of more indications of using threads in the aesthetic practice. Thank you so much.
Thank you, Swapna Priya. It was a very nice presentation. And no, I want all the juniors to start with normal PDO threads itself. Do it more and more. Once you gain good experience, then move on to the other advanced threads, complicated things. Thank you very much.
Yeah, thank you.
Next, I would like to call upon Optimizing Outcomes in Laser Hair Removal lecture, Dr. T.N. Rekha Singh. Still, we struggle with laser hair removal. So we do have 20% of our patients coming back to us telling us we are not getting good results. So let us see how Rekha Singh is going to enlighten us in regarding this and give us good insightful things.
Yeah, meanwhile, good morning everyone. I thank Telangana IDVL committee for giving me this opportunity. All of us, majority of us who are here in this auditorium, we do laser hair removal. And though we have different technologies, the years of experience, still we have some challenges. So in this 10 minutes of time, I'll try to be as brief as possible, and I'll try to give you the key points which are important. Yeah, thank you so much. Sorry for the technical glitch. So I was baffled when I saw this data. Now laser hair removal is one of the most common procedures that is done worldwide, and it is one of the 5 most popular non-surgical procedures. And when we look at the market that he has, it's like huge, and no wonder that is the reason why we keep on getting new technologies and the companies are trying to find something very new. So the impact, we all say that it is cosmetic, but it is not cosmetic because there are so many quality of life studies which tell us about the importance of laser hair reduction. And as dermatologists, as clinicians, it is very important for us, the onus lies on our shoulders to give the best result possible with the best understanding that we have. So we all know that laser hair removal works on the principle of selective photothermolysis. The thermal relaxation time is very, very important. But rather than thermal relaxation time, the new term which is getting its popularity is thermal damage time, which is mainly important because that is the right kind of temperature which is needed to destroy the stem cells. So most of the laser hair removal machines that we have work on the principle of selective thermolysis. Majorly, the melanin is the chromophore which absorbs the energy, and it tries to pass on the temperature to the bulge area, to the dermal papilla, everything. And what we are going to understand here today in this 10 minutes is majorly the factors which are important for us to consider to get the best result. So I would classify this into patient factors, technological factors, operator related factors, and etiology if it is a case of hirsutism, and also the pharmacological treatment. So what should we do as dermatologists? First thing is we have to establish the etiology, whether it is hirsutism or hypertrichosis, or whether it is a medical condition like pseudofolliculitis barbae or hidradenitis suppurativa. Then we also have to follow the evidence-based practice, and we have to drive in the hormonal therapy, which I think somewhere we are all lacking in. So coming to the patient factors, there are many. Skin type, which is more important. So light skin types are favorable with a background of light skin with dark terminal hair. These are the skin types which respond faster and better to most of the technologies. But the catch is the darker skin types between 4 to 6, which is challenging for all of us. So we'll have to be very careful when we choose our wavelength or frequency or fluence or the pulse width. Then hair type and color. The more the thicker the color, the more the chromophore, and you get better results. The thinner the hair becomes, that is more challenging. And then degree of tan is important because somebody comes for laser hair removal on forearms, they have tan, then you'll have to change your fluence accordingly. Hair growth cycle, anagen phase is very, very important because when the hair is in the anagen phase, that is where the melanosomes are slightly different in anagen phase. So that is a stage where you have stem cells as well. Then hormonal influences, very, very important, at least in those areas which are mentioned in the Perelman-Galway score. So and most important thing is optimal endpoint, wherein most of our therapists go into the procedure and we do not go in and check the optimal endpoint. I think all of us should check the optimal endpoint because with each laser it is different. If you do the conventional laser hair removal, then you'll have to look at the perifollicular erythema, perifollicular edema, all those things. And sometimes the hair singes, the smell of the hair gets pushed out as soon as you give the shot. That is the optimal endpoint. If somebody has it, that means you have hit the bullseye, we have given the right kind of energy. But at the same time, all of us have to be aware of the red flags. So what are these red flags? The confluent, intense erythema or edema, severe pain or discomfort while the laser is performed, any vesiculation or skin blistering immediately after the procedure or after the patient goes back home, and then change in the skin color, pallor of the skin color, we all have to be aware. Why am I including this? Because most of the times we leave it to the skin therapist, we do not go and see the patient. It is important before the patient leaves your clinic, we have to look at these signs. Then paradoxical hypertrichosis, this is again a little problematic, challenging thing for all of us. So this can be seen with any wavelength. It is not that only a particular wavelength causes this. Any wavelength can cause this, and low fluences especially can cause this. So uniform volumetric heating, that means when the therapist is performing the laser or a dermatologist is performing the laser, we should make sure that there is complete volumetric heating with the right kind of temperature driven to the melanin. And the accumulative and sustainable heat causes irreversible damage if you are giving the right kind of temperature. But we don't have to worry, even if there is paradoxical hypertrichosis, we can treat it. You only have to give further sessions with slightly higher fluences and short pulse duration. You'll have to be a little careful about this. So if you go with technological factors, there are many things, system specifications. There are many laser systems in the market. All of us get baffled about which to buy, what to buy, which is better, what not. Then the wavelength is important, fluence, pulse width, spot size, and pulse repetition rate. So I'll be talking little about all these things. So the right wavelength with high peak power is very important. The ability to choose the pulse duration in your machine is very important. The fluence, of course, many machines give us that liberty to choose the fluence. Bigger spot size is better. I'll tell you why in the coming slides. And then you should have both dynamic mode and static mode so that you can play around larger body areas. You can use bigger spot sizes in motion. Smaller areas where you cannot maneuver, you can use conventional modes. So you should have both the modes in whichever machine you buy. So each system is different. It may have advantages and disadvantages. We have to choose the machine according to our practice. So wavelength, of course, there is an array of wavelength. So 650 to 700 nanometers stands good for lighter skin types, Fitzpatrick 1 to 3, whereas 4 to 6 longer wavelengths are more important, especially Nd:YAG, which we used to use earlier, is slowly gaining popularity again. In fact, there is a machine which is coming up with a combination of Nd:YAG laser and alexandrite, which can just fit the bill. We'll have to keep watching for new machines that are coming up. Then these are the different wavelengths that we use. The most popular ones, at least for Indian skin types, are the diode, Nd:YAG, and the alexandrite. Alexandrite has come up with specific modulations which can be used in both 4, 5, 6 as well if you are very, very careful. And then you have combination era where you have triple wavelength, you have quadruple wavelength, you have double wavelength, you have so many combinations coming up. So we'll have to choose according to the practice that we have. So latest advancements, not only this, there are so many other modifications that are coming up in the machines like vacuum assisted handpiece. So when you have vacuum, the vacuum pulls up the skin and your laser exactly goes and gets deposited. There is no fear of the energy not reaching the bulge or the bulb. And then you have some machines with scanners which can scan and exactly make sure that the laser goes and hits the melanin or the bulb and the bulge area. Then maximum peak power is also modified in many machines to suit the laser hair removal. And there is something called pneumatic skin flattening. Again, with cold air, the machine tries to push the skin up so that the energy gets deposited at the right place. So these are the new advancements that we can look at. So now again, there is a lot of confusion between, single wavelength, double wavelength, which one to buy. So this table was beautifully given in Dr. Ganesh Pai's paper. So it talks about what are the advantages of single wavelength and triple wavelength. Each one has its own advantages. So again, we'll have to see our own need and then we have to buy. So fluence, higher fluences no doubt work well, but they are better, they are safer for lighter skin types. Low fluences are better for darker skin types, but again there is a chance of suboptimal response. So each time the patient comes to you, you have to slowly increase the fluence, stand there and just look how the skin is reacting, whether there is any pallor or excessive redness, all that can be. So it has to be individualized. The parameters have to be individualized. So from an efficacy perspective, no doubt high fluence is better. Then pulse width and pulse duration. I think this is this is very, very important. So short pulse width, when it targets the is used when the target chromophore is lesser, so it works for finer or the light colored hairs. Longer pulse width, when the target chromophore is more, it helps in coarser hair and areas with the dense hair. Longer pulse width can also penetrate deeper. That is why India 1064 is very, very beneficial. Pulse width between 15 to 30 milliseconds is considered to be optimal for the terminal hair. Spot size. Now, why are we getting machines with different spot sizes? What they say is with larger spot sizes, the scattering is very, very less. The photons are not scattered. They are just concentrated in that particular area. Whereas there is high chance of scattering of the light with smaller spot sizes. So for body parts to get better results, it is better we have larger spot sizes. But again, the catch is you cannot use it in smaller areas like mid-brow or knuckle areas or any other smaller areas where you want to target, or the lone hairs, the isolated hairs cannot be treated. So higher the pulse repetition rate, it has an advantage of covering larger treatment areas as well. The speed is a very important. The patient wants to get everything done in a jiffy. So larger spot sizes we can complete the procedure within lesser time. So the choice of laser parameters based on hair type, you can choose the higher fluence for lighter skin, shorter wavelength for darker skin, and this is a slide showing that. I would just look at for one more minute, I would be done. Factors influencing outcome of laser hair removal, it also depends on the various parameters. Then operator dependent factors, the skill of the therapist is very important. Please train your therapist well, because our fate lies in the hands of the therapist. We'll have to be extremely careful. Cooling is very, very important. And medical treatment, no need to tell, we have to establish the etiology, look out for underlying hormonal conditions like PCOS and treat it accordingly. The drugs are already there. Combined oral contraceptives are the first drug of choice. Addition of spironolactone, finasteride, etc. will definitely boost up the response. Then establishing the etiology, diagnostic workup, choosing the right parameters, and I'll just run through because of the paucity of the time. So most importantly, the pre-procedure do's and don'ts, not allowing them to wax or use any other methods of laser hair removal, avoiding all the active creams, make sure that there is no loose hair, patch test can be performed, post-procedure cold compress, avoiding excessive sun exposure. Number of sessions again varies, it depends on how early the patient presents to you. The earlier the patient presents to you, the higher is the chances of hormonal change, so they may need more number of sessions. Whereas the postmenopausal women may need lesser number of sessions. Challenges with light and grey hair, paradoxical hypertrichosis, darker skin types, true non-responders, these are already there. And to summarize, the success of laser hair removal depends on how you align your patient, your machine, your parameters have to be tailor-made to your patient, choose the right kind of pulse width and wavelength. Thank you. Thank you for giving me that extra time. Thank you so much for your patient hearing.
Thanks, Dr. Rekha, for nice take-home points in optimizing the hair removal. Now I introduce Dr. Sudhavani ma'am. Madam doesn't need any introduction, and she's a very successful dermatologist, very academically oriented, and most important, she's a good mentor for all of us and very positive and encouraging personality. And Madam is going to explain about the dual modalities, giving the desirable results followed by a live demo on a dialogue on Derma-Frac.
Thank you, Dr. Shobha. Good morning all. Today I would like to talk about Derma-Frac. So Derma-Frac is a new technique. So nowadays it is becoming very popular. Even most of the celebrities are undergoing this treatment. Recently, PV Sindhu, before her wedding, she took this treatment, and that reel is viral now. PPT please. So Derma-Frac is a patented technology, and it is made in US. So it's a patented micro-channeling system. It is made in US. It has a roller equipped with 180 ultra-fine needles, and it has the main advantage is it is a pain-free and no downtime. That is the main advantages. So here it penetrates the deeper tissues, especially at the dermoepidermal junction, and that leads to maximum infusion of the
serum into the important layers. So coming to the indications, it can be done with aging skin with fine wrinkles and periorbital melanosis, hypopigmentation, sun damaged skin, dry skin and dull skin, acne vulgaris. Even when active acne is there, we can do this. Oily or acne prone skin, enlarged pores, blackheads, whiteheads. But the most three common indications which I do is, one is periorbital melanosis, and the second one is hypopigmentation, and third one is dry skin. So it has two effective procedures in one device. One is microdermabrasion and the second one is infusion part. So exfoliation is normal, we all know that. So here microdermabrasion, we know that it removes the superficial layers of the skin. I am not talking about that. So this is microdermabrasion before procedure, you can see, and this is after 2 passes. The stratum corneum is exfoliation of stratum corneum is seen. And here the Derma-Frac has a dry microdermabrasion. That means it's a crystal free. There is no powder, and it has a disposable diamond tip. There are 2 shapes, round and one is oval, and it is excellent for the oily skin also. So this abrasive, how it works means, this abrasive surface cleans the exfoliates and epidermis. So that is why dermabrasion works. And coming to the Derma-Frac procedure, this is main here is micro protrusion, exfoliation and infusion. 2 things are there in this. So these micro protrusion roller tips, which exfoliate the skin with a simultaneous infusion of the serum. And it has 2 tips. The size has, the tips has 2 sizes, that is 0.25 millimeters and 0.5 millimeters tips. And how it works? So it is a precision controlled roller rolls across the skin. Once we roll across the skin, the vacuum pulls the skin and allows these micro needles gently to penetrate the skin, and the skin under tension develop, and it allows needles to deliver the serum. So that is the main important technique. So this gentle mechanical injury, it initiates healing response in the skin, so thereby it stimulates new collagen formation also. So this is how it looks once the needles enters, and this is the microchannel created in the skin. So this is before the delivery of the serum, and you can see this is after the delivery, of the serum, which shows the improvement simultaneously infusion of these serums. So Derma-Frac is the only modality which can deliver 8 to 10 ml of serum at the dermoepidermal junction. So there is no spillage of the serum or no wastage, but the main advantage here is there is no pain, no anesthesia and no downtime. So why it is effective means there is a maximum infusion can be seen here. So precision vacuum controlled microneedle handpiece is there, so which penetrates evenly, and the important thing is it is painless. So vacuum pulls the skin, leaving nerves behind, and it results no pain, and it removes the interstitial fluid and it deposits serum there. So where the areas where it can be done is face, upper eyelid, neck, back, underarms, hands, legs, genital area also can be treated with this. They have 5 formulations of serums. One is rejuvenate, lighten or brighten serum, clarify, hydrate and vitamin C serum. These are the 5 types of serums are available. So coming to the rejuvenate serum, it is mainly used for sun damage and general aging, for the wrinkles and fine lines. So what we expect is visible reduction in the fine lines. It is mainly antioxidant serum, and it contains 5 active peptides in it. So this is the result. You can see there is a improvement in the fine lines in a 60-year-old female after 6 treatments. And coming to the brighten serum, this is for the pigmentation or skin discoloration, and it has mainly kojic acid. So kojic acid, we all know this is very safe, no toxicity issues, and it has a very good role in suppressing melanocyte activity. And this is the after 4 Derma-Frac treatments, and with 1 lighten, you can see a drastic improvement in the underlying under eye pigmentation. And this is my patient. Only after 1 Derma-Frac treatment, you can see you can see more lightening of the pigment. And this is for the melasma. After 4 sittings, melasma also improved, but it is a little not completely gone. And underarm also we can treat with Derma-Frac, and this is melasma, and again this is lighten, another treatment, and this is Derma-Frac after 2 Derma-Frac lighten treatments. And coming to the hydrate serum, hydrate is used for the dry and dehydrated skins. So it has hyaluronic acid, aloe vera, vitamin E and green tea extract. So it has a hyala sponge system. So it acts like a second skin. You can see the sponges. So this is how it looks. And it also contains retinyl palmitate, which converts into retinoic acid once it is infused into the skin. So this is Derma-Frac hydrate treatment. So where this hydrate treatment we can use when anyone are afraid of any need undergoing skin boosters, then you can use this Derma-Frac Hydra system. So vitamin C also can be infused with this. And coming to the Clarify, this is for the acne scarring and problematic skin types. It has salicylic acid and lactic acid combination. So it reduces acne, even active acne also we can treat with this. These are the key ingredients. And this is after 1 treatment, this lady responded very well with the acne. So the main advantage here is there is no peel. After applying chemical peel, peeling will be there. But here there is no peeling, no downtime. So this is how she looks. So this is one more acne treatment. You can see the improvement. So these are the few scientific evidence. There is one article published in Journal of Cutaneous and Aesthetic Surgery. So it shows that Derma-Frac may be an innovative and effective new treatment option for the patients with periorbital hypermelanosis. So they studied ultrascan analysis summary and also. So you can see the restoration of skin barrier here after the treatment. So there is no absolute contraindications, but when there is any active acne or severe active acne or inflamed skin and HIV, hepatitis, any fungal infections, pregnancy, these are the few contraindications. So to conclude, it is an innovative, new, safe technology, and there is no downtime. And with that precision serum infusion, we can treat pigmentation, hydration and the wrinkles also. And further larger studies are needed to confirm these initial encouraging results. Thank you, and there is no conflict of interest. Thank you. So now I'll show you a quick demo of this Derma-Frac. So this is the system. This is Dermagenesis. It has 4 options: derma peel and microdermabrasion, followed by infusion and micro needling with the infusion and infusion only. So 4 options are available with this machine. And this is Derma-Frac. Here only micro needling with infusion is available with this system. So I'll show this. So this is the hand piece. So it has fine needles which can be rolled. It's on. Okay. So the serum, the cartridge, can you show? So this is the cartridge. This is lighten, I think. This is the cartridge. We need to remove this cap and we need to insert this into this handpiece and separate disposable needles. Micro needles are available. We need to fit into this, and once after cleansing the face, so you can hold this here. There is a small opening. We need to hold this into the skin. Close your eyes and then we can start. So just if you put, so there is the serum is delivered. There are two methods. One is like stamping method is there. This is called stamping method, and the other one is continuous. You need to stretch the skin and then you just you can feel the skin. This is a vacuum, and then it pulls and serum is visible. You can do it on even upper eyelid for the periorbital pigmentation, but here we need to decrease the vacuum pressure to 1. For the face it is 5, but here we need to decrease the vacuum pressure to 1, and you can do it here as a stamping method. You can do. You can see the serum also. No pain, no anesthesia, and he is very comfortable. And even any upper lip pigmentation is there, that also can be treated with this. Any pain? No. So this way, this entire 10 ml serum we can infuse into the skin. So there are multiple indications like melasma we can treat, pigmentation, under eye pigmentation, lip pigmentation, etc. And for the acne also, active acne is also there. We can use that clarify serum. There is no downtime, and so patients are accepting this. Now they are very much wanting this treatment because there is no downtime and no side effects. That is the main advantage of this Derma-Frac. If you want any further details, you can contact the stall. Thank you. Thank you very
Dr.
much.
Sudha, is it for the drug delivery system basically we are using it?
Yes. So first when they introduced this machine to me, I thought I have hydrofacial machine. What else? So I can deliver serums with that also. But what I understood is the patented serums. These are different serums. So these serums are giving different, better results. So that's the thing, and it has definitely a different technology, microchanneling technology.
Thank you.
Thank you.
Thank you, sir and madam. Excellent talk by you. Thank the organizing committee for giving the opportunity to chair the session. Thank you.
I thank the chairpersons.
Yeah. Thanks to the TS Cuticon 2025. Thanks for giving this opportunity to be the chairperson.
Thank you. I would request you to move to the memento. I request Dr. P. Narasimha Rao sir, Dr. Ram Mohan sir to give the mementos. For session 3, I would request Dr. D. Subhash Reddy, sir, Professor of DVL, Malareddy Medical College for Women, to come onto the stage. Dr. A. Ratan, practicing dermatologist since 41 years. Sir, I would request you to come onto the stage. Dr. Kumar Bandadi, sir, retired Professor of DVL. I would request you to come onto the stage, sir.
Good morning to all. Next session 3. Beyond Beauty, PRP for Vaginal Health and Healing by Dr. Samta Kumar, gynecologist. She is a gynecologist. Go to the dais, madam. Dr. Samta Kumar, consultant obstetrician and gynecologist, Cloud9 Hospitals, Banjara Hills.
So a very good morning to all my dermatologist friends, colleagues and seniors. I'm actually feeling conscious after looking at your lectures how my hair and skin is going to be in future, but very interesting topics. So as we all know, you are pioneers in using PRP in dermatology. I'm just going to throw light how PRP is helpful in vaginal health and in gynecological issues. So we know it is an autologous concentration of platelets which is rich in growth factors. Can I go behind? Behind. Okay. So we know there is a paradigm shift in medical treatment now. Doctors are focusing on longevity and improving the quality of life. And as ours is going to be a rectangular society, we're going to have more in older generation, and as gynecologists, we should be well versed in treating women with gynecological problems in their menopausal and perimenopausal stage. And yes, it is proven widely that sexual activity is not only for procreation, but also for pleasure. And we are getting women with female sexual dysfunction and asking for help. So, and they want to go for non-invasive with minimal downtime. That is where aesthetic and functional gynecology is having an increased awareness. So we know PRP is rich in growth factors, especially the transforming growth factor, vascular endothelial growth factor, epidermal growth factor, and all these essential nutrients. I'm sorry, it's not working. Can you change the slide? So they help in improving collagen production, causing neovascularization, improves tissue vascularitis, and they help in healing and regeneration. As it is non-surgical, minimal invasive and minimal downtime, patient compliance is better. So PRP was first introduced in 2011 by Charles Runnell under OSHOT, followed by Dr. Whipple, who injected PRP into the G-spot, and today PRP is performed worldwide by trained professions in gynecology, urology and aesthetic medicine. Now, what do studies say? Because of limited data, not much of bigger randomized control trials have been done, but the few studies which shown that there was increase in vaginal rejuvenation, increase in success in improving endometrial thickness, especially in patients with infertility, effective in treating vaginal penetration disorders, especially vaginismus. Now, there's a study done by Mohammed et al. In 2021 where he took 100 women with female sexual dysfunction between 18 to 55 years, and he asked a 19 questionnaire called, where a score was given which is called Female Sexual Functional Index Score, and PRP was given in the clitoris and in the G-spot, and he found that following application of PRP, the score was improved, and the same questionnaire was asked post PRP, and he was found an increase in the score in these women. So coming to vaginal rejuvenation, PRP improves elasticity and lubrication. It stimulates new cell growth for youthful tissue. It enhances patients' confidence and satisfaction, improves clitoral sensitivity and sexual satisfaction, and overall supports vaginal health. Now, what are the application in functional and aesthetic gynecology? It is used in sexual dysfunction disorders, helped in women with decreased libido, arousal disorders, dyspareunia. Because of its property of lubrication, increasing the lubrication, it helped in women with vaginal dryness, in lichen sclerosis and pruritus vulva, and mild urinary incontinence and genitourinary syndrome of menopause. So, as gynecologists, women with female sexual dysfunction, they don't directly come to us with vaginal dryness or decreased libido. It's a doorknob disease where they come for routine gynec health checkup, and when they're about to leave the room, that is where they just look at you and say, "Doctor, I have mild vaginal dryness, I think I have mild incontinence." This is where we have to actually take the patient into confidence, have a detailed chat with them and say, yes, this can be addressed and we can help you. So coming to O-shot, this is one which is very famous now, and women are going for that for decreased libido and arousal and orgasmic disorders. It is injected into the clitoris. So clitoris has hood and body. We give 4 injections. 1 cc of PRP is given subcutaneously at 12 o'clock, 3 o'clock, 6 o'clock and 9 o'clock position of the clitoris. Along with that, it is also given in the distal part of the anterior vaginal wall, which is called G-spot. And this is done after counseling and taking consent. It's an OPD procedure which is done in 30 to 45 minutes after a proper local numbing cream applied. And most women have noticed improvements in sexual function, mainly with increased sensitivity, arousal and lubrication within few weeks, and the optimal results were seen in 3 months, and the effect can last for 12 to 18 months. Now, there have been studies which show that PRP helped in women with mild urinary incontinence, where 3 cc of PRP was injected around the urethra subcutaneously, and they have found decrease in incontinence issues. Along with Kegel, electromagnetic and few energy-based devices, they had successful outcomes. PRP helps in promoting regeneration of the urethral support and structures. What are the other applications of PRP in gynecology? Especially in infertility, PRP injection into the endometrial cavity in women with thin endometrium where endometrial receptivity is low. PRP injection has increased the endometrial lining and successful outcomes in infertility. In women with low ovarian reserve, injection of PRP in the ovary have actually improved the follicles and increased successful rates. And coming to safety and efficacy, as it is 100% autologous, no allergic reactions, with minimal side effects, maybe they would have mild redness or discomfort which would last for 1 day, and high patient satisfaction rate. Because it is again minimally invasive, no downtime, complaints will be better. So to conclude, PRP represents a promising minimal invasive option in gynecology, offering potential benefits in tissue regeneration, sexual function and overall intimate wellness. And most of the time, dermatologists are the ones who are using PRP in their practice. So if you have collaboration with gynecologists under one roof, having a clinic under one roof where a dermatologist and aesthetic functional gynecologist is available, you can help them in restoring their intimate wellness, ensuring holistic care and continue to improve patient outcomes. Thank you.
Nice presentation, madam, Dr. Samita. From the audience, any doubts? 1 minute.
Madam, at which orgasmic score you will advise the PRP?
So I have not, it's a study done by Muhammad et al. But for me, when the patient comes to us in our practice, we started PRP since last 3 years. We take the histories and we say there's a non-invasive minimal downtime procedure available. You can opt for it.
Okay, thank you.
So if you want, I can share the questionnaire where it's a detailed 20 questions where the patient will answer the questions and then you give a score.
No questions? Okay. Next session, countering the curves demo of EMS and NMS live demo by Padmavati Surapaneni. Usually this is a different techniques, different modalities is there, dermatology, so many is that like HIFU and like that. The EMS is the electromagnetic muscle stimulations, and MMS is also, so many modalities there. When, Dr. Padmavati Surabhanayam is, everybody knows, she is a senior most practitioner. She is experienced in last 20 years in aesthetics, cosmetics like Botox, fillers, everything, well-known, renowned dermatologist in Hyderabad. Okay, madam, what did I? EMS and this is NMS or MMS? No, this in brochure, MMS is there. Actually, MMS, no? Both. Yeah. Electromagnetic muscle stimulation. Yes. Different modalities is there, no? Yes. Yeah. Proceed.
First of all, I want to thank Sudhavani and the team for inviting me here. Today my topic is body contouring and muscle stimulation technologies, whatever are available in the market. So what is an ideal body? So most of the patients come to us not for body contouring but for weight loss. So when you start your body contouring clinic, what you have to see, what is an ideal thing, what you have to promise to your patients, it should be a good tight skin with no cellulite and stretch marks. Ideal fat and muscle composition, which is very important. Now all the youngsters want to see not only how much weight they are, they want to see the composition, how much muscle they have, how much fat they have in their body. That's very important. Soft natural chill out without any bulges and bumps. Ideal weight and BMI. Ideal BMR. Good muscle tone and strength to give a good posture. So there are so many non-surgical body contouring technologies available and what we are using since decades. So again we target layer wise. When we see the skin tightening procedures, we use radiofrequency, microneedle radiofrequency, HIFU and shockwave. To target the fat, the modalities available are cryolipolysis, injection lipolysis, again HIFU, RF, low level laser and green lasers. Muscle, EMS and NMS. Lymphatic drainage, we use shockwave vacuum assisted radiofrequency. So what are the muscle technologies available? How do they work in improving the body contour? So first thing is the NMS, that is the neuromuscular stimulation. As we learned physiology, we all know there will be a stimulus from the brain which goes to the motor neurons which stimulates the muscles to contract. That is how it works. So NMS is devices which stimulate the motor neurons to stimulate and contract the muscles is frequently used now to strengthen the for strength training in healthy subjects and athletes to produce hyperexcitation in the muscles and improve the muscle tone and mass. The benefits of NMS are the NMS signal produces supramaximal contractions in the muscle group. The powerful contraction results in an injury to the muscle fibers. During the process of recovery, the body produces new muscle fibers, that is hyperplasia, and strengthens the existing fibers, that's hypertrophy. This leads to increase in the body muscle mass and eventually body contouring while improving the body posture and stamina. Coming to the electromagnetic stimulation, the electromagnetic fields are created when electric current flows through the coil. The greater the current, the stronger the magnetic field. Low frequency magnetic fields induce circulating currents within the human body. If sufficiently large, could cause stimulation of nerves and muscle. The magnet emits powerful electromagnetic emissions over the treatment area. They harm less form of the emission, when comes in contact with the muscles, trigger strong vibration in the muscle fibers. So this machine what we are using is called the Wonder Prestige. And the advantage of this machine is it have a double action mechanism. It has both electromagnetic stimulation as well as a neuromuscular stimulation in this device. It have the combination, and it have intense muscle contraction. It causes fat lipolysis also. So only non-invasive technology offering full body treatment. So if you see the other modalities, you can target one group of muscle, and then afterwards, after that session, you have to take an other muscle group. But this technology, 6 core muscle groups are treated at the same time, and in the treatment time of 25 minutes, there will be for 52,000 supramaximal contractions of the whole muscle group. And the pulse width of this machine is 700 microseconds, which can cause a deeper penetration of the stimulation up to 16 centimeters, so that the larger bellies and the bigger muscle mass can also be targeted. There are 7 different programs in this which can be operated through a wireless tab, and there is a low acquisition cost and there are 0 consumables, so you can get your quick ROI. So what are the muscle groups in stimulated in this technology? We target the legs, obliques, arms, quadriceps, glutes and abdomen in the same treatment session, which in the time span of 25 minutes, and there will be a very good muscle contraction of all these areas, including calorie burn, because there is a lot of stimulation of the muscles. When we use the smart watch on the patients and see, in this 25 minutes we can see up to 150 to 200 calorie burn in this patient. So it gives you a negative calorie balance also. So as I mentioned, the pulse width is 700 microseconds and maximum penetration into the bigger muscle mass can happen. So what are the benefits of the treatment? There will be increased skeletal muscle mass, reduced body fat mass, improved basal metabolic rate, improved BMI, reduced body weight, improved posture and stamina, and improved bone density and improved tone. What are the contraindications of this treatment? Pregnancy and lactation and minors, we don't use this treatment. Any illness like flu, bacterial infections, fever or any other systemic illness, bone pains or injuries, epilepsy or any neurological problems, cardiovascular patients with pacemakers or any other implants, acute infections or allergies in the local treated areas. So this machine have 12 sensory panels and 2 electromagnetic panels. It have a wonder suit where the patient have to wear this suit, and then we apply these panels, these 14 panels on the legs, arms, glutes, obliques, abdomens. So we can see a live demo of Wonder later. The volunteer is ready with the Wonder suit over there and the Wonder machine. This is a small video of how we use Wonder in the clinic. Audio is not there. Audio. I think audio is not coming. This is the tab what we usually use. You can see the contraction of her glutes. It's a very comfortable treatment of 25 minutes. We slowly increase the intensity of the muscle contraction, talking to the patients if they can tolerate from level 1 to slowly to 20, 25 or 40, depending on how the patient can tolerate. So these are the different programs which are available in the Wonder. First one is the Superman program. It's a fat burning and muscle building program. The program is created to cause metabolic alteration that triggers a process of burning calories and losing fat along with building muscles in a clients of BMI of 30 and above. Superwoman is almost the same as Superman but at the lower intensity levels. Definition is the starting program, where the milder form of Superman and Superwoman are used. This is mainly for the beginners and who doesn't do a gym workout and very new for the stimulations. And muscular is the body for bodybuilders and athletes. It's a much more intense program than the Superman and Superwomen. Cellulite is a vascular program. This is to improve the pumping of the blood and to improve the circulation to reduce the cellulite. Pelvic floor is one more thing where to strengthen the pelvic floor muscles, which targets the thighs and the glutes and the surrounding muscles. Physio is for the people who have a muscular or ligament complications to stimulate the muscles and strengthen the muscles. And other one is the spa, that is relaxation of the muscles. Usually we do this after the intense program to relax the muscles and to avoid fatigue in the next 24 hours. So what should we brief to the patient when we are doing that? It is not for a weight loss. We are doing to improve the body composition analysis and to create a negative calorie balance, and they have to follow a healthy diet. We can see increase in the skeletal muscle mass, basal metabolic rate, improved posture, strength and stamina, and improved body tone. There will be a decrease in body fat mass, body mass index, weight, visceral fat and body circumference. So there are multiple indications to improve the muscle toning, to burn the fat, pelvic floor or SUI, pelvic floor strengthening, and to control SUI. Athletes, cellulites and rehabilitation, we can use this machine with the different programs. There are different papers published in this with this device. In one paper from Colombia, there is a reduction of total weight of all the subjects had a weight loss of minimum of 5.2 kgs and maximum of 14.7 kgs, average of 9.5 kgs in the group. Loss of 5 to 10% of weight in 60%, loss of 10 to 15% in the next 40%. Weight loss was slightly higher in female clients. Coming to the waist circumference in another study from Mexico, 10 wonder sessions, the percentage difference was 5.35 centimeters and minimum waist reduction is 3 and maximum is 10 centimeters. In the same study, the abdominal circumference, 10 sessions, the average difference was 11.51, minimum reduction is 2 and maximum is 10 centimeters. These are different white papers showing general information, how the wonder can strengthen the muscle therapy, physiological approach of NMS for the muscle toning device, and in this study shows pelvic floor muscle strength increasing in with the wonder machine, and increase in the muscle mass and loss in fat after the wonder therapy. So this is how we usually do in our clinic. We have a chart of the body analysis where we see the weight, muscle mass, body mass and the BMI. So every week when the patient comes, we do this chart and then see how the patient is improving. Nowadays there are a lot of patients who are aware of gymming and doing exercises. Also there is a lot of drastic weight loss patients where not only the fat, they lose their muscle. So these patients also we enroll in this so that the muscle mass is maintained or muscle mass is improved than while they are losing their fat when they lose the weight. These are different pre-post pictures. These pictures are from the company, not mine. This is another patient. You can see good improvement in the muscle tone, abdominal muscle tone. This is again another. You can see a reduction in the fat and improved muscle tone on the belly. This is another one. You can see good improvement in the back and the glutes. Conclusion, always in aesthetic practice we should use different technologies. Till now we are doing fat and skin tightening procedures, but introduction of muscle stimulation and toning up of the muscle and burning the calories in a physiological way is very important. You have to target all the layers of the body as we do the aesthetics on the face, and combining the procedures will always give you a better result. Thank you. Now we'll show you the live demonstration of the wonder machine. Hello. So this is the wonder. They have different suits, like he had a shirt and a pant. They have different sizes, small, medium, large and extra large, depending on the patient. The patient will wear it. Then they'll have, you have these 2 for the arms and then 2 for the glutes, abdomen. The front they have the cartridges, and then on the obliques also they have. This is for the glutes and this is for the thighs. And this is the tab. Can you focus on the tab, please? So this is how it looks, muscular electromagnetic. So how many seconds it contracts and how many seconds it relaxes, it will be written. So when we start the programs, you have all the muscles like obliques, biceps, arms, obliques, abdomens, quadriceps, femoris and gluteus. When we start, we can select the program. Start it. This is the definition program. Usually we start with the definition program, which slowly we contract all the muscles, and whenever after 1 or 2 minutes we'll ask the patient how he is feeling, and then we start increasing. Increasing we can do this way. Individually, like you can increase the start. So if you want to increase the abdomen, we can increase only abdomen. Go to the master otherwise. So you can see the contraction coming like do a definition. So you can see the contraction and relaxation. 8-second contraction and 2 minutes relaxation, again it starts. They have different modalities. You can change the intensity of the individual muscles, or you can stay all over. Like if it is in a master program, if I do this, overall program will be increasing. You have to do when it is not contracting. Actually, when it is in a relaxation phase, we can increase the session. So it comes to 7 and 8. Like that we can do individually, or you can do the overall muscle stimulation. So it comes to like, initial 5 to 10 minutes we use the definition program, so that it is a low intensity contractions. So when the patient gets used to that type of contraction, then we'll move it to the either Superman or a Superwoman program, and then slowly start increasing. Maybe hands will take only up to 10. And then abs you can take up to 20, and glutes and thighs they can take up to 40. We record like how much the patient has taken in the initial session, and next session we slowly start from there and increase till they attain the maximum amount of contraction and calorie burn. So we usually do the chart what I have shown you, the BMI and the muscle and the fat mass, as well as we take the circumference also. The good thing in this is the patients who come to me with the knee joint pains and all, when they start with this, when their muscles start strengthening, the reduction in the pain, and they tell me like, doctor, we are able to walk properly. So not only for aesthetics, like for the rehab and for the physio also, you can start using this machine in your clinic. Thank you.
Overall, it's a good presentation regarding your modes of E3 available dermatologists. Good. Thank you, Dr. Padmavati. Thank you.
Next speaker, focus on frontal fibrosing alopecia. By Dr. Manoj Gya. What is the name?
Thank you, sir. Without further ado, I would like to start the topic. My topic is focus on frontal fibrosing alopecia. By definition, frontal fibrosing alopecia is a progressive scarring alopecia characterized by frontal and temporal hairline recession. It was first described by Cosard in the year 1994. It was described initially as a subtype of lichen planopilaris. Interestingly, its incidence is rising globally, particularly in postmenopausal women. It most commonly affects women in the age group of 45 to 60 years, predominantly female patients. Of course, more and more males are also presenting with this condition, and cases are reported worldwide. Now, we cannot talk about frontal fibrosing alopecia without talking about lichen planopilaris. The question is, are FFA and lichen planopilaris unrelated yet similar, like these two people? Or are they related with a few dissimilarities, like these two people? And the clinical and histopathological features are equally confusing. Clinically, both of them are distinct. Histopathologically, they have a few similarities and they have a few differences. So, where do they stand? The theory is that both of them are branches of a similar underlying pathology. The initial stages of pathogenesis are similar for both of them. However, individuals who are predisposed to LPP will develop that phenotype, whereas individuals who are predisposed to frontal fibrosing alopecia will develop a different phenotype. And what is the factor which decides which individual develops what? LPP predominantly is characterized by M2 macrophage activation, whereas frontal fibrosing alopecia has more of genetic as well as hormonal components. And now this is a diagram of the pathogenesis. Initially, this is the hair follicle. The healthy bulge of the hair follicle has something called immune privilege. But here, when the immune privilege collapses, then the pathology starts. Why does the immune privilege collapse? Because of certain processes, one of which is epithelial mesenchymal transition. One more is immune cell recruitment. Third is microbial infection with antimicrobial peptide secretion, cell apoptosis, and certain environmental factor. And when the immune privilege collapses, because of the related factors, whichever one comes into play, the pathology goes either towards LPP or towards FFA. And what are the factors which lead to frontal fibrosing alopecia? One is hormonal. There's a strong association with menopause. And there is a possible role of hormonal changes which affect the immune privilege. Environmental factors, particularly urban living, and use of cosmetics and topical products, and some postulate that sunscreens also have a role in this. And there is a genetic predisposition like HLA-B7O2 is associated in some populations. Family history is reported in 8 to 10% of the cases. Now this is a diagram of the pathogenesis. There is PPAR gamma. It is downregulated, particularly in cases of frontal fibrosing alopecia. And TGF beta and the mesenchymal transition lead to fibrosis. So this is autoimmune and it is T-cell mediated immune response. And cytokines like IL-6 and TNF-alpha perpetuate the immune damage. And in the end, there is a lot of fibrosis. The environmental triggers are makeup and facial creams which can contain titanium dioxide or zinc oxide, and chemical exposures such as hair dyes and hair relaxers. A lot of people are going for straightening treatments. These are also potential irritants. But there is a lot of evidence gap in this particular area. Reduced estrogen levels are implicated in this condition, and androgen receptors also have a role. How do we diagnose this condition? We diagnose based on clinical findings, on trichoscopy, and also on basis of histopathology. Clinical findings, we have hairline recession and eyebrow loss. We have symptoms like tenderness, itching, or burning. Trichoscopy, we have perifollicular erythema, hyperkeratosis, and absence of follicular openings. Histopathology, we have lymphocytic infiltrates in the upper follicle with perifollicular fibrosis. And these are the diagnostic criteria. This is an image. It's a very characteristic image of a patient with frontal fibrosing alopecia. And we have to find out about the onset and progression of hair loss, the presence of symptoms like itching and burning, family history of hair loss or autoimmune conditions, use of cosmetics or hair treatments, and history of hormone replacement therapy or medication. And on examination, we see symmetrical recession, frontal as well as temporal. We see perifollicular erythema and hyperkeratosis. We see loss of follicular openings. And we have features like eyebrow loss, body hair loss, and sometimes facial papules. On examination, we ask the patient to raise their eyebrows. Why do we do that? We do it because raising the eyebrows can help us in identifying the original hairline. And the skin of the affected area is smooth, light, and it also lacks photoaging when compared to the forehead skin. And there are three patterns. One is hairline recession, the second is diffuse hair loss, and the third, there is a pseudo fringe sign where we see a small fringe of normal hair ahead of the cicatrization. Eyebrow loss is also a very characteristic feature, and it may sometimes be the sole presentation of frontal fibrosing alopecia. So any patient with eyebrow loss, it is advisable to do a trichoscopy. Facial papules are also a hallmark feature. They are observed on the face, and they are because of involvement of the facial vellus hair. There are other coexisting conditions, could be sometimes lichen planus could coexist, lichen planus pigmentosus also could coexist. Dermoscopy, I will not repeat once again, mainly absence of vellus and intermediate hairs, absence of ostia, and there is a very characteristic sign called the lonely hair sign, where there are one or few isolated terminal hairs in the middle of the forehead. DDs are lichen planopilaris, traction alopecia, and androgenetic alopecia. Lichen planopilaris particularly shows scarring, but it is more diffuse. AGA is more gradual with thinning out. Traction alopecia does not have inflammation, it does not have systemic symptoms. Confirmation, of course, is a biopsy. Biopsy should be performed in active area with erythema. Histopathological findings are lymphocytic infiltrate targeting the epithelium and perifollicular fibrosis. Interestingly, a recent paper showed that ultrasonography of the scalp can help in the identification of frontal fibrosing alopecia. There is increased echogenicity of the skin and loss of differentiation between the dermis and the epidermis. And a few hair follicles have an enlarged and hypoechoic area around them. Coming to the treatment, this is a very brief algorithm taken from JAD. Here, if a patient presents with FFA and we get a diagnosis, we can initiate therapy with topical corticosteroids or with topical calcineurin inhibitors. And then based on whether the woman is premenopausal or postmenopausal, we can go for other drugs. Topical therapy corticosteroids are important because they reduce inflammation. Calcineurin inhibitors are immune modulators, and they are particularly effective if we can identify early and if we can give them in the early stage. Minoxidil is efficacious. It can topical 2% and 5% formulations have also been used. Its anti-fibrotic activity is beneficial in FFA. Systemic therapies include hydroxychloroquine, tetracyclines, and systemic corticosteroids. Systemic corticosteroids can be given if there is rapid progress of the inflammation. Hydroxychloroquine is a very safe and effective drug, and interestingly, hydroxychloroquine is much more effective when compared to finasteride in the treatment of frontal fibrosing alopecia. Isotretinoin also has shown considerable benefit in the treatment of frontal fibrosing alopecia. It helps not only for the hair but also for the facial papules. Almost 15 articles with 232 patients who received 20 mg once daily for 6 months showed good results with isotretinoin. The mechanism of action is normalization of follicular keratinization, and it also has anti-inflammatory effects. Anti-androgens interestingly have a role, but like I said before, they are not as effective as other agents. JAK inhibitors, there is limited evidence. They could be promising in refractory cases. Light-based therapies are useful adjunctively. Surgical management, hair transplantation is very challenging because there is a lot of scarring. It can be done if disease is already stabilized. We have to monitor and follow up the patients regularly, and lifestyle modification is very important. And there is a controversy about sunscreens, but recently an article showed that electron microscopy, transmission electron microscopy showed particles, titanium dioxide particles in the hair follicles. But interestingly, the electron microscope also showed these particles in uninvolved skin. So the link with sunscreens has become even less clear. So we need not be afraid to prescribe sunscreen to patients when required. So these are the challenges in diagnosis and treatment. So we should diagnose early. And I would like to acknowledge Dr. Sudhavani ma'am for giving me the idea, Dr. Bhumesh Kumar sir for his guidance, Dr. Nazia Naushin Siddiqa for her inputs on the presentation. I would also like to thank Dr. Rekha Singh ma'am for her inputs and her images. Thank you.
Okay. Nice presentation, one of you.
Thank you, sir.
Overall, a good presentation, and we thank all the speakers for maintaining the time, and we thank the organizers for giving the opportunity. Thank you.
I thank the chairperson for conducting this session. I also request the chairpersons to move to the memento booth. I request Dr. K.S. Ram sir, Senior Consultant Dermatologist, Dr. Manmohan sir, Professor and HOD of Apollo, to hand over the momentum. I also request judges and chairpersons of free paper session 2, Dr. Kamal Jamani, Dr. Alankrita, and Dr. Harshita, to collect their mementos. Moving on to session 4, I would request the chairpersons, Dr. Mukesh Raj sir, Consultant Dermatologist in practice since 1987, Dr. K.S. Ram sir, CEO of Elegance Skin and Hair Laser Clinic, Senior Consultant at Apollo Hospitals, Jubilee Hills, to come onto the stage.
Hello. Good morning, everybody. May I call upon Dr. Josna Vinayak Dio for her paper Beyond the Basics, Advanced Indications of Botox.
Good morning, everybody. It's a pleasure to be here in Telangana state and giving a talk in front of all of you today. And I'm really grateful to Dr. Sudhavani for inviting me here. So when we talk about botulinum toxin, we need to first understand how is botulinum toxin working. You're using a drug to relax a muscle, and the muscles which you're relaxing are the muscles of facial expression. Now, what is specific about the muscles of facial expression? That they originate in the bone and insert in the skin. So therefore, when we use the muscles, we are moving our skin and causing dynamic wrinkles. But the second use here is that we are also using botulinum toxin on skeletal muscles like the masseter and the temporalis muscles, which are muscles that originate in bone and insert in bone. So when you relax those muscles, you are changing the size of the bone and changing the shape of the face. So when we approach facial aesthetics, we divide the face into three parts. The trichion. So we have the trichion, then we have the glabella. So between this is the upper 1/3. Then you have the middle 1/3 between the glabellar and the subnasal area. And we have the lower 1/3, which is between the subnasal and the submental area. And why do we divide the face in these three parts? Because the three parts age in a different way. So when we consider the upper third of the face, my topic is beyond the basic indications. So the basic indications we know is the glabular frown lines, the horizontal frown lines, the periorbital wrinkles and the crow's feet. But what more can we do? We can also do brow shaping by modulating the way in which we inject the toxin. We can also widen a narrow palpebral aperture, and we can also look at temporalis hypertrophy. In the middle third of the face, we can treat facial asymmetry, we can treat nasolabial folds, lip malposition, we can treat bunny lines, we can treat a gummy smile. In the lower third, now when the major part, the demos which I would be showing on the lower third of the face. So in the lower third, when we try to understand the anatomy, there are a number of muscles here which are surrounding the perioral area. So the muscles of facial expression, if we know, basically surround two orifices. They are surrounding the area around the eyes, they are surrounding the area around the mouth, the perioral area. And because of which we are able to move these orifices and generate expressions. Now we have the depressor auricular anguli oris, which is a depressor. We have the depressor labii inferioris, which is a depressor. And on the other hand, if you see the mouth, you have the zygomaticus major, the minor, which act as elevators of the corner of the mouth. So we have the orbicularis oris muscle, which surrounds the mouth and is responsible for communication. We have the depressor anguli oris, which contracts and causes a downturn corner of the mouth. The mentalis muscle is responsible for a pebbly chin, and the platysma is as we know, is a broad band of flat muscle which extends from the anterior neck to the mandible. So in the lower third of the aging face, we treat for gummy smile correction, perioral wrinkles or lip flip to elevate the corner of an aging mouth, smoothen a dimpled chin, for hypertrophic neck bands, Nefertiti lift and masseteric hypertrophy. There are other indications also in botulinum toxin in dermatology, such as the treatment of axillary and palmoplantar hypohidrosis. We know about mesobotox, microbotox, trapezius muscle reshaping, gastrocnemius or calf muscle reshaping. Trapezius muscle reshaping is also known as trap tox, and then we also can be using it for keloids. So there is a very healthy market for toxins, as we can see. India has two manufacturers. So we have Gufic, which is marketing Stanox, and we also have Nabota. Plus we have the known ones, that is Dysport, Botox, Xeomin and Ciax. Now out of these are all onabotulinum toxin, whereas this is Dysport is botulinum toxin type P, and the dilution is different. So what do we need when we do a procedure? Well, we need normal saline, we need a marker to mark the muscles, and of course we need the product. So coming to the bunny lines, for treating the bunny lines, the injection points are 1 to 2 units in the nasalis muscle. Now whenever we inject botulinum toxin, how does it work on a line? So if a muscle is moving in a particular direction, the lines are perpendicular to that direction. So if I see the frontalis muscle, it's a vertical muscle. Therefore the lines produced by the frontalis muscle are going to be horizontal in nature. So similarly, when I see the nasalis muscle actually is a horizontal muscle, which then produces lines which are vertical, and I inject them to treat the nasalis muscle. To correct a gummy smile, what is used is this triangle. So we have three muscles, the levator labii superioris, alici nasi. You have the zygomaticus minor muscle and you have the levator levi superioris muscle. Now, the Yonzi point lies exactly over here at the junction of this triangle. So, if you see a surface marking, it's approximately 1 centimeter from the ala nasi and it is about 3 centimeters from the oral commissure. For perioral rhitides or for a lip flip. In lip flip, although we say we can use the same point for perioral rhitides and for lip flip, the difference is in perioral rhitides, you are injecting 0.5 to 1 unit with a total of 3 to 4 units in both the upper lip and in the lower lip. And your injection is in the superficial fibers of the orbicularis oculi muscle. Whereas when you are treating it for a lip flip, you come a little more inferior and you inject at the vermilion border. And you do not inject in the lower border, so that what happens is there is an upturned upper lip and a subtle lip eversion. So can be used in a young patient who does not have much volume loss in the lips, but just wants that subtle bit of lip eversion because the upper lip is considered should be slightly more projected as compared to the lower lip. For the mentalis muscle, the injection points, we take 2 to 5 units on each side. You take about 1 centimeter below the mental sulcus. The thing is, you have to stay within the lateral incisor margins. And this works for treatment of a pebbly chin. For a DAO, the depressa anguli oris, the injection points is 1 centimeter below and lateral to the corner of the mouth. You give 2 to 5 units on each side. Now, when I am injecting here, what do I need to look for? Well, I have the rhizorius, which is laterally. If I inject that, I could cause a change in the way the patient smiles. I also need to be careful about not injecting the DLI or the depressor labii inferioris if I go to medially, because then that would give rise to a difficulty in the patient drinking or sipping from a straw. So the muscles which I covered till now, as I said, were muscles which were originating in bone and ending in the skin. Now we come to a muscle, the masseter. Now, how is the masseter different from the other muscles? So the masseter originates in the bone, it originates from the zygomatic arch and it inserts into the ramus of the mandible. And what does it do? Well, it helps us clench our teeth. But then a hypertrophic masseter gives rise to a slightly bulky appearance of the face, and that is what we are trying to correct when we are treating the masseter. So how do we avoid? So what is it that we need to look for? Well, we need to look for the lower border of the earlobe and the lower commissure, anterior lateral commissure, and you need to stay below that. Why stay below that? Because just above this you have the parotid duct going, and also, so which you wouldn't want to injure that. The second thing is you take the mandibular border and you go 1 centimeter above. Now, you mark the anterior and the posterior border of the masseter and you stay 1 centimeter behind the anterior border of the masseter. The other thing about the masseter is this muscle, although it is a single muscle, it has 2 lamina. And there is a tendinous lamina which separates the superficial and the deeper part of the masseter. How does one ensure that one injects it properly? If we go too deep, then what will happen is you miss the superficial part of the masseter, and that gives rise to a bulging appearance even after a successful procedure. So a biphasic technique is tried in which you take a superficial point and a deep point. So you insert the needle into one point, inject, then withdraw and again inject. I'll show that in the video. So by doing a biphasic technique, you can avoid the bulging of the masseter, which can sometimes happen during mastication after the procedure. Yeah. So we mark the anterior and the posterior border of the masseter. You mark 1 centimeter above the mandible. Just palpate to make sure. Then as you palpate, you can ask the patient to clench their teeth and feel the bulk of the masseter. Once you're sure about that, you mark 3 points, 1 anterior and 2 posterior. The aim being to cover the entire bulk of the masseter. Now, if you see the needle that I am using for masseter, this is not the typical insulin syringe needle. I have actually taken a 30 gauge needle which is ½ inch long. The reason being that this muscle is a bulky muscle and I need to go to the depth. Now see how I am injecting. I go to the depth, I inject some units, then I just slightly withdraw and I inject again. So this way I make sure that I inject both the deep and the superficial part of the masseter. And I have used a tuberculin syringe to take my product. The product that I have used for today's video is the brand that I have used is Tunox. Now this is Onabotulinum toxin A, and the dilution is, it contains 100 units and which is diluted to 2.5 ml of normal saline. So which gives me around 100 units in 2.5 ml or 40 units in 1 ml. Now I have used around 20 units over here, so on each side, so which means around 6. I have given 6 units here, 7 and 7. So this is one of my patients. Don't look at her skin. Actually what happened was that she had also had a fractional CO2 laser resurfacing, and then that's how it happened. And the next time she came, also we had scheduled her laser for her acne scars. So, but you can see the difference. See the bulky masseter here before the treatment and see after treatment, which was about 6 weeks later. Now the effect of this procedure would typically last for 6 to 8 months. And initially the sittings are more frequent, but later it can last longer. This is a lateral view of the same patient. Now, along with the masseter, we can also treat parotid hypertrophy. Now, what is the location of the parotid gland? The parotid gland, it overlies the masseter and it also extends over here, just behind the ears. Now, sometimes when the mandibular contour is bulky, but if you can see that it is extending beyond the angle, that is when you suspect that the patient might be having a parotid hypertrophy. Now in this case, you give 20 to 30 units per site and the injection is superficial. If you are in doubt, you can get an ultrasound done to confirm that the patient has a bulky parotid. So these are the points where you can mark for a parotid gland injection. So the way to do it is, you first mark your masseter points, then you can feel the angle. If you know that there is a bulk which is extending beyond, this is more likely to be the parotid. So you again, we know that the parotid duct is going here, so you stay a little behind that and take care, bearing in mind that you have the branches of the facial nerve which are also piercing through the parotid gland. This is one of my patients in whom we had done, note the visible slimming. If you see, you can see the bulk which is due to the parotid. She did not have a masseter when she was clenching, so we just did parotid for her. We also did upper face, so, but anyways, she gets a visibly good cleanse. The last muscle that we are covering today is the platysma. Now, the platysma, as we know, it originates from the sternoclavicular joint and the clavicular and the scapula, and it inserts into the smas of the face. Now basically the platysma stretches the neck downwards and laterally, and along with the depressor anguli oris, it pulls down the lateral corner of the mouth. Now with age, what happens is the muscle fibers detach and they become attenuated. Now there is a lot of variation in the facial anatomy. So it is never copy and paste when we are injecting. So the platysma also shows variations. You have a type 1 platysma which is seen in 75% of the population. Now in this, the medial fibers decussate about 1 to 2 centimeters below the skin. And in the suprahyoid, so when we swallow we can feel the hyoid, In the suprahyoid, you have separate muscle bellies. So the second type, which is 15%, but in this, the decussation is happening at the level of the thyroid cartilage. Now in this muscle, if I were to relax the lower fibers and leave this, so when we relax one part of the muscle, the remaining part of the muscle becomes stronger. So if I want to give good support to the jawline in such a patient, the moment I relax this part, this becomes stronger and I am able to actually strengthen the jaw. And the third type is one, which is turkey neck, where there is no decussation at all. So this type of plastisma is worst for support. So therefore, the techniques which I inject will also be different. So we know that the plastisma is extending all the way here. So if we do a microbotox technique, wherein you inject small amounts of Botox. So typically in Dr. Waffles' Wu paper, he took around 20 to 28 units of onabotulinum toxin A per ml, which was diluted to 40 units, and then it is injected in microdroplet manner. So what is the advantage of this technique? It will improve the skin texture, it will smoothen the horizontal creases, it will decrease the vertical banding of the neck and give a better apposition. So it is good for type 1 and type 3 platysma. But in a type 2 platysma, it may not be that great, and platysmal bands which are there will definitely need topping up because microbotox cannot tackle the platysmal bands. So to tackle the platysmal bands, we have the neck rejuvenation or the Nefertiti lift. So here you give intramuscular Botox along the platysmal band, but you give subcutaneous Botox at each point, 2 units below the mandibular margin. So you are improving the apposition of the jawline, of the skin with the jawline, and at the same time you are taking care of the banding. And Nefertiti was an Egyptian queen. So she had this perfect square jawline, which we are trying to achieve by doing this technique. So when you compare the two, Nefertiti lift has both intradermal and intramuscular Botox. You have platysmal bands at rest and on contraction, and it is more effective in a type 2 platysmal anatomy. On the other hand, microbotox technique is intradermal. You may need to add it will work on platysmal bands which are there in contraction but not in rest, and it will improve the skin laxity and horizontal necklines. So here, one second. So here we are injecting the neck bands. So as you can see, you have to ask the patient to clench, feel the band, hold it, then ask the patient to relax and inject. Approximately we need about 10 units when you are injecting the neck bands. Now this is not diluted Botox, this is not hyper diluted Botox, this is the standard dilution of botulinum toxin. Along with that, we give subcutaneous botulinum toxin. If you want to do the DAO along with this, if you see in this patient, I have marked the bands. I have also marked, if you see, this is the marking for the depressor anguli oris, because the DAO along with the platysma helps in pulling the jawline down. So just ask the patient to, pull down the corner of the mouth. This gives you, see, as I said, the lines, your DAO is vertical, your lines are horizontal. So again, ask the patient to relax and then get the DAO. Yeah, I'm almost done. So, yeah, this is another of my patients in whom we did both masseter and we did the parotid. This is his post-treatment photograph. And yeah, I would like to invite you all to Axicon 2025, which we are hosting in Navi Mumbai this year. Thank you so much.
Well done, Dr. Josna. It's an interesting and very useful presentation. Thank you.
Hello. Now I am
I want to call Dr. Nilesh Narendra Goel for the topic from flap to fab. Please come, Nilesh.
Good afternoon, everyone. Oh, it's just afternoon. First of all, thank you very much for the Telangana State IDVL team for inviting me, in particular Dr. Sudha Vani. I'm here to speak about liposuction and, or rather lipobody sculpting, which is my area of interest. So from flap to fab, which is what we all want to achieve, not only for us, but also for our patients. So what can be done by modifying the fat compartment of the body? So we all know about visceral fat and the subcutaneous fat. So it is always the subcutaneous fat that can be removed. The visceral fat is the one which has to be lost by increasing your metabolism, by changing your lifestyle, and many other factors. The global body fat reduction figures show a very promising future in this field, and hence it's something which we should all think about, especially that we have patients who are very cosmetically inclined and they want to look good not only on the face but also on their in terms of their body shape. In addition, there are a lot of devices which are now coming out, and there's a lot of research happening where body shaping is taking priority. We have achieved quite a bit of excellence in lasers, so now the device companies are now targeting body shaping, and we've had talk about muscle stimulation and muscle reduction just a little while ago. So this is something which we need to start thinking about. And this article in the Indian Journal of Plastic Surgery in 2015 mentioned that amongst all the surgical procedures done by plastic surgeons, liposuction tends to be taking the lead, and it is quite commonly done, and this is not just in India, it's all over the world that we have a lot of need for liposuction. So lipobody sculpting is the new terminology, which is basically liposuction with or without fat grafting. So you can use that fat which you have removed from one part of the body and use it in the other part of the body. It's a term which I have derived from the words liposculpture, which was the actual term given by Professor Pierre Fournier, the inventor of liposuction, and liposuction, which was a term given by the American plastic surgeons to this procedure. So we remove excess body fat from one area and then we put it in the other part of the body, which is called autologous fat grafting. A little bit of history, because this is something new for all of us. So Arpad and Giorgio Fischer, Arpad Fischer on the left is the Hungarian doctor who was settled in Rome, and in 1974-75 he invented liposuction. Basically he was sucking out fetuses, and in the process realized that he could suck out fat, and that's the idea which led to liposuction. And Giorgio Fischer is still alive on the right side. That's his son. He is doing orthostatic liposuction now. This is the first machine made by Fischer called cellulose succiotome, and this was the one which has led to our modern suction machines and modern devices for liposuction. Professor Illouz was his contemporary from Paris, again a gynecologist, and they both actually helped in developing liposuction and inventing cannulas for liposuction. Incidentally, I met Professor Illouz just a few months before he passed away, where he was talking about cell-assisted lipotransfer, which is essentially transferring fat to different parts of the body, and he was saying that in his lifetime, all patients in whom he had done a breast augmentation with fat, none of them developed breast cancer, whereas the incidence of breast cancer in France was about 12%. So definitely he was hinting towards fat having an anti-oncogenic potential when you transfer it to the breast. Pierre Fournier, again at the same time an aesthetic surgeon in Paris, he also was in the same process and developed liposuction. He resurrected autologous fat grafting, realizing that the fat which you acquire from liposuction can be then used for improving the appearance of other parts of the body. And he would do the entire procedure with a 60 ml syringe, which he would carry with him and show us how he would do the entire procedure. And he has been on my courses for Dazzle, and we've done wonderful. There was a lot of learning from the master. And then Professor Lawrence Field, a few of us must have met him. He's come to India twice. He was the first dermatologist to learn liposuction from Pierre Fournier, and since then has gone on to teach a lot of dermatologists across the globe. In fact, the history is that dermatologists first learned liposuction rather than the plastic surgeons, and then in the late 70s, dermatologists started doing liposuction in the US. That's when the plastic surgeons got the hint that there is something new happening in that part of the medicine, and then they went across and learned from Professor Illouz and started calling it liposuction and now claim it to be their own procedure. And finally, Dr. Jeffrey Klein, from whom I actually learned liposuction. He is the inventor of tumescent anesthesia for liposuction and using microcannulae for liposuction. Both of which these techniques have radically modified this procedure to the extent that it can be done as an outpatient procedure now. Patient comes in, does the procedure and goes home. We don't need to keep the patient in the hospital. It has limited all the complications associated with liposuction to a great extent, and just uses lignocaine up to 55 milligram per kg for liposuction. So the technique, as I said, it has to be discussed between the patient and the doctor. You mark the mountains of fat, then you infiltrate with tumescent anesthesia solution. You allow the anesthesia to settle down and then aspirate using microcannulae and a suction machine. This is the traditional liposuction. Nowadays you have variations. You can use ultrasound energy, you can use laser, you even have power assisted liposuction. A bit about tumescent anesthesia, which can be used in all fields of dermatosurgery. So it's a mixture of normal saline, lidocaine 2%, which is available in India freely, adrenaline 1 in 1000, and sodium bicarbonate 7.5%. So these are mixed in a specific ratio. The dose of lidocaine and adrenaline keeps changing depending on which area you're infiltrating and how much you want to infiltrate. So that keeps changing, and there's a specific chart for it. It has to be prepared freshly before infiltration, and you can administer it using a pressure bag or an infiltration pump. So it has, as I said, it reduces blood loss and it prevents over suctioning, because your patient is awake. You only are able to work in the area which has been adequately numbed. So you have to numb the area, and then your patient does not allow you to go into a either deeper or in a area which is outside your anesthesia area. So it keeps you in the safe zone, and as I said, there's no hospital stay required because there's no hemodynamic changes in the patient after the procedure. Complications, as is true for every surgery. Anesthesia complications, because we use high dose lidocaine, there's a possibility of nausea, drowsiness, headache. However, having said that, the therapeutic, the toxic dose is never crossed when you use tumescent anesthesia in the true manner. There are some short-lasting side effects like pain, bruising, irregularities, but these all can be helped with a compression garment. And some serious side effects like seroma, hematoma, and infections, these can be prevented by using the traditional method, by using microcannulae, by actually using the pressure garment effectively 24 hours of the day. So these prevent all these collections from happening. And to date, not a single death has occurred when principles of tumescent anesthesia are followed for liposuction. So you need an operation theatre. It's a proper surgical procedure. Cannot be done in your normal procedure room. You need an operation theatre which is adequately sterile, but we don't need the HEPA filter and everything because it's not like orthopedic surgery. You may need to have a washroom attached to the theatre because the patient will need to go there. It's a long procedure, takes 5-6 hours when you're doing a full abdomen, and you're infiltrating so much fluid, so the patient will need to go to the loo. Cannulas of various diameters, lengths, different companies have different forms of cannula, so you need a whole gamut of it. These are tools for fat grafting. You got the injection cannula and the nanofilter and the injection, the nanofat injection cannulas. And you need a good suction machine. Not a very hi-fi one, but just a simple suction machine which you get in the market. So if you see on the right side, that's all fat, and just the about 450 ml of blood tinged fluid. It's not exact blood, and it is said that if you do the procedure properly and the anesthesia adequately, you don't lose more than 10 ml of blood when you aspirate 1 liter of fat. So if you're going up to 3 to 4 liters of fat aspiration in a day, you're not going to lose more than 30 to 40 ml, which is easily survivable, and the patient can be sent home. So there's no hemodynamic instability. So you can go from here to here in about 4 hours, this is immediate post-op, and so that can have a very big impact on the patient's habitus. This is a male, just the lower abdomen and the waist, lateral thighs and upper buttocks done in a female, gynecomastia in a young male. This is on the rise. There's lots of patients who are having this kind of problem. So it's a procedure which can be easily done. Takes not more than 2.5 to 3 hours. A small axillary pad of fat. This can be removed easily using liposuction. Lower back. This was about 4 liters of fat removed from just the lower back of the patient, and the amount of reduction was significant. Arms show a very good result. I mean, you can easily give, and this is all usually permanent. I mean, it can last for years, this change. So this is something which you can really, patients can really benefit from it. And you can use that fat and put it on the face and give an immediate change to the face as well. This was about 40 ml of fat put in the entire face, the lateral and the medial cheeks. Again, arms, 3 weeks later, and this is 3 weeks later on the face. Morphia is the most commonest dermatological indication where once the disease has stabilized and it's in remission, you can actually use fat to resurrect and change the appearance. This was a 23-year-old boy who had come to me asking for something to be done for his left half of the face, because at the age of 7 he had morphia and the face had stopped growing at that point. All the tissues were all stuck inside. So we put fat, about 5 sessions it took us to reach from here to here. About 120 ml fat was put in, and this was him after about 2 years. Look at the way the pigmentation has changed. The skin pigmentation has changed, the skin texture and the quality of skin, the skin integrity has changed. He needed a hair transplant on the eyebrow, but otherwise his forehead also had smoothened out, and we literally lifted his cheek. I mean, if you compare it from this side, there's a good elevation of the cheek. It's like creating a new kind of surface out there. Another case of morphia. After 2 sessions, she had only 18 ml of fat put in, and she had a good correction of her forehead and right infraorbital area. You can do facial rejuvenation with it. You can just put fat in face. We lose fat, our tissues degenerate. We all know about it on the face as we grow older. So it's the best way to actually replenish those lost elements on the face. This was a 50-year-old heavy smoker actually, but she was very insistent on getting it done. So I did her whole face, 40 ml of fat was injected, and this was her 3 days later. So you can have an immediate effect. In fact, there is not much of downtime. This is a young boy, 37-year-old, super exerciser, just goes on, wants to reduce his abdominal fat, but also loses the facial fat. So you just replace and put some out there, and look at the difference. Same thing in a female. This is her after a month, and the face looks so much more younger and happier than the previous one. You can do nanofat under the eyes, just to give a little bit of lifting, and also mainly for the melanosis and the wrinkles which are there under the eye. Nanofat can also be done for pigmentation under the eye. This lady, nanofat under the eye, and also we put a little bit of fat in the lips to give the lips that little bit of hydrating and a plump effect, not to make her like Angelina Jolie, but fat in the lip gives you the most natural lip filling. It doesn't make it look very obvious that you put a filler in the lip, because lip fillers are very, very obvious. You see, and you can make out from a kilometer away that she's had a lip filler. Lift and fill, that's another thing which we should think about. I mean, we had talk on threads. So why don't we do fat filling after threads? Because there are a lot of patients who have lost a lot of volume on the face. So once you lift, you can then fill it with fat and resurrect the whole face. The change is very drastic in this lady. She was a 61-year-old lady who had come just for fillers actually, and because her cousin had fillers in Chennai. So she wanted fillers in the nasolabial fold, which I said, rather than that, let's first lift and then put some fat on your cheeks, because you've lost your entire volume in the cheeks. So filling in the nasolabial fold would actually make it much worse. And she was very happy with this. Nanofat for hair growth, that's the latest. It's the best product available, full of stem cells and growth factors. You can get very good results within 3 to 6 months, and it can be used as a stopgap arrangement before the patient decides to go for hair transplant. So this is something which can also be done. So essentially I feel fat is the future of aesthetics, and once you start doing it, I mean, I can tell you my life story that in the last 14-15 years it has changed my way of practice dramatically, and even those who have learned fat grafting and liposuction, they all have really made wonders with their patients. It's got multiple uses: facial rejuvenation first of all, any deformities, breast augmentation, buttock augmentation, hand rejuvenation, periorbital rejuvenation, wound healing, scars, Dupuytren's contracture, lichen sclerosis, morphia we all know about. So there's so many opportunities where we can use fat. Any depressed scar, post-op surgical scars can be modified with this. So I offer a hands-on training course in my clinic, which is now incidentally there on the 7th and 8th of January, which is just 2 days away. It's a hands-on training. I've got, from Hyderabad we've got Dr. Sri Ranjita. She's sitting here. She's my student. She's been with me last year. And Dr. Rajita and Dr. Revant Kumula, they both have come to my course. This is a very hands-on course where in 2 days I teach everything about liposuction and fat grafting, what I know as of today, and they get a certificate of completion. So if you're interested, you can email me or WhatsApp me. Also, I am in the process of creating a group of dermatologists specializing in these procedures. So we are currently having about 25 members. All of them are my students from across India, and so we are following all the concepts which are laid down by Professor Pierre Fournier and Lawrence Field, because they are the true masters of all dermatologists who are doing liposuction these days. So the office bearers of the society are myself and Dr. Nitin Jain from Pune and Nikhil Singh from Bijnor. They both have been my students, and a whole host of other members from across the country. They all have been to my courses in the last 7 years. You want to read more about these? I was a guest editor for a particular issue of Dermatologic Reviews, in which I had invited articles to be written by everyone from across the world. They all are dermatologists who specialize in liposuction and fat grafting. So this is issue. If you are interested, you can WhatsApp me. I can send you the soft copy. It's all to do about liposuction and fat grafting as of 2021. Things have changed now, but then still pretty much advanced. Thank you all very much.
Thank you so much, Dr. Nilesh, for the lovely lecture, and thanks for inviting us for the foundation what you have started. It will be very good, especially for the youngsters to enter into the field of liposuction.
Absolutely. They are the ones I'm targeting.
That's very good. And I thank all the organizers of Cuticon for chairing me this session. Thank you so much, and thanks a lot.
Thank you, chairpersons, for this session. I request Dr. A.K. Lahiri sir and Dr. Jain sir to hand over the mementos. Moving on to the next session. This is a very interesting session. It's a debate. And I would like to call upon the stage our chairpersons, Dr. N. Veena Kumari, ma'am, Deputy Civil Surgeon, ESI Hospital and Consultant Dermatologist at Yatvi Skin and Hair Clinic since 20 years. Dr. Tulsi J. ma'am, Associate Professor at GHC, Kamam. Dr. Archana ma'am, Associate Professor at ESI Medical College.
Good afternoon to all the dignitaries, respected seniors, my dear colleagues and friends. For the next session, I would like to invite Dr. Rajkirit sir onto the dais. We have two interesting debates lined up now. The first one is, okay. Dr. Rajkirit sir is a well-known dermatologist. He is the managing director of Celesti Skin, Laser and Hair Clinics and professor of dermatology. The first session is titled Finding the Best Fit, Oral Minoxidil versus Topical Minoxidil. I would like to invite Dr. G. Madhusudan Reddy sir and Dr. Divya Siddhavaram onto the dais. I request Rajkirit sir to start the session.
Thank you, Dr. Archana. So Dr. Madhusudan and Dr. Divya. So Dr. Madhusudan is a consultant in, he is Madhusudan Dermatology Clinic, and he's a very good teacher, and of course I learn a lot of points from him also. So I invite Dr. Madhusudan to start his session right away. Thank you.
Thank you, Rajkiriti sir. Thank you, organizers. So today I am going to talk between topical minoxidil and oral minoxidil. I am for the topical minoxidil. I straight away go to the presentation. So minoxidil was approved way in 1980 for the topical application. Once they are using for hypertension, we have seen. So how it is going to act? It is a potent arterial vasodilator which opens the potassium channels and smooth muscles of peripheral artery, causing hyperpolarization. And minoxidil also prolongs the beta-catenin pathway, increased vascular endothelial growth factor, and increased PGE2 activity. So what is the positive effect? Why it is getting the hair? Mainly because of its metabolite minoxidil sulfate, which the enzyme sulfotransferase helps in conversion of minoxidil to minoxidil sulfate, further helps in growth. And the drugs salicylates and aspirin are known to inhibit the effect of sulfotransferase. Coming to the indications, this is a topical minoxidil, oral minoxidil, no FDA indication still. Androgenetic alopecia, FPHL, 2% in female and 5% in male. Off-label, we know these are all the indications. So, how you can interpret the topical minoxidil efficacy? By doing the sulfotransferase enzyme. You can plug the hair follicles and do the sulfotransferase enzyme. Nowadays patients are coming asking about the minoxidil potency test. With this we can predict 94% accuracy of whether they are going to respond to topical minoxidil or not. And coming to the non-responder to the 45% minoxidil, they can also be seen. Actually in my practice also, once they are 5% non-responders, with increasing strength, not completely, but the response will be more. In 15% of individuals, once the minoxidil strength is increased, you can see the difference. Here comes the side effects to the topical and oral. This is very important for the treatment aspect, and before prescribing a drug, you should always keep in mind. Topical minoxidil has contact dermatitis, itching, scaling, headache and hypertrichosis. Especially in females with 5% you get it, 2% hardly you get a hypertrichosis. Coming to the oral, nowadays we are using, many people left and right, be cautious of these side effects, the pulsatile headache and giddiness. Definitely you need to advise to take more water and in the bedtime. Hypertension is one of the risk. Fluid, especially sodium and fluid retention will be there. And ischemic and pulmonary artery hypertension also noted because of the high output state. So these are the dreadful complications also common and is noted. So nowadays many people are advising do the ECG before giving oral minoxidil also. And hypertrichosis is more with the oral minoxidil compared to with the topical minoxidil. And rare complications like itchy eyes, bullous eruptions are also noted. So the dreadful complications are there. Keep in mind before giving oral minoxidil. And coming to this one, I am going to present the most recent study which was published in April 2024. It's a randomized control trial between 5 mg oral minoxidil versus 5% minoxidil twice daily application. They have taken the patients between 18 to 55 years age, Norwood Hamilton grade 2, grade 3, grade 4, and who doesn't have any comorbidities. And they assess the outcome at the end of 24 weeks. Primary outcome was they have marked 2 into 2 centimeter square on the frontal and occipital area. And their primary outcome is to measure the increased hair density in frontal and occipital area. And secondary is to assess overall increased hair density in the entire scalp. What the study has shown, total 90 patients were enrolled, out of which 68 patients were finished the study. Frontal area from the baseline to the end of 24 weeks, the mean difference in growth with oral minoxidil is 3.1 hair per square centimeter, whereas with the topical is 2.6 hair per square centimeter. Coming to the vertex area, the mean change at the end of 24 weeks was with oral was 23.4 hair per square centimeter. With the topical, it is 15.5 hair per square centimeter. If you compare also, oral minoxidil is working more in the vertex area rather than frontal area. Frontal area more or less topical and oral are showing equal results. And coming to the side effects of this study, this is very important. They have seen hypertrichosis, headache, nightmares, insomnia, and lower limb edema, abdominal pain, and pain in lower limbs in the oral group, whereas itching and increased hair shedding only in topical group. Conclusion of this study is 5 mg of oral minoxidil has not shown any superiority over topical minoxidil 5% twice daily application at end of 24 weeks. Oral minoxidil should be used in caution. Who doesn't respond to topical minoxidil? 2 seconds, sir.
Yeah.
Who respond to topical minoxidil, who doesn't want to use topical one, and enzyme deficiency of sulfotransferase. This is the last slide which I want to show. There will be a non-minoxidil response, which I used both topical as well as oral minoxidil. There are a set of patients who doesn't respond both set of oral as well as topical. This we need to go for hair transplant. Thank you.
Dr. Divya, please.
So here I am defending the bad guy that sir just bombarded it. So here we go. I'm still pledging my allegiance towards oral minoxidil. And we had minoxidil for about 4 decades now. It's showing promising results in androgenic alopecia in topical form. But in the recent past, oral minoxidil has been showing more practical advantages and on-par results. I think I can skip this part of the mechanism of action of the sulfated metabolite. Sir has already elucidated on this. Coming to the metabolism, oral minoxidil is primarily metabolized in the liver and excreted via urine. It has no plasma protein binding and it has a half-life of about 4 hours. So here coming to the dosage, there is a varied dosage which we use. It is usually higher in males compared to that in females. A gradual updosing is preferable about 0.5 milligrams every 2 to 3 months up to a maximum of 5 milligrams per day. The side effect profile as mentioned, yes, there are CVS symptoms and hypertrichosis, which are the most predictable ones of this group. And this can be alleviated by giving the drug at bedtime, wherein you minimize the appreciation of the hypotensive side effects. There is a black box warning for minoxidil even in the use of hypertension, where there is an idiosyncratic pericardial effusion that can develop. So whenever you start oral minoxidil, start with a lower dose, gradually updose, and it's very noteworthy to note that the hypertensive effects are very minimal in normotensive patients. Yes, be cautious when using in patients with severe hypertension and those with cardiovascular risk events. So this is a busy slide telling you of the clinical trials which were used, which were done in female patients for androgenic alopecia, and a low dose oral minoxidil was used. It is noteworthy to see that most patients continue to remain in the trial in spite of hypertrichosis because the results were more appreciable. And there was a dose-dependent efficacy. A similar study as in male counterparts was done, wherein we have seen that the improvement, as Dr. Madhusudan has already elucidated, is more over the vertex area that compared to the frontal area, and the drug was very well tolerated. It's interesting to note that oral minoxidil is also useful in conditions of autoimmune and inflammatory alopecias because it has grown to reduce perifollicular inflammation. The same study that Sir quoted, wherein it's a similar thing, wherein we have used 1 milligram of oral minoxidil against 5 milligram of topical minoxidil in female pattern hair loss. The most important thing that we've noted is a very well acceptability, the safety profile, and results are of comparable efficacy. These are the other studies which are showing a better therapeutic compliance, which being very important, and also comparable efficacy between these two formulations. Topical minoxidil has been around for very long, but undesirable hair texture, acceptance of applying it every day is not easy for every patient. Scalp irritation, allergic contact dermatitis from the same has been limiting its compliance in the long term. And yes, variable response which we are seeing is attributed to the variation in the follicular sulfotransferase enzyme. Coming to oral minoxidil, this can be bypassed because oral minoxidil uses liver and platelet sulfotransferase for producing the active metabolite. If I want to project my hero, it scores above topical minoxidil, especially for the convenience of use. There is a better cosmetic acceptance and effective cost therapy, and co-therapy here with other topical agents, and more importantly for patients who wish to use camouflage like hair fibers, this would be feasible. Compliance has been the star here, and yes, crown efficiency wherein the vertex growth is more than the frontal area. To conclude, I would say low-dose oral minoxidil is an effective and well-tolerated treatment alternative in healthy patients, and it allows for very long-standing compliance. Yes, I would still agree there is a need for larger randomized studies to establish a best treatment protocol. Thank you.
Thanks for finishing in time, Dr. Divya. I would like to invite the next speakers, Dr. Smita ma'am and Dr. Jyotsna ma'am, to come onto the dais. Dr. Jyotsna ma'am has done her MBBS and Diploma of Dermatology in Kakatiya Medical College with almost 2 decades of experience, and she is a member of Trichology Society, and she has conducted numerous workshops on thread lifting and dermatosurgery and various aesthetic dermatology procedures. And Dr. Smita ma'am, she is well-known consultant from Twacha Skincare Gachibowli, and she has been a consultant at Oliva Skin and Hair Clinic for many years. So I'd like to invite Dr. Jyotsna ma'am to take on to the next presentation, please.
Good afternoon, everyone. Thank you for giving me this opportunity. Today I am going to present about this scalp threads, or otherwise called as thread embedded therapy. The scalp threads are nothing but a type of dermal needle threads which are inserted into the skin of head for prolonged therapeutic stimulation, also called as thread embedded therapy. Basically, it depends on the dialogue between the mesenchymal and the epithelial compartment of the hair follicle for maintaining the normal hair growth. So we all know there are various signaling pathways like WNT pathway, which are one of them. So these scalp threads, they contribute in stimulating these pathways to restore the hair growth. So the mechanism of action of these PDO threads is basically activation of these pathways, anagen induction by upregulating the hair follicular cell proliferation. Not only that, it controls the expression of fibroblast growth factor 7 and fibroblast growth factor 5, which are involved in anagen induction and anagen cessation respectively. It also stimulates neovascularization, collagenesis and fibroblast proliferation. So types of threads, various threads are there like mono threads, screw threads, cork threads, inserted in different techniques. So coming to evidences, what are the evidences showing, like there are few evidences of animal studies where a study was conducted showing the effect of PDO threads on hair growth versus topical minoxidil. Hair growth. They are embedded into the dorsal skin of mice. Hair growth activity was evaluated by using dermoscopic and microscopic observations. So the results of the study showed that there is enhanced anagen development. Active cellular proliferation was noted by using markers. This increased expression of fibroblast growth factor 7, which shows anagen induction, and decreased expression of fibroblast growth factor 5, which shows anagen cessation. So based on similar lines, many human studies were conducted. So as per the Cochrane review, we all have seen that, and the previous presentators also presented that in spite of using finasteride and minoxidil both in oral and topical forms, the response is only 40 and 60%, and the rest 50-20% non-responders are seen. So there are many other newer treatments which have come up in the pipeline, like scalp threads, PRP, growth factors, mesenchymal stem cell therapies, all which are basically like in between. They have a role in between the minoxidil, finasteride and the hair transplantations. They have an additional benefit of providing extra hair stimulation via this WNT pathways. So what are the studies are saying? The Bowman study is on 100 male and female patients, which concluded the improvement within 6 to 12 weeks of PDO thread insertion. There was one more study conducted in 27 women where monofilament thread therapy was done along with minoxidil and used as an alternative for female genital androgenetic alopecia. So conclusion in all these things is like microneedle therapy combined with oral minoxidil or topical minoxidil, it provided improved results with increase in hair density, thickness and appearance compared to topical minoxidil alone. So what happens? What happens when these PDO threads are inserted? So when these threads are inserted, histologically there are changes like in the sequence, which basically a PDO threads invokes inflammation with influx of a lot of abundant inflammatory cells. Collagen tissue is neocollagenesis is formed. Neovascularization we see. So the collagen tissue is formed which merges with the pre-existing tissue, forming a proper scaffolding, and the influx of inflammatory cells and neocollagenesis basically increases the revascularization, influx of growth factors and the stimulation of bulb cells, the stimulation of stem cells in the hair bulb area. So at the insertion of PDO thread set, there is increased capillary vessel. All these changes are not studied histologically. So where is the role of these scalp threads? So we have different basket of treatments. So where is the role of these scalp threads? Who are the ideal candidates? So whenever a patient can't afford to come for multiple sessions, like for a PRP or with mesenchymal stem cells, so scalp threads are a single session treatment which provides a continuous low-grade inflammatory stimulation of the scalp area with influx of inflammatory and growth factor regions. So it acts as there are comparatively results have shown that single session of scalp threads have given equivalent results to multiple sessions of PRP application. So whenever a patient can't come to afford multiple sessions, this gives better results. So the expected results are new hair growth, thicker hair texture, reduced hair loss. Within 12 weeks, noticeable changes are seen. So this definitely I think has a role in the therapeutic basket. It acts as one of the treatment modality. Thank you.
I now invite Dr. Smita ma'am to take over for the presentation.
Good morning, everyone. Thank you, Cuticon, and thank you, Sudha ma'am, for having me here today. Every coin has two sides. So Dr. Josna has beautifully explained her side of the coin and left a very small window for me to describe. So today we are talking about PDO threads, either boon or a bane. Coming to complications, I would directly go to the complications because these are in detail. Immediate complications and side effects, they occur in first 2 weeks. Pain and discomfort. As usual, mild to moderate pain, swelling and soreness can be there. Bleeding and hematoma can be there. Infection, bacterial and fungal can be expected. Allergic reactions, immediate hypersensitivity reactions can happen. Thread visibility, yes, threads given very superficially can be visible and they may have to be removed sometimes. Short-term complications and side effects which last from 14 days to 30 days. Inflammation and redness, mild to moderate can be there. Swelling and edema can be there. Thread migration, threads given at one site can be migrated to the other side resulting in complications. Hair loss, if not suited, the temporary hair loss or shedding at the insertion site can be seen and could be distressing for the patient. Long-term complications and side effects, 30 days to 1 year time. Scarring, formation of scars or keloids at the insertion sites can be permanent. Thread breakage can happen which can lead to inflammation or a reaction. Foreign body reaction can occur. Hair follicle damage can be permanent and a long-lasting complication. Rare but serious complications can be nerve damage or infection spread. Coming to the main point is histopathological changes in the scalp. In the acute phase, as doctor has already explained, there are certain inflammatory changes characterized by infiltration of neutrophils, lymphocytes and macrophages. Edema and hemorrhage can be seen in the acute phase, that is in the first 2 weeks. Subacute phase, 14 to 30 days. There is a granulation tissue formation which starts, characterized by proliferation of fibroblasts. This is important. Vascular endothelial cells and inflammatory cells. There's a lot of collagen deposition. Initial deposition of the collagen fibers can lead to tissue tightening. Thread encapsulation. So beginning of the thread encapsulation by fibrous tissue starts by the first month. Chronic phase, 30 to 90 days and beyond. So there is a mature fibrosis characterized by dense collagen deposition and a scar tissue formation. Thread integration, complete integration, which starts from the 30 days, it's completed by the 90 days. And potential changes in the hair follicle morphology such as perifollicular fibrosis or inflammation can be seen. So what next? All the mentioned changes happen every time pedio threads are done on the scalp. And average number of threads inserted every time is 20 to 40. So in 20 to 40 points, these changes keep happening. And average number of sessions, initially they were little earlier. I mean 3 to 6 months, but yes, now better threads, so they are being placed little apart. Such repeated injury to the scalp may lead to permanent cellular damage in the done areas, leading to cell death over a period of time. These are a few articles. It was very difficult to pull out articles for this topic. So these are a few articles which I could pull out to conclude with the key points. Thread-induced fibrosis. The authors note that thread lift treatment can cause fibrosis, making it challenging to dissect the recipient site during hair transplantation. Difficulty in assessing the recipient site. Thread breakage and fragmentation. The authors warn that threads can break or fragment during the hair transplantation, causing inflammation and potentially affecting the outcome. Impact of the hair on the hair growth. The article also discusses the potential impact of thread lift treatment on the hair growth, including the risk of hair loss and scarring. So to conclude, the article concludes that hair transplantation after thread lift treatment can be challenging and it requires a careful planning and execution. So I would like to end with the point that pedio threads on the scalp can be a boon or a bane. It's not always that we can look forward for the good effects, but also down the line, multiple times injury can lead to a permanent cell death. So these are the references. Thank you.
So this was an innovative session where the moderator is also supposed to present. So it's a very short session. There was a movie scene where the Munna Bhai MBBS, where the Sanjay Dutt goes into his MBBS hostel and then the chota fellow says, "Ye room kitna hai? Shuru hone se pehle khatam ho gaya." So I am also in a short run, so I'll just finish off in 3 minutes. So the whole thing is the treatments they're given as a ray of hope as well as a skepticism. So, but what in practicality? How many people we are seeing are mostly non-responders? Am I right? In hair transplant or in hair care. So in that patients, so would you like to use 5 and 10% versus oral minoxidil? Just a quick points.
First always I use 5% and 10%. If not responder only, I will shift to the oral minoxidil. Topical minoxidil is always my first choice.
So you like to use 2.5 milligrams once a day or twice a day?
Once a day 2.5 till I didn't use 5 mg. I am 1.5 2 mg also we can start, but 2.5 mg is the conventional which we are using.
And I have started with 1.25 mg only, sir, in females to begin with. In males, yes, I did put 2.5 to begin. Updosing I've done only in a lesser population. Most of them were comfortable with these low doses.
Okay, so do you prefer that in the nighttime dosage or in the morning?
In the night times, essentially night
So
time.
did you see any overgrowth in the other areas?
Hypertrichosis certainly was there, sir. But in females, as I said, even my patients were comfortable to go and do an LHR for it.
Anybody has
one of the important side effect which I want to tell is increased chest tightness has seen in oral minoxidil in 2 patients. So that also should be kept in mind.
Correct. So anybody has used in combination with oral dutasteride or finasteride?
I have been using both topical and oral minoxidil because this is a rat race nowadays. Everybody is so busy. When they travel to other places, they don't like to apply. So at that time, I give them oral minoxidil and patients are happy.
Okay. So
One more point I want to add, Rajkirti. As we have seen the studies, we have seen that oral minoxidil has more effect on the vertex area compared to the frontal area. So probably I feel combination. So sometimes we can limit the application topical to the frontal and along with the oral also. That also gives benefit.
So minoxidil sulfatase has been a new buzz. So in case if the minoxidil sulfatase deficiency is there, do you think the oral minoxidil will work for that?
It has been proposed that it's majorly metabolized and using the liver sulfotransferase. It is going to circumvent that.
Okay.
I advise why, because nowadays few patients are asking, I want to know about minoxidil potency test. So we cannot deny that we need to do the test. If it is deficient, directly we need to go for the oral minoxidil and try rather than going for the minoxidil. Because nowadays IT patients are coming and directly asking, I want to know the minoxidil potency test.
Okay. Do you think compliance is a better thing for oral minoxidil? Do you educate the patients for the...
So far, yes.
Okay. So since my time is coming to an end, so I'll just ask, this is an interesting hypothesis. Scalp PDO causes neocollagenosis and neovascularization. Microneedling causes neocollagenosis. So neocollagenosis in scalp is equal to hair growth. So are we equating the same way? A is equal to X, X is equal to Y, so A is equal to Y. So are we doing the same thing for the scalp PDOs?
You mean to say comparison with the roller?
Anything.
No, basically scalp threads I have.
My question is very simple, ma'am. How is collagen going to help for the hair growth? Because we do microneedling for acne scars and fractional CO2 also for the acne scars. But there we don't see any amount of hair growth altered. Neither you see the increased beard hair growth, neither you see any kind of decrease of hair growth. So how is that impacting on the scalp?
Basically, it's the influx of the inflammatory cells and the growth factor release compared to the other factors, I feel, which provides a continuous stimulating pattern in along with other topical minoxidil and other preparations, and that too only for grade 1 and grade 2 people, not people who have already fibrosed scalps.
Okay, in which kind of grades of alopecia would you like to advise for scalp PDO threads? Grade 2, grade 3?
Yeah, grade 2, grade 3 or just avoid, but who can't come for multiple sessions, particularly NRI patients who are here for a short term. So they want some therapy. I advise these things for those patients as a single session.
So NRIs for short term therapies, then you can do that. That's the point. Anyways, so do we think about this in any kind of cicatricial alopecia since we're talking about collagen regenerations? Have we found any evidence on that part?
No, little skeptical.
No. Okay. So since I'm running short of time, so I'll end my session here. All the speakers have presented very well, both sides of the story. I thank the speakers and also I thank the chairpersons and the scientific chairperson to give us the opportunity. Thank you.
Thank you Rajkirti sir for wonderful moderation, and thank you Madhusudan sir, Divya ma'am, Josna ma'am and Smita ma'am for giving your insights. Thank you so much. With this we can just conclude that better to tailor the treatment according to the patients and based on your experiences. Thank you everyone.
That was an interesting session. I request Dr. Rajlakshmi ma'am and Dr. Chandravati ma'am to hand over the mementos. Moving on to the next session, session 6, which is Devices and Complication in Aesthetic Dermatology, Conversations with Clinicians. I would like to invite Dr. Debian Murthy sir, who is a senior practitioner in Hyderabad since last 4 decades, and Dr. A. Durga Prasad sir, who is a senior dermatologist and managing director at Dermacare, Hyderabad.
First of all, thanks to the EC team of Cuticon 2024 for giving us this opportunity to chair this session. Now I request Dr. Ganesh Espai, who moderates this session, to the dais. I also call the panelists Dr. C.V. Madhuri, Dr. Vimala Manne, Dr. Madhavi Pudi, Dr. Nishant Jain, Dr. Sushant Mukka, and Dr. D. Saujanya. Please, all of them, come on to the dais to start the session as early as possible.
Thank you.
This topic for the session should have been devices and complications in aesthetic dermatology, conversation with the clinicians. It should be with either dermatologists or aestheticians. Clinicians means, I think it's little improper. And Dr. Ganesh Pai doesn't require any introduction. He's a very well-known dermatologist, aesthetician, cosmetologist, whatnot. Half of the people who are sitting here are not born when he started his practice. He's such a senior dermatologist in our country, and he's the greatest clinician, and we should know the art of practicing dermatology through him. He is master at it. I request Dr. Ganesh Pai to go ahead about moderating the session.
Thank you, Dr. Murthy and Dr. Durga Prasad, and the famous trio combination. Dr. Somani is there. I wish he was also here. We will now, you see, this particular thing, I have brought up a couple of, we'll wait till. Okay, now that we have a little silence, I'm going to put up case here which has baffled me and troubled me. So it's not that I have the answer. And this is a very typical patient. This is a man, show his picture, yeah. This is a man, I'll show you these three pictures. Can you have these lights dimmed a little, please? Intense pigmentation on the nose and intense pigmentation on the cheeks. And this has been going on for the last several years. He's a very high-placed IT officer in a very big company, travels abroad a lot. He is about 120 kgs, is about 5'7" or so. Excellent cook and has a great appetite, so that's another major problem. He's not able to control that. So how would you go about this? You know, he has had an angioplasty 4 years ago during COVID time. So how do you go about managing this? So would you, the panelists, please give me an opinion on this. Apart from the dietitian and apart from what devices would you use? Madam, we'll start with you. Please give her a mic. Yes.
I would like to do the laser toning, sir, like it is apart from... there is
I
a
did that. I did all the laser toning for what it's worth.
Oh.
He is among the top 10 in TCS, okay, worldwide. He's a very big name.
Okay.
Yeah. So I did that for him, yes.
And
it did work.
The next thing I would like to do a fractional CO2 with a combination with laser.
I did that too. Did work. In fact, all of that came back good.
And then number 3, TCA peel.
You did, I didn't do that. Next, you.
Same, I think, mostly the answers.
Good. Yeah. Feel free. I mean, even anybody in the audience has a better opinion, do this. Because these are the bugbears of, I mean, you can practice for 100 years, you know. But then you get these people with flaring pigmentation, extreme pigmentation in the face. And he started about 15, 20 years back. He's around 48 now. Next.
I too prefer to do peel, sir. As you have done everything and it's coming back.
The skin was also quite thickish. So really the peel, in fact it had peels earlier and it had led to worsening of the pigment. Yes, Bimla.
Sir, actually, did you start him on metformin and things like that, sir?
I didn't start him on metformin. He is with his physician who's been treating him and all that.
Yeah, because if it's not responding, because lasers will help to some extent. I feel it is a metabolic syndrome, so definitely if he's on metformin, the lasers would have made some more difference to this patient.
So he's diabetic, mild diabetic.
So it's looking like a facial acanthosis nigricans, sir. So definitely.
Nose was intense, everything yesterday, except that he's been looked after by everything.
Yeah, because I feel that phenol peel with TCA and metformin would have helped apart from doing erbium YAG laser, because erbium YAG.
He's had TCA peels elsewhere in Mumbai, even in Netherlands.
But without medical management, any kind of laser peel wouldn't help.
I've been telling him that, everybody is telling him that. The point is an extremely busy man with several thousand people under him and a great cook also and with a great appetite. So he called very difficult. Yeah, next, yes please. You have anything?
Medical management,
Yeah.
then along with that, we would advise lifestyle changes, but just like you mentioned, if it is not possible, I would go with fractional CO2.
You did well, I did that. I did the ultra pulse on him on 2 or 3 occasions. All right. You see, he's a good friend of mine too, my son. So I said, look, I'm going to experiment on your face since you've been around. You've tried everything. He's game for that. I didn't charge him a rupee. I made sure he made a very good dinner for me though. He's an excellent cook. So I'll tell you what I did next and surprise. Do you have anything to answer? Well, what I did essentially is, having tried everything, I said, let's burn this skin off and let's see what happens. He was willing for that. So I will show you the pictures here. The pictures don't look so clear, but when he talked to me, essentially what I did was, I did an IPL. I used, I've done all the lasers and all the devices except the IPL. So I did an IPL, the M22 615 filter, the fluence of 12 joules per centimeter square. And believe me, he is better by 75%, he says, because the skin actually burnt off. For the first 5 days, he did it and flew off to Netherlands. He says for the first 5 days it was terrible. I'll show you one picture of what happened. This is the cheek, and you can see the nose. I did on the nose, that piece, it got depigmented because everything flaked off. All the skin on the cheeks, all the skin on the nose flaked off dramatically over 5 days. He kept showing pictures, and then thereafter, he says the nose hasn't improved much, but the cheeks have improved dramatically. So this is the picture.
Sir, but you got very lucky, sir. You got very lucky because it would have developed post-inflammatory hypo or hyperpigmentation in other cases.
He got lucky, not me, because he knows me so well. He says, sir, try what you want. And I said, okay, this is the only thing left. We have tried the lasers, we have tried the peels, the salicylic, glycolic, you name it. We've not tried this, let's see, because the IPL, so what I'm trying to say is, if you have a patient with intense pigmentation, this is not moderate, intense, it's like boot polish on the cheeks. You have a patient with intense pigmentation, I think you have an opportunity at least to do a test spot on a patient with IPL. This is the filter I use. The machine guides you to the filter, and the patient is extremely happy. In fact, he says it's happy. improved even more now. So this is a difficult case, and I'm sure all of us get these kind of patients. So finally, go for the old-fashioned intense pulse light. You never know. If it works wonders. Of course, you need to have a patient who is receptive to a little experimentation and says, "Doc, I have nothing to lose. It's already so dark, it looks so bad, I'll try it." Okay, so remember that. So this is the lesson I learned just about 4 months back. After having all the devices in my office, this is what I use. All right, the second case was interesting. This is a guy, he's a doctor, and he flew in from Nagpur. He had ILVEN, inflammatory linear verrucous epidermal nevus. The problem is, since childhood, he's hardly been able to sleep. He's around 38 now. Burning sensation, irritation, and extreme misery. He says, "I can't even sleep on my head." He had tried. So what would you do? Would you start with this?
CO2 ablative.
You do he has had 3 rounds of CO2 in Mumbai and elsewhere, and it all bounced back. Absolutely bounced back. He says, "The CO2 I did." The book says CO2 is the treatment. Yes, sir. What about you?
CO2 ablative.
You also did the CO2, and you will ablate it substantially.
Yeah.
Because in these kind of things, you're not looking at cosmetic. He says, "Sir, I'm not, it's in the back of my neck. I'm not looking for any cosmetic care. I'm just looking to make sure that I get well and and I can sleep well." Yeah, madam, yes.
First option is fractional CO2, sir. People who don't have can go with even radio frequency, but the chances of scarring will be there, so you have to be little careful if you're doing radio
He was
frequency.
not bothered about scarring. He says, "Dr. Pai, please scar if it's required. I don't mind. It burns me so much that often I sit up the whole night with pain. Just want to do anything you can." So this is yes. What about that? Anything beyond CO2, madam? Anything else you have to offer?
The RF, what she said, we
Okay,
can ablate it.
that's a cousin of the laser. Yeah.
Plain RF also gives good results. In this
It does not. He has tried CO2 3 times, and it's very well known that the option that if you do not do a CO2, see, CO2 is fine if it's fairly superficial and the lesion is small. But if the lesion is extremely large, even grafting is, you can have an excision followed by grafting. But if it's extremely large, even that's very difficult. You see, these are these typical reddish papules, they look warty actually, the typical reddish papules. It was in the back of his neck as well as his ear and into the hair zone also. Madam, do you have anything?
We can try even IPL vascular mode.
Okay, what did you do?
No, sir. We can try.
No, I didn't do the IPL for this, I tell you. Go ahead.
Radio frequency, RF is better.
You do the RF, yes. Failed. CO2 failed, RF failed, cautery failed. It all came back. He says, within a month of finishing the cautery or the laser, it pops back with increasing intensity.
Sir, did you try pulse dye laser?
I will tell you later what I did.
An excision of it.
Don't ask me what I tried. Tell me what you would try.
All failed, Ganesh Pai sir.
You are here for that.
Pulse dye laser.
Well, I'll tell you what I did next. Okay. See, I'll tell you what happened for this patient. I did the CO2. See, I did a fractional CO2. I said, okay, I'll give it one more shot. Let's do the fractional CO2. So I did the fractional CO2 in this patient. And at the end of that, he came a month back from Nagpur, just as bad, in fact worse than before. He says, "Sir, it's burning even more." And it's more. So that was the 4th attempt after 3 attempts elsewhere. And so then I said, okay, let me go on. And we injected about what, 30 ml of lignocaine. I called an anesthetist. And then what I did was I used a long pulse Nd:YAG laser. I said, okay, we'll do a small test patch with a long pulse Nd:YAG 1064 because it essentially targets vascular tissue. Since this looked erythematous and there obviously was an element of vasodilatation, I said, let's take a try at this. So after I did the long pulse Nd:YAG laser, this is what it looked like. And then I did the whole thing with it when he came because I'd done that. Look at what I did. I actually destroyed the tissue there. He said, "Dr. Pai, go ahead and finish it off. I am so miserable." So you can see on the left the ILVEN, and then you see what it looked like soon after I finished the 1064 long pulse Nd:YAG. And then you can see this picture 2 weeks later. It looked like a mess, but it healed extremely well 3 to 4 weeks later. And this is what it looked like. You see the start, the redness. You can see how bit by bit the patient improved. And today, 6 months later, the patient sent me this picture. He sleeps very well. He's extremely happy. The only modification in his life now, he's got a high collar shirt so that that scarred area is not seen. Grown the hair a little long so that it covers the whole thing. And therefore, the lesson I learned in this was, nowhere in the book does it say use a long pulse anti-aglazer. I never seen that. So I said, okay, let's give it a try. After all, I have now reached an age, somebody said, but half the people are not born here and I started, you're right. Maybe I'd go to 60%, not even half. To the extent that I sometimes have a youngster asking me, sir, why don't you stand for IADBL national president? And I was president in the year 2000, 25 years ago. And these people were in school at that time. And therefore, you even have that. You see, I belong to that last generation of dinosaurs, which is still coming on the stage and speaking. And so I said, okay, just like in the previous patient, I said, I burnt it with an IPL to save him. I said, let me try the long pulse NDAG on this patient. It worked brilliantly. So the message I'm trying to bring you is that ill-when patients will come to you. If ill-when patients or somebody with this kind of thing comes, you do a long pulse NDAG test patch and see if it works. It worked for that chap, the test patch, because I had done it along the CO2. After that was over, the man has enormously relieved now, extremely grateful. And you can see now, though the area is scarred, this last picture, of course, he sent on his mobile. The first 2 pictures are taken in my studio, in my clinic. This is on his mobile. You can essentially see how well it has responded. There is no ill-when left there. So these 2 separate messages. Now, for the third one is, this can lead to a lot of struggle, fighting, and yeah, here's a patient with under-eye dark circles. So this is no man's land. Though it's a woman, it's a no man's land right now. So go ahead and start from what? Yeah, you start. How are you going to... See, every answer here is the right answer. And simultaneously, every answer also becomes the wrong answer, because most often we end up with hardly any difference. I think the real success in doing an under-eye dark circle in most cases is, patient, you do the procedure, patient comes back and says, doctor, I am so much better, and you know it is not better. That is ultimate cosmetology, and you don't fight with these patients. You agree with them. It says it's improved? Yes, say it's improved. Even though you know it's not improved. Yeah, so tell me, what are you going to do with it, starting with you?
So there is a thickness of the skin and the pigmentation, so I'll start with the milder chemical
She's
peels.
about 21 years old.
Okay, I'll start with the mild chemical peels, lactic acid and arginine peel, and then with the corneal shield I'll do a laser toning in that part, and then those 2.
Okay, in sequence, you will first do the
First
peel.
do a chemical peel, a couple of sessions, and then do a laser.
Placed how much apart?
15 days apart.
15 days apart.
Yes.
And when do you do the laser?
After a month we'll see the
After
response.
a month you'll do this. So you have 1 or 2 month recipe for that. And what do you expect to see? Improvement or moderate improvement?
A moderate improvement.
You expect to see moderate. What about you, ma'am? Next.
So lifestyle changes and investigations, everything will be advising. And along with that...
What lifestyle changes? She's fit, she's smart, she's a college student.
Some of them usually have the habit of rubbing their eyes. So atopic individuals, so we advise them not to rub their eyes. And straining of the screens, that also plays a role. And vitamin deficiencies.
She's a college student from Chikmagalur. Okay.
So depending on the budget of the patient, we can even advise hyaluronic acid fillers.
Budget? Big budget share. She's a coffee estate owner's daughter.
We can do fine fillers.
She can give a whole estate, she says, for this. You get her on the pen.
So we can do fine fillers, hyaluronic acid fillers.
You do a HA filler, okay. So please, enlighten the audience on the HA filler, because this is important. And fillers do actually, because of the Tyndall effect and because of the filling of the structure, the filler actually helps. So would you please elaborate a little more for the benefit of the audience?
Definitely the hydration component will be improved.
Correct.
And because of that, it gives the lightening effect. It gives
Correct.
the pulling effect and gives the shadowing will be reduced.
Correct. Yes, sir.
And carboxytherapy also have tried in few patients.
Fat grafting.
No, sir. Carboxytherapy.
Carboxytherapy. the age is not a criterion for that. That's okay. 21 is fine for you. Okay.
Sir, I do the fillers and laser in the same session itself. First
She does peel followed by laser.
Sorry,
do
sir.
filler.
No, sir, wait, sorry. I do peel and laser session in the same session, both of them.
Yeah.
I do first peel and then followed by the Q-switched NDAG laser session. And after few sessions, I'll take up the patient. Once I feel that whatever result these things have given, then I go for the filler. Once we have put the filler, we can't do the...
This is essentially throwing the kitchen, everything in the kitchen at the bowls, the utensils, the spoons, the ladles, the vacuum, the mixie, everything you throw at it and hope that something connects. This is a major, all of us have this problem. And therefore, yes, Vimala, I think you have a different answer.
Sir,
you usually have a different answer.
No, sir. Actually, doing all together, something or the other works. That's how Dr. Sakya's learning also actually for periocular melanosis.
People from the west of this country, Gujarat and Maharashtra, are so used to the bhel puri. Everything is mixed together to find a great dish. We in the south don't do that.
No,
so
sir,
Sakyas is the
actually-
bhel puri theory where you put in everything.
Sir, for periocular...
That also makes sure that the next dermat the patient goes to can't do anything more. सब कुछ कर दिया है, पर क्या कर सकते हैं, no?
Sir, for periocular melanosis, bhel puri is the right thing, sir, to address because she has...
So, okay, you tell me how you mix your bhel puri different from their bhel puri.
Sir, I do...
Not me, them, the audience wants it.
So because we are all failing and you are passing every time, sir, that's why I'm looking at you.
I am not passing, I am deflecting.
Basically, it's there is a pigmentation, there is thickness, there are fine lines, and there is a tear trough. So there are all elements in this case where we have to address each and every thing.
Right, you're right. So there are, actually, it's not just the pigmentation, there are also fine lines. You're right.
So addressing every layer has to be done with a different modality of treatment, finding whether it is a true melanin or not, or whether it is metabolic syndrome again, because there is a lean PCOS people who have this kind of thickness around the eyes. So
Yeah,
suddenly
that can perhaps be checked. Yes.
that has to be checked and then addressed with oral medications.
I didn't do that. That's something you didn't do.
Yeah,
All right.
and definitely do a peel, laser, filler on the same day.
You do the peel, laser, so peel morning, laser afternoon,
No,
filler
sir.
evening.
Same time, one after the other.
One
sir.
after the other.
Yes.
Okay. So how much
So that
time?
they don't go back to you.
Okay. Yeah, I was asking for this.
I would like to
Dr.
rule out.
Narsivram, this is becoming very entertaining. It feels when she speaks that I have a clinic in Hyderabad. I am in a small town, madam. I am in Bangalore. Very, very safe. Yeah, okay.
I would like to rule out atopy, sir. Then
No, there is no atopy. She is otherwise in good health.
then peels and filler would do.
Her mother also had dark circles. This is another question normally. When these girls come, you ask them if somebody in the family has, okay, and the mother also has dark circles under the eye.
Peel and filler would do, sir.
You do the peel. So, is there any difference you have, anything you want to do?
Maybe combine a PRP.
You'll also do a PRP.
Yeah.
Yeah, so she had been to Bangalore, she had been to some big aesthetic clinics, quite desperate, and having tried everything, she came to me. So I said, anyway, this IPL machine is in my clinic for an extended period of time. I said, look, I will try this on you, it can't get worse, it's pretty dark. I said, she agreed with that. Okay. And I did the IPL, 3 sessions, the 590 filter at 12 joules per centimeter. I can go up to 25 joules, but 10 joules is the minimum. So I did a 12 joules per centimeter square. I did M20 to the 590 filter. The previous one was 615. The machine selects the filter. It's not that I look at it. When you feed in the parameters, the filter comes, and I did this, and she has had extremely good improvement. And within 3 sessions, she is down by around 60 or 70%. You can even see that the wrinkles and grooves have come down. The pigment has come down substantially. So I was able to do this procedure in all these 3 that I've seen. What is the common thread? Everything else had been tried on them. And I said, I often have in my career from year 99 when I picked up the first laser, and I became known as the father of laser industry. And then by 2015, people started calling me the grandfather of laser industry. It's come to that. And Rekha had said that to me, you are the grandfather of laser. And I said, madam, then who is the grandmother of cosmetology? And after that, people stopped saying that. So this is the thing I use. So if you can use an IPL, go ahead and use an IPL. Okay, so I will come to my last slide because I will save time here. And that is I always end my talks with some philosophical quote. And this is this. When I planted my pain in the field of patience, it bore fruit of happiness. So in our careers, you have to plant your pain, the pain of lasers, devices, where the results have not been good, where we have been uncertain about how to treat patients, where we have had conflicting thoughts about what device to use, because the average clinic now has half a dozen devices. So you plant your pain, and over a period of years, make it the field of patience, and eventually you get your rewards. Patients get the rewards, and we are able to share these things with people in the audience here so that your patients are better attended to and better managed. And that is how you bear the fruit of happiness. Thank you very much. We are done. I've saved you 7 minutes of time. Thank you.
Thank you, sir, for a wonderful, entertaining session. Thanks to the panelists also.
Thank you.
We thank the organizers for giving us this opportunity to chair this session. Thank you.
That was quite an interesting session. I would like to invite Dr. V.K. Sumani sir and P. Narasimha Rao sir to hand over the mementos. Moving on to the next session, session 7. So before that, I would like to inform that we will move on to session 8 after session 7. We are running short of time, so we won't be able to break into a lunch break. For session 7, I would like to invite Dr. M. Shashi Rekha, ma'am, a senior dermatologist at Diksha Skin Clinic, Hyderabad. Dr. Vila Lakshmi Kumari, ma'am, founder and CEO of Dr. Lakshmi Skin and Hair Clinic, Miapur. Dr. M.A. Rehman sir, Associate Professor, General Surgery, Usmania Medical Hospital. Also the judges of chairpersons of free paper session 3 are Dr. Shilangi, Dr. Ashwini and Dr. Manvi. Chairpersons Dr. Praveen Kumar sir, Dr. Harika and Dr. Vibhu to collect the mementos.
Hello, good afternoon all. Today I would like to invite Dr. Deepthi to give her a talk on AI in dermatology, boon or bane.
Very good afternoon to one and all. When Dr. Sudhavani ma'am asked me about this topic, that was my first reaction. Because when it comes to technology, I'm like this, not like that flower, but like that droplet of water, which goes around irrespective of what the technological happenings are happening around us. And when it comes to anything which is
intelligent and not human, I'm very skeptical. Maybe not to the extent of this. And this is the closest to AI which I've actually got. I think all of us have got there. So for this session, I had to do a lot of unlearning and learning to delve into the depth of artificial intelligence from the real world. So technically, what is AI? The scientific understanding of the mechanism which underlies thought and intelligent behavior and their embodiment in machines. So before we move into AI in dermatology, a very quick look at what is exactly AI. So there is conventional AI, something like an algorithm where we give inputs and it gives an output. And then when there are layers of this AI, the layers of algorithms, then it becomes machine learning in which 50% is by the human and 50% is by the computers. So this is where things are moving right now. But if we move towards deep learning, there are a series of convoluted neuronal networks, almost akin to our brain, the neural circuits in our brain. And these machines are capable of quite a lot. So I won't be going into the details of the type of AI, but here I would like to draw your, thought towards the natural learning processing. See, we do the voice to text, text to voice stuff. We are actually using AI because AI can actually be helpful. It can be quite helpful when it comes to understanding big data. And robotic processes is something which, it is being used already. Now the question of why AI in dermatology? Because basically dermatology, we have a lot of clinical images, dermatological images, dermatoscopic images as well as dermatopathological images. And what AI does is photo recognition algorithms and numerical values. And in dermatology, it's growing by leaps and bounds, and now there is interplay of digitalization, telehealth, as well as informatics. So there are a lot of studies, and most important of all is the role of AI in skin cancer detection as well as in dermatopathology. I won't be going into the details, but for atopic dermatitis, in 2017, basically AI was used. The algorithm had a very high positive predictive value and sensitivity when it comes to individualized treatment for atopic dermatitis. In psoriasis again, it basically focuses on image recognition. So a response to biologic therapy is something which AI has played an important role. And in ulcer assessment, there is a very good AI can be employed, especially in diabetic and pressure ulcer, because this margin of the ulcer is something which can be taken a clear up picture, and these micropixels can be actually looked upon by the AI, and it is much more sensitive and specific. So to predict, as a risk prediction tool, AI really helps. Now in onychomycosis, deep learning was used to do in a study by Hans et al. And you can see the sensitivity and specificity of this AI versus the regular dermatologist was almost 82.7 to 96%. So onychomycosis is something which AI actually outnumbered the dermatologist. Now, a lot of other uses for AI, like in predicting skin sensitization, so basically which can be a sensitized substance, these studies were done. And the most important of all is AI in skin cancer detection. So this is an interesting study which was done in 2017 at the Stanford University, and a deep learning network was used, and it was a head-on-head trial against 21 board-certified dermatologists, and they found that compared to this dermatologist, the machine found out early malignant melanomas and seborrheic keratosis. There are a lot of studies when it comes to skin cancer detection, and this is again deep convoluted neural networks. We are not talking about the moderate AI, we are talking about highly advanced machines. And further studies again, these are easily available. We can all look anywhere into the internet. But coming to smartphone apps for skincare detection, it can give a false sense of hope for some pictures. Especially what happens is in skin of color, the pigmentation, the quality of the picture is different, and we require very high quality images to actually look into this kind of high-end technology. In dermatopathology also, AI has played a very good role. You can see a convoluted neuronal network has a sensitivity, specificity of accuracy of almost 76, 60 and 68% in comparison to pathologists. So there are a lot of other things in which AI really makes a lot of difference, and there is an evolving branch. And natural language processing can actually be used based on the patients. We in dermatology talk about quality of life, and based on the online algorithms can actually track what the patients are using, but of course there are data privacy issues here. And this is a lovely paper. Those who are interested in AI in dermatology can go through it. A lot of other papers. Now why are we talking about AI? Because you can see the future of AI market is really high. It's almost growing 35.5% fold every year. So by 2030 you can imagine what the number is. And there is a lot of scope for AI in healthcare analysis, precision medicine, predicting disease and illness, and interpreting tests and diagnosing disease. And these are the current trends. Beyond dermatology also there are a lot of apps, a lot of robotic surgeries being done. So now we boil down to the same question once again. What about AI in dermatology? Is it a boon or a bane? AI can definitely be used by us as a friend to aid in improving our decision making when it comes to diagnosis, giving a personalized treatment plan, as well as predicting survival outcomes. And the future of AI, apart from the opportunities, there are a lot of challenges. A lot of collaboration is required, and between the doctors and the dermatologists as well as the computer science guys, there's a lot of ethics involved and a lot of privacy issues. And if we go by the godfather of AI, there was a sensational statement by him that AI could pose an existential threat in the next couple of years. So now it is important for us to understand that it's not artificial intelligence versus the humans. It can actually be artificial intelligence with the humans. But of course, AI is not perfect. Just like us, even in AI, there are AI hallucinations where the algorithm, when it does not get the right set of data set, it actually synthesizes its own images. So these are some things which has to be done. Now that we're coming to the end of the session, I would like to ask you, do these names ring a bell for anybody? Alan Turing, Alonzo Church, and they are the two people who have developed the first algorithm in history of mankind. And John McCarthy is the father of AI. This, I guess, is equally easy. Can anybody please guess from which movie is the last picture? Anybody? The iconic pose of AI, which we all saw, probably were during our post-graduation. My alumni there should be able to tell. It's Keanu Reeves. Okay, anyways, thank you so much. I should give a special thanks to this guy, my son, who did the PPT for me. But he did it in Canva, and after it got downloaded, all the fonts went away. So I'm not going to show that to him again. And Dr. Somesh Gupta, he had given me a lot of insight into the literature review. And as it comes with AI, the last picture is from yesterday night, Vande Bharat. So my co-passenger, he's doing his computer science in BITS Pilani, and we had a lovely chat till 11 in the night trying to understand AI and dermatology. Thank you so much.
Thank you, Dr. Deepthi. That was a fantastic presentation, and you have enlightened us with the AI in the dermatology. So the next speaker is Dr. Monita, and the topic is Peerless Peptides, a demo of biomimetics peptides of hair growth.
Good afternoon, everyone.
The peerless peptides research recognized revolutionary product QR678 Neo. Yeah. So we are facing 40% of the normal patients are not responding to conventional therapy. 54% of females normally have this alopecia issue and also 68% of men. So where and when I start using this QR, when the conventional treatments are not responding, definitely QR is my savior. The pitfalls of conventional treatment is because of unpredictable and variable results, lack of evidence-based scientific research, time-consuming medical and systemic side effects, invasive treatment procedures. The novel invention, overcoming these barriers and challenges and uncertainty, first-in-class hair regrowth therapy, a revolutionary procedure. Rigorous, ripe and rewarding journey of research and development, multiple milestones achieved over last 16 years. There comes the landmark of event like award of US patent and also Indian patent and Indian FDA approval of manufacturing and sale of QR happened in 2019. So now it is a crowning glory, dual patent India and US patented, and it is. So what is the special about this QR? What are the formulations? They are nothing but human synthetic polypeptide 9 and polypeptide 1, oligopeptide 2, copper tripeptide. All these peptides are human synthetic peptides are doing wonderful job. They have multiple activities which are specific and all are there. All of them act at different stages of the hair cycle. That is the reason why they have multiple indications where peptides are working wonders in the clinical practice. The polypeptide 9 acts at the stimulation of hair follicle by inducing angiogenesis. Polypeptide 2, dermal fibroblast mitogen, anagen phase stimulation and maintenance of inhibits apoptosis, and copper tripeptide inhibits 5-alpha reductase, where this is the specific growth factor where it works for androgenic and female pattern baldness and reduces inflammation. Because of this inflammatory response and cytotoxic insults, it is also effective in seborrheic dermatitis conditions also. And oligopeptide 4 stimulates the stem cells and increases the number of keratinocytes. Because of this specific stimulatory sustained action of this growth factor, we have multiple indications with QR. We'll see a video on the last. 13 continuous research has been happening since last 13 years. The first one is like animal study for safety and efficacy, and second was for 1000 patients of androgenic alopecia, and it has a comparison study with monotherapy and combination therapy, and QR versus PRP, we'll discuss in detail, and also an alopecia areata, chemotherapy induced alopecia, COVID-19 induced erogen ephraim, not only COVID-19, acute and chronic erogen ephraim conditions, psychological impacts of hair loss, PCO related problems, and also seborrheic dermatitis and QR. Intradermal and derma-roller injection comparative studies. In all these papers, I have been using QR since last 8 months, and I am using this QR on 35 patients since last 8 months. Out of 35 patients, 15 to 16 patients are androgenic alopecia, and 10 to 12 patients are female pattern baldness, and 5 patients are of chronic and acute telogen ephraim conditions. And also I started using on seborrheic dermatitis patients who have this itchy scalp condition with scalp psoriasis along with androgenic alopecia. After trying multiple conventional treatments, I started using this QR, and it's a savior in my practice, I can tell. And results are very much consistent with the results which you see here. And the QR versus PRP. We are all great fans of PRP, but I am not a great fan of PRP. I don't use PRP as a continuous therapy every month, PRP along with minoxidil and finasteride. Whereas now after after getting this QR, I started using monthly once therapy of QR, monthly once like 5 to 6 sessions without any between microneedling, any other sessions. As a monotherapy also I started using in recent times because people are not ready for compliance for minoxidil and finasteride. There also results are definitely good. So what is the difference between PRP and QR? Where the QR is like new age therapy, ready-made solution, contains only stimulatory growth factors. Why we have variable results in PRP? Because of their inhibitory and varied concentration of growth factors. And PRP is a 40 to 45 minutes procedure, whereas QR is 10 minutes procedure. And consistency is variable, whereas the results are consistent. They are consistent even after 8 sessions. For next years also they can just continue with that. May or may not be optimal, the results are optimal. And pain and inflammation definitely no, absent. So these are the inhibitory factors which are making the PRP giving variable results in different patients. Yes, I have used for this QR for acute telogen effluvium conditions for 4 to 5 patients, and including me. I am also a patient of acute telogen effluvium along with female pattern baldness. I am on my 5th injection. After 1 injection, I have 50% decrease in my hair loss, and after 2nd injection, I have seen 25% decrease in my hair loss, and later, after 3rd injection, I started seeing thickness in my hair along with my patients. These are the few pictures. Few pictures are from few patients, and this is from my patients, and also a company provided these pictures. Before and after results, this is after 8 sessions. So revolutionary, negligible pain and no side effects, and predictable results better than conventional therapy, 10 minutes procedure. This is making me use rampantly in my clinic. No blood or body fluid required. So indications, as I already specified, this is androgenic alopecia, telogen effluvium, anagen effluvium, chemotherapy associated hair losses, and traction alopecia, alopecia areata, PCOS associated hair loss, seborrheic dermatitis associated hair loss. Here I use the seborrheic condition cases also with the QR along with normal methotrexate also, because sebo-psoriasis, scalp psoriasis has become very much rampant in my clinic in recent times. So I started using QR in these conditions. The inflammation, the scaling has been reduced along with normal topical liquids and topical oral medication. QR is an neotherapy in standardized at 1 ml per session. We can do more than that, but because of the cost, this one we are going only 1 ml per session, 3 weeks apart, 8 to 10 sessions monthly once, or we can do like that also. After completing the therapy, a maintenance dose of 1 session spaced 3 months apart may be suggested depending upon severity of the alopecia. I started explaining my patients regarding this like only since last 8 months, and my patients are on from 6th and 7th session till now. So mostly I may extend, because few of my patients are like very happy. They are not very happy with the minoxidil and finasteride taking continuously. So one of the female pattern baldness patient responded so well that after 6th session she started getting baby hair without finasteride and minoxidil. That gave me some encouragement to continue this more in my clinic. At the same time, as we discussed, microneedling and macroneedling with QR and directly injection. QR is working through microneedling also, and I started this doing in youngsters. My youngest age of treating androgenic alopecia is 14 years. For them, not androgenic, female pattern baldness. For them, I started doing with derma rollers. Response is equally good, and patients are very happy. So avoid shampooing till next day. Avoid chemical hair treatments, styling products and so on. Refrain from touching and scratching the scalp. Avoid caps, helmets, scarf for at least 1 hour after session. Live demo is happening in the stall. If you are interested, please go and visit. So here we are missing the live demo. Video please. So this, QR is all about creating multiple channels. It is very easy to treat. Just less than 1 unit should be injected. It should be more superficial, not like not intradermal, but more superficial. 1/3 of the needle should go into the scalp, and pain is very less. We should create multiple channels. Because of this, I'm trying to start. I'm trying to start with the microderma pen also. So I'm dividing this into 40 units. I'll make to use in 10 units. I'll use for 4 needles for this. 4 needles, and I'll create 80 different channels. So because of this channeling, so it's all about creating micro channels in the scalp so that QR will be penetrating more, much better. But it's okay. Thank you for giving me this opportunity. You can just have live demo in the stall, and also you can experience the pain in the stall itself.
Dr. Monit, how many ml you will give per sitting?
1 ml per session.
1 session, 1 ml.
Yes, sir.
So that vial comes with 5 ml. So you can give 5 sessions for same patient.
8 sessions, sir.
Yes.
We have to buy one. See, same vial, see, once we open the vial, it can be used for any other patients. It can be stored for next 6 months to 8 months also, sir. It's not like immediately we have to use that vial.
Thank you, Dr. Monita. That was a nice presentation and very informative presentation. So we invite next presenter.
We invite the next presenter, Dr. Vijay Bhaskar Reddy, who will speak on fresh and fantastic emerging system treatments for atopic dermatitis.
A very good afternoon to you. Thank you IIDL family for inviting me here. Today we'll discuss about emerging systemic treatments for atopic dermatitis. Before starting, what we already know, the traditional immunosuppressants, we are already well versed with the cyclosporin, methotrexate, azathioprine. I will not be talking about this, though efficacy and tolerability are very good. There are very new emerging treatments which are targeting the specific cornerstones, that is specific pathways which are important in atopic dermatitis. While they are promising safety and efficacy, there are long-term studies and real-world data which are essential to confirm their lasting impact. Basically, in atopic dermatitis, the damaged keratinocytes which release cytokines or chemokines known as alamins, and these which activate the Th2 cells. So all the newer molecules which I am going to discuss act on these pathways. So why this need to be known? Because there is an increasing trend of atopic dermatitis, not only the pediatrics, even adults, we are seeing many newer phenotypes, not only the classical flexural distribution, many prurigo kind of lesions, and the most important is quality of life. About 10% of patients are reporting depressive symptoms and non-negligible impact on daily activities. So atopic dermatitis, as you all know, should not only be, it is not just the patient, the family and caregivers, everyone are important in the treatment and choice of the medication. So this is the usual choice based on the disease severity, whether it's moderate or mild, and we do a clinical scoring and the patient's quality of life. Safety versus efficacy, a difficult choice to make. And needless to say, the mainstay of the treatment is always the topical emollients and non-foaming detergents, and always try to avoid the need for active treatment and relieve pruritus. So before coming to the new drugs, this is basic knowledge about what phase 1, 2, 3 and 4 drugs are. They usually focus on safety in the first with a fewer number of patients. As we go to phase 4, the treatment is approved and available to thousands of people. But still the adverse effects will be monitored. Coming to the first target, that is IL-4 and 13, dupilumab is the first biologically approved drug for the treatment of moderate to severe atopic dermatitis in both adults and adolescents. It blocks IL-4 alpha. These are these approvals in both by US FDA, EMA and NICE, and it is proven to be a highly effective treatment. So the target is IL-4 alpha given subcutaneously, and these are the dosing regimens. And the treatment emergent adverse effects are conjunctivitis, oral herpes simplex virus, reactivation, arthralgia, eosinophilia, and injection site reactions. It is in clinical trial phase 4, and it is available in the market. The next drug is lebrikizumab. It is acting on IL-13 with a high affinity in a non-receptor binding domain, and it is again FDA approved in September 2024 and a well-tolerated drug. The route is subcutaneous, and the dose is 500 milligrams leading dose followed by 250 milligram every 2 to 4 weeks. The treatment emergent adverse effects are again nasopharyngitis, URTIs, headache. It is presently in trial phase 3. The third drug is tralokinumab. It acts against IL-13. It is evaluated in phase 3 randomized placebo controlled trials. It is again given subcutaneously, 600 milligrams leading dose followed by 300 milligrams every 2 weeks subcutaneously. It is again a phase 3 drug. There are many more molecules which are targeting this pathway. That is IL-13 agent, sandakimab. It is presently in phase 2, and its efficacy is, it is reducing the eczema area severity index score at week 16. And these are the newer drugs which are acting both IL-4 and IL-13 pathway, and there are many more numerous antibodies on the way. Redimkibbat is a IgG4 kappa monoclonal antibody which is targeting IL-4R alpha. It is exhibiting a higher affinity for IL-4R alpha compared to the dupilumab. Stapokibbat, it is again same in phase 2b trial, human monoclonal antibody which is targeting IL-4R alpha. And the last, ablasakimab, in this molecule which is targeting the 13R alpha 1, it considering the potential for increased safety, the longer treatment duration and low prevalence of conjunctivitis in the studies, it can be compared to therapies which is targeting type 1 IL-4R like dupilumab. The next target is IL-31, that is nemolizumab. It is again a fully human monoclonal antibody against IL-31R alpha. These are the dosing regimens, again given subcutaneously in phase 3 trials. And the next target is the JAK inhibitors. These are the various JAK inhibitors which are approved, whereas Abro is a specific inhibitor. Abro and Upada are specific for JAK1, whereas baricitinib is a pan-JAK inhibitor. We have very good trials, that is Upada and Abro have reached clinical trial phase 4 and now available in the market with similar treatment emergent adverse effects when compared to placebo. It is given as 200 milligrams or 100 milligrams once daily, and Upada 30 milligrams or 15 milligrams once daily. Baricitinib is attacks both on JAK1 and JAK2, and there are 2 independent phase 3 trials which are comparing all the 3 doses against the placebo. Abro, the new molecule, the safety and efficacy of both the doses, high and low doses, are done compared with the placebo and other drugs. And Abro 200 proved to be more effective in controlling the itch, but after 16 weeks there is not much significant difference. Interestingly, you can use this Abro in patients who have previously undergone treatment with dupilumab also. It has a favorable impact on all the patient-reported outcomes like BOEM, PGI, pruritus scale, DLQI, and depression scale. This is a slide showing the comparison of all the JAK inhibitors with the standard dupilumab. We see the Abro 200 milligrams and Upada 30 milligrams with a better efficacy compared to dupilumab, whereas the other 3 drugs and Upada low dose is almost similar to dupilumab. This is the newer target, OX40, which is nothing but a co-receptor stimulator molecule on TNF-alpha receptor. And these, we see atopic dermatitis patients have higher levels of this receptor expression, and the newer drugs which are coming, anti-OX40 are agents. These are both monoclonal antibodies, and the amlitelimab, which is targeting the OX40 ligand. This is GBR 830, which is currently in phase 2. It is also a promising option to target the chronic inflammation, and these are it is given by repeated IV infusions, 10 milligram per kg every 2 weeks. The treatment emergent adverse effects are similar to the other drugs, but it is still in clinical trial phase 2. This is one more rosatinlimab, which is again a fully human OX40 monoclonal antibody, and the benefits of this drug were maintained over 20 weeks post-treatment follow-up. Amlitelimab, it is still in phase 2, and it is seen that serum IL-13 levels have been reduced in patients taking this drug. Coming to what does evidence say? This is a very messy slide, but what need to be concentrated is the greener things. The greener things are the most effective, and the most, as you go to the red color, these are the most harmful drugs, and the darker variant is the highest harmful with very low certainty evidence, and the green things are with the high certainty evidence. With this, you can concentrate on the green color, that is the dupilumab and abrocitinib 200 milligram doses, and upadacitinib have very efficacious but also equally harmful. There are many more newer targets in pipeline. These are the different pathogenic steps, and there are many more drugs in this, which are in both phase 1, phase 2 and phase 3 trials. To conclude, atopic dermatitis, it hinders the quality of life of patients, their families and caregivers. Therefore, effective therapy is mandatory to reduce signs and symptoms and to avoid repercussions of anxiety and depression spectrum. At the moment, clinicians can prescribe agents targeting IL-4, 13 pathway and the JAK inhibitors. But further studies will be essential to identify clinical and laboratory biomarkers to predict the potential efficacy of specific drug in order to achieve a true patient-tailored, personalized approach. Among individuals with moderate to severe atopic dermatitis, the high certainty evidence, as the slide previously shown, high-dose upadacitinib is among the most effective in addressing multiple patient-important outcomes, but also is among the most harmful. High-dose abro and low-dose upada are equally effective, but also among the most harmful. Dupilumab, lebrikizumab and tralokinumab are having intermediate efficacy and have a favorable safety. So, while always when you go for a new drug, always take the side effects with a pinch of salt. They are always compared with the placebo studies in a small group of people. Thank you. Thank you very much for giving me this opportunity.
Thank you, Dr. Bhaskar Reddy, for your wonderful session. Thank you for organizers for giving this opportunity. Thank you.
That was a session on AI in dermatology and some new innovative molecules for hair growth and atopic dermatitis. I would like to invite Dr. Aruna S. Ma'am and Dr. Anchala Parthasarthi Sir to hand over the mementos. We will carry on with session 8 and I will hand over to Dr. Shruti. Thank you so much.
Good afternoon, everyone. I hope you are enjoying the conference so far. Before we begin, I like to inform you that due to time constraints, there will be no formal lunch break. However, food stalls have been arranged outside the hall. You may step out quietly at any time while we continue with the sessions. We are now ready to begin session 8. To chair this session, we are privileged to have Dr. B. Udayakumar sir and Dr. G.S. Reddy sir. I kindly invite both of you to the stage to preside over this session. We will be starting the afternoon sessions at 2:15.
Now the H&H pharmaceutical lucky draw is happening on the stage. Our Honorable State President Dr. A. Venkatkrishna sir and Scientific Chairperson Dr. Sudhavani ma'am will be perform, and our General Secretary Dr. JVDS Prasad sir. I request you all to come on to the stage for the lucky dip. Dr. JVS Reddy from Hyderabad. Dr. R. Nikhila, Hyderabad. So the H&H Lucky Dip winners are Dr. JVS Reddy and Dr. R. Nikhila, both are from Hyderabad. We request the winners to kindly collect their prize from the H&H booth. Dr. JVS Reddy and Dr. R. Nikhila, both of you have won the Lucky Dip, H&H Lucky Dip. We request you to collect the prize from the H&H booth.
Good afternoon once again, everyone. We are now ready to begin our session 8. To chair the session, we are privileged to have Dr. V. Gauri ma'am, retired professor and one of the most senior dermatologists in our state, and Dr. G.S. Reddy sir. I'd like to invite both of you to the stage to preside over this session.
Good afternoon. Anything? Sometimes luck falls into your lap. So we are lucky to chair this session, and all of them are from Usmania and close to Usmania, S. Reddy and Dr. Sudhir is also a student from Gandhi, but he worked with us. So I'm happy to invite Dr. Putta Srinivas, Dr. D.V.S. Pratap, Dr. A.S. Reddy, Dr. G. Manmohan, Dr. Sudhir, and Sudhir is not there. The top.
Dr. Srinivas is not there.
Pratap sir is coming.
I asked Pratap sir to come immediately. Dr. Sudhir also invited to.
Only 3 are available. Okay.
Sudhir, okay. Dr. Sudhir,
Invite moderator. Only moderator. Now we invite moderator. Somani.
I invite Dr. Somani sir to come as moderator. Today's topic is critical conundrums in dermatology, a case based on panel discussion.
So welcome Dr. Somani. So please put on the first conundrum. How these people will answer, we'll see.
Good afternoon, everybody. I think you all must be still enjoying the aftertaste of the lovely lunch spread over there. But we have to carry on, and we have a very distinguished panelists here with us. The combined experience may be more than 120, 150 years of clinical experience. So today's endeavor is to only bring out certain clinical situations where we face a dilemma in diagnosis and trying to manage the cases, and to come to some diagnosis, proper diagnosis. So we have Dr. I.S. Reddy, Dr. Manmohan and Dr. Pratap with us, and also we have Dr. Reddy and Dr. Gauri, my assistant professor at that time. So she taught me dermatology, so she's also here. We can take her inputs also, along with my panelist input too. Now these are the 3 very common presentations what we see in our practice every day, and these always are kind of confusing. We see purpura very commonly, wheals very commonly, and nodules. And these always pose a challenge as to the diagnosis or proper placement of the condition what we see. So today I'll try to take the opinion of the panelists in how to tackle cases when they're presenting with any of these three features. First we'll just start with a case of purpura, and the first case of today is a 26-year-old female with presented with petechiae and palpable purpura of 4 days duration, lesions over lower legs and medial forearms, no constitutional symptoms, but complained of mild itching and burning sensation over the lesions. History of fever about 10 days back, for which she took some treatment, and on examination there were hemorrhagic blisters in addition to the palpable purpura and petechial spots on the lower legs, along with some petechial spots on the forearms too. And the investigations did not reveal anything. All the investigations were normal, including the urine analysis and kidney function tests and serum creatinine, all were normal. So this is what we see very often in our clinical practice. And right from my PG days, I kind of develop cold feet when I see a case of purpura on the lower, because it's so confusing, so difficult to come to proper conclusion. This was the case. You can see here the patient showing purpuric spots and petechial spots, and in lower areas you can see So you can see in the lower part, there's a hemorrhagic blisters also developing in between the purpuric spots. So this is the presentation. So my question to my panelists, right, to begin with, suppose you're having such a case, what would be your initial thoughts? Dr. I.S. Reddy?
With the background history of fever and the treatment for the fever, we have to suspect vasculitis, especially leukocytoclastic vasculitis. Either fever and infection per se also can cause leukocytoclastic vasculitis. And the medication given to the fever also we have to suspect. And in the history we have to go about asking any other associated symptoms like abdominal pain or joint pains to exclude henoch-Schonlein purpura.
Anything other than vasculitis? I mean, I think Dr. Manmohan, first I think looking at the lesions, you feel that there is purpura or petechial spots.
Yeah.
So, I mean, could you think of purpura and then the conditions?
See, it has two components in it, purpura and vasculitis, palpable purpura and petechiae. So there may be some association of vessels as well as the platelets. Both the things has to be seen. Because petechiae are generally seen with platelets, whereas purpura, palpable you see with vasculitis lesions. So we have to see that, and then as I.S. Reddy said, we have to ask for the associated symptoms, because this is a very common thing, having systemic features. Because I know one of my friends, classmates I lost because she had only few purpura, palpable, and ultimately it went into ischemia of the bowel and she died. So that can be the severity. So we have to decide whether the purpura is localized or involving the other systems. So evaluating that through the history taking and some few investigations, I think then we can go ahead to, and this combination is generally seen in leukocytoclastic vasculitis, as you said, but henoch-Schonlein at this age group, generally we don't. But
Dr. Pratap, I want you to tell me now, is there any other condition where you can think of purpura as a presenting feature? Because here let us not discuss about vasculitis. At this juncture, patient has come to us, you see purpura. So can you see purpura on the lower limbs in any other condition other than vasculitis?
Other than vasculitis?
Any condition where you can see purpura?
Still my mind always targets vasculitis and drug-induced vasculitis, maybe because of some this thing, and metabolic other associations like thrombocytopenia or something like that.
Correct.
We have to think of.
Thrombocytopenic purpura.
Yes.
Yes. Anything else?
There are multiple causes. If you ask me for the purpura,
Yeah.
there are innumerable causes we can enumerate.
A few.
For example, ITP is one cause. And then other conditions, for example, rarely Primary systemic amyloidosis also can cause purpura. And infections also can cause purpura.
Right.
And
So my point is that when you're looking at a case like this with purpura, we simply straight away think of vasculitis, but you should also exclude other causes of purpura also.
Exactly. Rook writes one line. He says, when you see petechiae as well as ecchymosis, you suspect coagulation disorders or ITP. Whereas vasculitis, palpable purpuras, we can have so many causes like large vessel, small vessel.
That's right.
And all.
So always as clinicians, we must look at first to when you are encountering such a case, whether we have any other causes of purpura. For example, patient has any scurvy or Ehlers-Danlos syndrome, or most commonly senile purpura or purpura because of steroid usage. So all those things would be first we need to exclude before we go on to the diagnosis of vasculitis. So these are the conditions what we can see, where we can see purpura, and many of them can mimic vasculitis also. If it is purely cutaneous small vessel vasculitis, it can be, any of these conditions can be present on the lower limbs too. Of course, there will be other features which can distinguish, but they can present as purpura on the lower limbs, all these conditions. So first rule these out, and then we can go on to the diagnosis of vasculitis, because of the experience of all the dermatologists over here, they straight away knew that the case, the vasculitis case. But for a person who is initially starting his practice, rule out other causes of purpura, and then only confirm the diagnosis of vasculitis and then proceed further. Now, after this, the vasculitis is a very, very tough and complex situation where we have multiple vasculitis. We have large vessel vasculitis, giant cell and Takayasu, and we have got medium vessel vasculitis, Kawasaki's and polyarteritis nodosa, which we normally do not expect to see such cases. But our domain starts from the small to medium vessels. So we have got the immune complex small vessel vasculitis, and we have got ANCA-associated vasculitis. These are the vasculitis we see more often in addition to plain leukocytoclastic vasculitis. Of course, leukocytoclastic maximally what we see is in our practice leukocytoclastic. Yeah, Dr. Prasad?
I have seen a case of one female patient has come with small petechial lesions or vasculitis lesions with some vessel, that is vesicles. So I thought leukocytoclastic vasculitis and proceeded with the treatment of leukocytoclastic vasculitis. But ultimately it turned to be medium vessel vasculitis, and depth is because of that vesicular lesions. Then slowly it has become ulcerated, and then medium vessel vasculitis is has turned to be. Then I was
that's a very good observation, because we assume that it's just a small vessel vasculitis, but we need to examine each and every case in detail and look at the presentation of the patient, and there we might get some clue, and then we need to proceed in a certain manner to ascertain whether it's only cutaneous small vessel or medium vessel and small vessel, like you see in ANCA-associated vasculitis. Dr. Ayush wants to say something? Okay, so keeping that point in view, I think now, what are the clinical pointers of small vessel vasculitis versus medium vessel vasculitis in your opinion? For example, what we just saw, the petechiae and the purpuric spots on the lower limbs and small hemorrhagic blisters. These are all points towards, cutaneous superficial vessel vasculitis. And you expect superficial changes here. But in cases of deeper lesions or medium vessel enteritis, you may get some other set of symptoms, like if you can highlight those which might alert you to the possibility of medium vessel vasculitis also.
Now, usually in the small vessel vasculitis, what we see is palpable purpura.
Yes.
Whereas in the medium vessel vasculitis, we see the presentation will be usually painful nodules. And sometimes you can see libido racemose or libido vasculitis like pattern also.
Yeah.
And then most of the time these nodules can ulcerate also. And these are the various presentation compared to small vessel and medium vessel vasculitis.
That's perfectly correct. That's right. I mean, that's what we see normally. We have petechiae or palpable purpura as a prototype. Hemorrhagic blisters, what we just saw in the picture I just showed you, and very superficial ulcers, and sometimes you get urticaria also in small vessel. For medium vessel, as Dr. Reddy pointed out, we get nodules, and we can get deeper ulcers. We can get libido racemosa or libido reticulitis like pattern also, along with some scarring. So these are, I think, clinically what we can see to distinguish between the small vessel and the medium vessel. We can actually get a clue as to involvement. If we are seeing all these features mixed together, we can think that this could be a case of involvement of both medium as well as small vessel vasculitis, as we see in case of ANCA-associated vasculitis.
That case has gone up to the stage of bigger ulcers and debridation. We have to take the help of surgeons because it started with small vessels, hemorrhagic blisters, as I said. But that can happen.
Yes, that will discuss when we come to the management part of it.
Okay.
We are just trying to now see how to diagnose a case, like how to come to a conclusion. So these would definitely give us a clue whether it's small vessel or medium vessel or a combination of both, so that we can come to that classification. Now if you again visualize the classification, if it is both vessels involved, then we can think of ANCA-associated vasculitis, like Wegener's disease or Churg-Strauss syndrome, which are of course older versions, older names now, but we can think of those of macroscopic polyangiitis. In addition to vasculitis, what we see as purely cutaneous small vessel vasculitis. So now the question is, as we just discussed, ANCA-associated vasculitis. Now we cannot order for ANCA, P-ANCA and C-ANCA in all cases of vasculitis. We have to choose our patients with care, and when should we ask for the P-ANCA and C-ANCA test, because when we are suspecting ANCA vasculitis, only then we are going to ask for these investigations. So when would you like to think of maybe it could be ANCA-associated vasculitis?
We can suspect ANCA-associated vasculitis. Just not only the skin lesions, the patient, we can expect some systemic symptoms also. Systemic symptoms like if there is any involvement of the lungs, involvement of the joints, involvement of the kidneys, and the patient usually presents with fever and other associated symptoms also. And usually in small vessel vasculitis, it won't be so fulminant. Systemic symptoms will not be there. Whereas in ANCA-associated vasculitis, usually it be associated systemic involvement will be there.
Yeah, that's right. Anything else, Manmohan, you want to add?
The same thing, like once you suspect there is some systemic involvement, like maybe Wegener's or something, or hemoptysis or cough, breathlessness, then in that case we do also ask for C-ANCA and P-ANCA,
Yes.
just to know the systemic involvement.
Right. Anything you want to add, Dr. Pratap?
When the clinical picture, cutaneous lesions, other things, everything is perplexing, then we have to suspect ANCA-associated this thing. Because that complication means associated symptoms, systemic symptoms. Yes.
Yeah, Dr. Gauri might add or Dr. Reddy might add, anytime you can join in the discussion, anytime you feel like passing a comment, please feel free to do so. Yeah, I thought Dr. Reddy will be commenting more upon the DIF changes in vasculitis, because the ANCA-associated vasculitis will have no DIF changes, no deposition of IG, G, IgM or IgA, so that is why it is known as post-immune vasculitis, because you are more into immunofluorescence and all that, so I thought you would point out. So that is one feature where after biopsy you don't get any DIF positive changes, in contrast to the cutaneous vasculitis where you get deposition of IgG, or IgM or IgA.
That is also not mandatory, I think, no?
No, that's why it is known as post-immune group. Post-immune, where you don't see changes of DIF changes in these vasculitis.
Even in APLA also you don't see any deposits.
In where?
APLA.
APLA is a totally different issue.
It's a vasculitis, no?
That is a syndrome which
No,
is totally different than this. It doesn't come to the gambit of vasculitis.
No, but still, enoxaparin may show IgA deposits and all, but all...
Enoxaparin is not ANCA-associated, that's what I'm saying. It's not ANCA-associated.
No, the thing is, ANCA-associated positive you are telling about the histopathology?
Yeah. ANCA-associated vasculitis will not have DIF positivity.
Even non-ANCA also will not have, not necessary. What are you ready?
No, what normally we see in the vasculitis, in small vessel vasculitis, we see IgA deposits in the blood vessels. Small vessels.
Yes.
And whereas in ANCA-associated vasculitis, even if it is clinically, if it looks like small vessel vasculitis, there won't be any immune deposits.
Yes, that's what.
There won't be any immune deposits.
That is one way of distinguishing between plain cutaneous and ANCA-associated.
Yeah.
For example, here. Now, of course, we'll suspect ANCA-associated when we see the clinical picture of more generalized pattern and medium vessel cutaneous signs, nodules and ulcers, and the racemosa pattern of libido and other things there. Second point would be the vasculitis picture should be there, of course, to diagnose vasculitis. Then CRP and P-ANCA positivity, only then we suspect that this is a case of vasculitis and it is DIF negative. DIF negative positivity will be seen in Henoxanil, as Dr. Mohan pointed out, it will be seen in leukocytoclastic also. It's seen in urticarial vasculitis also, but not in these cases. You don't see DIF positivity. And of course, there will be systemic pointers like you all pointed out, lung involvement or kidney involvement, etc. So if you need to also screen for systemic involvement. When you're suspecting systemic involvement, you need to look for certain involvement in systemic organs also. And this is how we need to progress and look at the systemic involvement, try to take the history proper, try to examine and find out where it falls into the classification of vasculitis. So all this will tell us whether there is any malignancy or whether there is any hematuria or kidney involvement or pulmonary involvement or even CNS involvement. So these things need to be screened before we label the patient as ANCA associated or plain cutaneous, so small vessel vasculitis. So diagnosis of cutaneous vasculitis is basically clinical, and you can of course confirm it with histopathology, and DIF will definitely give us a clue, because if it is IgA positive, we know for sure that is Henoch-Schondlin purpura. Similarly, if it is cryoglobulin positive, we know it's cryoglobulin purpura, cryoglobulinic purpura. And of course, DIF will also give us clues. Basically, it's a diagnosis of exclusion, where we have to exclude everything else and then we can come to the conclusion that it is only purely cutaneous small vessel vasculitis. So, a brief answer from Dr. Pratap. How would you manage this case of, I just showed the case, how will you proceed in managing such a case?
Cutaneous vasculitis,
purely cutaneous.
Purely cutaneous. But in my experience, colchicine is the best drug. Colchicine gives good results, definitely good results. Yes. Of course, we can start with steroids and in antibiotics. Then, if it responds well, otherwise, I prefer to go to colchicine.
Yes, correct. Now, that's a very logical way. Many of us would use colchicine. True. Right. Dr. Manmohan?
I think before starting the treatment, I would like to see the urine examination first. As yesterday Dr. Manjunath was saying, RBC or CAS indicate some problem in the kidneys. In those situations where there is some involvement, not clinically but investigation-wise, then in that case it is better to start steroids to prevent the further damage. And maybe indomethacin can be given later as a steroid sparing.
Yeah, Dr. Reddy?
Yeah, I concur with Dr. Pratap. My first drug of choice is colchicine, and I am little hesitant to start on dapsone because of various reasons. Of course, when the lesions are very fulminant, I put them on steroids also. And then I have seen patients, it is sometimes can be very chronic. It prolongs, it doesn't stop with weeks or months. I have seen patients, every time you try to stop the medication, it keeps recurring. And sometimes there are instances where I have given other immunosuppressives like mycophenolate also for the treatment of very chronic and recurrent leukocytoclastic vasculitis.
Just another point I would like to make, like Dr. Reddy pointed out, we need to first look at the case of vasculitis, the duration of vasculitis. If it is just 4 weeks or so, most of the cases resolve in 4 weeks' time. If it's going beyond 4 weeks, then you may have to review your diagnosis, or maybe think of maybe some other, your diagnosis may be wrong, you may be dealing with some ANCA associated or some other kind of vasculitis. Most of the cases of superficial vasculitis will disappear in 4 weeks' time. Staying beyond 4 weeks, then you need to reassess the case and look for other pointers to confirm your diagnosis. So, yes, colchicine, dapsone. Dapsone would be logical in case because there are lots of neutrophilic infiltration, so we can also use dapsone. And of course, steroids is a very good choice along with antihistamines. I think we are now running out of time. Now, just giving you a very brief here, this thing. You can see here the algorithm kind of a thing where you just note large vessel and medium vessel, we are not bothered. But small vessel vasculitis, you see, you do ANCA test. It tells you which are ANCA vasculitis or which are non-ANCA vasculitis. And then afterwards, if it is non-ANCA, you go for IgA test to confirm whether it is Henoch-Schondlin or not. That confirms your Henoch-Schondlin purpura. If it is negative, then you go for cryoglobulin levels, and then if that is positive, it's cryoglobulinic vasculitis. If it is not so, ultimately we are left only with leukocytoclastic or urticarial vasculitis or BESX. So this is how you can come to some conclusion clinically with minimum tests. You just need ANCA, IgA and cryoglobulin test, and with these 3 blood tests, we can come to a reasonable conclusion in some cases or most of the cases. But anyway, this is just a general rule. We need to work up a little more on each and every case. This is case number 2, arterial wheel. I want Dr. Reddy not to take part in this discussion because he knows about this case. So this one more case, 47-year-old male, wheels ranging in size from 2 to 5 centimeter over the trunk and proximal arms, and they become confident to show polycyclic configuration. They are resolving gradually over 24 hours or so to be replaced by new ones. Constitutional symptoms, mild fever, arthralgia and bone pain are noted, and 6 to 7 episodes the patient had spread over the last 3 years, and each episode lasted for about 3 months. This is the picture. We know that, you can see the picture here. This is large lesions, and you can see that they are coalescing to give polycyclic configuration in many areas associated with fever and pain and joint pains also, and it is lasting for about 2 to 3 weeks each time. So this is the case which presented with these changes. Now what would be your possible provisional diagnosis keeping arterial wheels in view? In other words, arterial differential diagnosis.
This is definitely not urticaria because it is lasting for a longer time. So it's a kind of erythema or whatever we say that persists beyond arterial vasculitis like, but it need not.
Vasculitis. Arterial vasculitis also is possibility.
Possibility, yes. Okay. Arterial vasculitis. Right. So if that is there, then we have to investigate probably for any weight loss, fever and all joint pains, any connective tissue, or if it is related to any malignancy inside. There is a possibility. Such an extensive thing lasting for such a long time. So, and of course, we have to also consider figurative erythemas which may mimic this. Figurative erythemas.
Right. So here, this is what, I mean, initially when the patient presents with urticaria, these are all the conditions where we can see urticaria-like lesions, but which may not be urticaria. Mainly in these autoinflammatory syndromes like CAPS and TRAPS and Schnitzler and adult onset Still's disease and arterial vasculitis and other conditions. I would like you to concentrate more on, mastocytosis and Sweet syndrome also they can present like this. And also polymorphic eruption of pregnancy, and even DH and bullous pemphigoid, you see urticaria so often. So urticaria itself is a huge conundrum where you have to diagnose looking at the other features and then you come to your own conclusion. Basically, chronic urticaria, chronic spontaneous urticaria, you can easily diagnose, but these are all the pitfalls. If you don't look into this, then you might have a problem. So if a patient is persistent beyond a certain limit, not responding, or lesions showing atypical presentations, you need to think of all these conditions before you label the patient as a chronic urticaria. In this patient, we investigated the patient. The ESR and CRP were high, ANA profile negative, normal serum alkaline phosphatase, chest X-ray normal, immunoglobulins were raised, IgA and IgG both were raised, and IgE also was raised, but this basically IgG and IgA were raised, and all the other factors, RH factor, serum ferritin, everything was normal. Complement levels were also normal. We wanted to rule out arterial vasculitis, so even that was normal. So now, keeping in view of the monoclonal biclonal gammopathy in this case, there is IgG and IgA are raised in this case. So with this, we reviewed our differential diagnosis, and we have these possibilities later on. We made the diagnosis of monoclonal gammopathy of undetermined significance, adult onset Still's, arterial vasculitis, Schnitzler syndrome, and CAPS, cryopyrin associated periodic syndrome. So after working of this, then we had to observe the patient, saw the patient, and then after going through the patient's history and clinical presentation properly, we found that the patient has got these features. The Strasbourg criteria were present. The two major criteria, that is the non-pruritic urticaria and also monoclonal gammopathy should be present along with the minor criteria, like our patient had elevated CRP and had neutrophilic dermal infiltrate, no vasculitic changes, but there was changes of neutrophilic infiltrate and recurrent fever. So because these criteria are fulfilled, we could then come to the conclusion that this is a case of Schnitzler's syndrome. And I don't think there are many cases of Schnitzler syndrome diagnosed in our country. At least I did not come across any of these things after when I did the research, when I did the search. And so this was a case of Schnitzler syndrome, but presented as a case of chronic urticaria. And the patient had been having this problem the last 7 years, and nobody could diagnose this case. He was being given treatment with steroids and antihistamines, but when we worked upon the case, it finally turned out to be Schnitzler syndrome. Last, and I'll try to finish off very shortly, nodules on the legs. Another scenario where we are presented and we are at a loss to diagnose. So here we have a 38-year-old female, sudden appearance of painful lumps on the shins since 4 days, history of fever and cough 2 weeks back, for which treatment was taken, fever resolved in 3 to 4 days, and on examination, multiple ill-defined tender nodules ranging in size from 2 to 4 centimeters over the shins. All the investigations were kind of normal, including chest X-ray. Now, this is the picture. Of course, it's not a very clear picture, but you can still make out the nodules which are vague and you present only on the shins, sudden appearance and tender nodules. So, Dr. Pratap, what would you like to comment on? What disease would you think of this diagnosis?
Because normally we think of erythema nodosum, leprosum, and of course the panniculitis. These are the things that come to my mind when I see these things.
Yes. Dr. Manvi, anything to add?
Yeah, erythema induratum is one thing which is very possibility here because
we are in India, yes.
Yeah, so we'll like to do a biopsy to rule out any granulomas are there. But generally erythema nodosum and erythema induratum is clinically maybe difficult, but maybe sometimes they ulcerate. Erythema nodosum never ulcerates, erythema induratum can ulcerate. Yes. So with that clinical history and examination, we can come to a reasonable conclusion. As he said, panniculitis is one thing which we have to always consider. Then sometimes other subcutaneous fat disorders, sometimes injuries, repeated injuries, 1 or 2 tender nodules, fat necrosis can also occur in some. So these are certain things I think panniculitis kind of picture.
Even stasis, because even chronic insufficiency.
That is a diffuse.
Vasculitis.
Yeah, that is a diffuse lipodermosclerosis.
Yes.
That is stasis.
That also will take it. Dr. Reddy?
Yeah, same thing.
So yes, this is a very typical presentation, and you can suspect erythema nodosum because it is present on the shins, tender and sudden appearance of the lesions, and there is no ulceration. No ulceration, as Dr. Manmohan pointed out, is again very important. No ulceration in this area, sudden eruption on the shins. Now we'll just go through the differential diagnosis. We have got all these conditions. Most of them have been already enumerated by our panelists. So the only thing I want to point out here is that in case of erythema induratum of Bazin, we tend to have lesions more on the calf muscles, and there, as he pointed out, the ulceration is much more often seen. And these are the presentations what you see in erythema induratum. And the histopathology also differs. In erythema nodosum, there is no vasculitis, but in other conditions, you can see vasculitic changes also. So this is the calf where you can see the changes on the calf area and multiple lesions of erythema induratum. Similarly, here you can see cutaneous polyarteritis nodules also is a very notorious area condition where we can see similar lesions, but they are multiple in number, and you have got other systemic pointers. And then another interesting is pancreatic panniculitis, where the nodules discharge oily fluid, and of course investigations we can see as increased amylase and lipase and all these changes we can see. And alpha-1 antitrypsin deficiency, though rare, it also is very similar to this, and you can see a host of other features, systemic pointers, in addition to the nodules on the legs. Suppose this is a case of erythema nodosum, we need to treat the patient, so we need to first look at the causes, isn't it? So what do you think, Dr. Pratap, could be the common causes for erythema nodosum?
Right from infections to tuberculosis.
Yes.
Anything can give rise to herpetic is most common thing, I think. Herpetic infections.
Okay, any infection?
It is the bacterial infections. This patient history of
just 1 more minute to go. Yes.
So history of fevers and other things were there. So probably it is a streptococcal induced erythema nodosum.
Yes.
That is one possibility. Yes. And then apart from that, I would share a case seen by Dr. Ayers and ourselves. One old man came from, we will take extra minute, but please bear with us organizers. That man was coming to you with all the rashes. He got admitted. You wrote skin smear.
Loudly.
Yeah, you wrote skin smear. That fellow went away. And then when they came back to our general hospital, medical college hospital, when we did it, it was 3 positive. So it was totally a different presentation. Yes. So can you just...
No, I don't know. I wanted to tell you some more information. Maybe you are not aware. The 3+ positive, we have a little suspicion about that because we did the biopsy. 3+ positive for M. leprae. We did the biopsy. Biopsy did not show anything. Usually, M. leprae 3+ positive, biopsy must show something. That's case. This also same present with urticarial lesions, fever. I am suspecting one of the autoinflammatory syndromes in this case also. This patient, he comes, gets admitted. The physician, they give injection Solumedrol, 125 mg BD for 5 days. Everything disappears. He goes off. Again, after 2 years, he comes back with the same symptoms.
In such cases only you should look for autoinflammatory syndrome.
This condition I am thinking in terms of autoinflammatory syndrome.
Correct. That's right. So
That's
in
what.
short,
And ultimately, the thing is, when I discussed about this 3+ positivity with the smears, our pathologists in the medical hospital, they were telling, our hospital water is so much contaminated. There's a lot of saprophytic AFB in the water, it can show 3+ positivity. That's what she was telling. When they do here in the hospital, they use distilled water for doing the smears for AFB. They don't use regular tap water. Regular tap water, there's a possibility of contamination.
point to be noted. No tap water.
We may still find bacilli, but there will be atypical bacilli, tuberculosis. All these are contaminated municipal water, what we get. Atypical mycobacterial infections, they may also show us.
So coming back to the causes of erythema nodosum, we have seen, I have pointed out in red, the most common causes are streptococcal infections, tuberculosis in our situation, and of course sarcoidosis. These are 3 very common causes, but you can see also in facets, you can see in Sweet syndrome, you can see even in pregnancy, erythema nodosum. So just keep this in mind when you are treating so that you can exclude all these conditions and treat. But basically, in most of the cases of erythema nodosum, what we see is that it is happening in 8 weeks of time without any treatment being given or being given only placebo treatment. So any treatment insights you want to offer the panelists for erythema nodosum, how to manage or how do you plan to manage?
Yeah, if we can identify the cause, it is the best way to treat.
50% of cases are
It's not possible.
Then what will you do?
Usually I put them on, my first line of treatment is NSAIDs.
Okay.
I give them, my first drug of choice is indomethacin. And sometimes I give them a short course of steroids also. And other drugs, sometimes colchicine again helps here.
Dr. Manmohan.
Yes, basically, although we do all the investigations, but still there may be some infection somewhere we cannot. So I give a course of antibiotic first, followed by NSAIDs. If that is not helping, then we may add corticosteroid for short.
I go for first antibiotics, and then afterwards it doesn't respond, then I go for steroids.
I was expecting at least somebody would say about saturated solution of potassium iodide. That's a very, very common and very effective treatment. We used to give when we were in Usmania, Dr. Gauri knows about it, we used to study and give. So SSKI is again very, very common for idiopathic nodular erythema nodosum. That's also after NSAIDs, I think that's a very popular treatment. I think we are running out of time. I have to close now. Thank you very much. I appreciate all the inputs from my panelists. I thank all the chairpersons and the organizing committee for giving me this opportunity. Thank you. Thank you very much.
Thank you.
Thank you to our chairpersons, panelists and moderator for such an enlightening session. I request our chairpersons to proceed to the memento booth and present mementos to speakers. I also request Dr. Durga Prasad sir and Dr. D.B.N. Murthy sir to kindly come forward and present mementos to our esteemed chairpersons. Now moving on to session 9, we are honored to have Dr. M. Ashok sir, Dr. Aruna Samarth ma'am, Professor, Usmania General Hospital, and Dr. R. Satyanath sir, Senior Dermatologist, Patnaik Skin Clinic and Laser Center. I kindly invite you to the stage to preside over this session.
Yeah, the next topic is JAK of all trades, a deliberation on rational use of JAK inhibitors. It would be moderated by Dr. Anchala Parthasarathi Garu. Now I request Dr. Anchala Parthasarathi to please come onto the stage, please.
Dr. Anchala Parthasarathi sir is the doyen of dermatology. He has been recently awarded about this at TN conference. He is abysmal to talk about because he is vast in the knowledge and experience. He worked in Kingdom of Saudi Arabia for almost 15 years, sir. 10 years, 6 years, 6-7 years. He was a consulting dermatologist even at Singarani Collieries for a short time. Sir, over to you.
I think I thought you will be.
And he conducts basics every year, and now he is slowly seeping into Kerala and Andhra Pradesh.
Thank you, Dr. Satyanath. Maybe you can invite
Before any drug comes into market, it goes to Sir's Institute.
I think I would like to invite the panelists. Dr. Rajarashmi, please do come. Dr. Sai Krishna, Dr. Vijay Bhaskar Malala, Dr. Kranti Verma, Dr. Indira Pavan, and Dr. Sridhar. Please do come on to the dais. In this panel discussion, I will be asking questions to each of the panelists, one question to each of the panelists. So the others can answer if they want, but that question will be directed to one particular panelist. I think you know about JAK inhibitors. Most of you might have tried JAK inhibitors. Even though they are called the JAKs of all trades, they are also masters in treating many of the diseases. They are not masters of none. They are also masters. My first question goes to Dr. Rajalakshmi. What are JAKs and what are JAK inhibitors? So that the audience will be knowing.
Yes, sir. So it is a Janus kinase, is a receptors. First, what happens is exactly the cytokines and all that. Every cell is having a JAK pathway, JAK-STAT pathways, which goes the cytokines and then the receptors will get activated. So these JAK are Janus kinase, which are a family of the 4 enzymes where we have JAK1, 2, 3 and the tyrosinase kinase 2. So that is also called, and all put together they are known as JAK, which again they act accordingly with the JAK-STAT pathway, sir.
Yeah. Actually, Janus kinases are nothing but tyrosinase kinases. Actually, they should be named as tyrosinase kinases. But later on, when they found the structural similarity in most of the JAKs, I mean most of the tyrosinase kinases, they named that Janus. Janus is the name of Roman god who has 2 faces. So he is the one who keeps the keys for the hell and heaven, who opens the hell and heaven gates. Next question goes to Dr. Indira Pavan. I think I'll just, you can see here the Janus kinases they are all similar, most of them. And we have the stats also. Because whenever you talk about JAKs, you have to talk about stats also, because stats are the signal transducer and activators of transcriptions. They are also similar. Initially, we are having JAK inhibitors. Later on in future, we are going to get STAT inhibitors also. So what are JAK inhibitors and why do JAK inhibitors seem to treat the most difficult disorders in dermatology? Doctor?
Yeah, so as ma'am rightly said, JAK inhibitors, most of the dermatological conditions when we look into, they are mostly inflammatory, autoimmune and cellular regulation where it is disturbed. So when we understand this JAK, these enzymes, JAK1, 2, 3, and then rightly said tyrosinase kinase enzymes, they play a very crucial role in intracellular signaling. Whenever these cytokines come and attach to the cell, and they activate this JAK-STAT pathway. So whenever we target the cause, the exact site where the activation of the cytokines is happening, then we can inhibit the inflammatory mediator release and then autoimmune activity through regulation and cellular growth regulation. So most of the dermatoses, as rightly said, they are like, we say like jack of all and master of none, but now the future is now we are seeing like everywhere they are becoming jack of all but master of everything in the dermatosis and treatments.
Yeah, as he has mentioned, there actually that the targeted biological therapies in autoimmune, inflammatory, and even allergic diseases, even viral infections like COVID-19, where baricitinib has been played a major role, and most recently for the cancer therapies also. And because actually all JAKs are, the JAKs signaling pathways involved in normal physiological process, in the sense in the development and in the hematopoietic and the immune functions and all those things. But when there is an aberration of this pathway, then only the diseases like hematological malignancies and then combined immunodeficiency syndromes, inflammatory syndromes, and then the infections and all those things come. So inhibition of this pathway is very important in having majority of the diseases where there is an autoimmune, inflammatory, infective, and hematological malignancies. So JAK inhibitors we call them. JAK inhibitors work in those conditions where cytokines play a major part in pathology. What is the link between JAKs and cytokines, Dr. Sai Krishna?
Sir, here as said,
JAKs and cytokines.
Cyto is cells, kines is movement. So these cytokines are stimulated by the cells whenever there is an aberration or a normal process also. So once they come onto the cellular receptor, so they activate this JAK, they attach to the JAK. Cytokines type 1, type 2. So there are several types like interleukin 2, interleukin 4, interleukin 5, you can name any number. So they function through this pathway. Once they stimulate the JAK pathway, then the JAK get dimerized, phosphorylate, and then the STATs are phosphorylated. Then the signal is transduced to the nucleus. From there, the genetic modulation, either the inflammatory process will start.
Yeah, you have rightly pointed out all those things. Actually, there are 200 cytokines. If you count them, approximately around 200 cytokines are there in the body, and there are 4 JAKs. And then there are 57 cytokines which pass through the JAK pathway. There are 57 cytokines. That means 1/4 of the disorders can be tackled with JAK inhibitors. So as he rightly pointed out, there are type 1 cytokines and type 2 cytokines. So both of them are involved in the JAK-STAT pathways. And you can see there are 4 JAKs and there are 57 cytokines which they tackle the 57 cytokines. And these are the things. If you see here, as Dr. Indra has pointed out, they work in autoimmune, they work in allergic diseases, they work in inflammatory diseases, they work in viral infections, and they work in cancers. I think he has explained to you about JAK-STAT pathway. I did not explain all those things. JAKs are not receptors, they are at the lower end of the receptor. They are not the receptors actually.
They are intracellular component.
They are attached to the receptor, lower end of the receptor. They phosphorylate the STATs, and then the STATs get dimerized, and then they get translated to the nucleus, and then the nucleus, they just genetic transmission, and then inflammatory cytokines will be formed. So this is how they work. What are the types of JAK inhibitors, Dr. Malala? Types, I mean type 1, type, so the JAK inhibitors, I am not talking about JAKs, I am talking about JAK inhibitors.
Yeah, so there's different kinds of classification now, sir. So first generation, second generation. As we have a minimal JAK inhibitors in Indian market, so the first generation is launched in 2013. That was used for rheumatoid arthritis. In 2013, available as Xeljanz, that is tofacitinib, now available with multiple companies, multiple brands. Started with the price of 80,000, now to the 8 rupees. So that's the beauty of the patency. It's gone. So the first generation is Tofa, which is approved for rheumatoid arthritis. Now we have multiple drugs available. To the latest Cibinco available, as abrocitinib. So this first generation, now we are waiting for the latest drug called upadacitinib, and then the deucravacitinib, which is TYK2. So first generation, second generation is the best classification, and the selective and non-selective, and the other one is there's different classifications, sir. But
As he rightly
reversible,
pointed out, we have the non-selective.
JAK 1 and 3, sir. 1 and 3 inhibitors combined will be there.
Yeah.
And selective, now they are coming about selective JAK
Non-selective,
inhibitors.
pan-JAK.
So to prevent the side effects.
Yeah, I'll come to that also. So these are the non-selective inhibitors. We have tofacitinib, we have baricitinib, and we have ruxolitinib. It has come recently to the market. And we have selective JAKs, where here JAK1, JAK2, JAK3, or JAK1, JAK2, JAK3, TYK2, all these things will be there. That's why they are called as non-selective. Selective means only one, JAK1 or JAK2 or JAK3 or TYK2. So these are the things. We have natural JAK inhibitors also. That we should always remember. The natural JAK inhibitors are from Chinese herb. There is one JAK inhibitor. Curcumin, there is JAK inhibitor. And blackberry, strawberry, and pomegranate also. And quercetin in apples and onions, and silymarin in thistle plant. There are natural JAK inhibitors. Don't think that they're all manufactured. They are there in natural ingredients also. These are the available JAK inhibitors in India. I think you should know tofacitinib. Ruxolitinib, now only topical form is coming. Baricitinib is also there, not available, but during COVID time it is very, very much available. Now it is also available in certain companies. Tofacitinib is available as a 2% ointment. Ruxolitinib is available as 1.5% ointment. Abrocitinib is now marketed in 50, 100, 200 milligram tablets. Tofacitinib and abrocitinib are the two oral medications, and tofacitinib topical is also available freely in India. So these are the JAK inhibitors. So what are the approved JAK inhibitors and their indications? Dr. Sridhar.
Sir, FDA approved are limited only. In dermatology, is mostly off-label. So approved JAK inhibitor, tofacitinib now, and baricitinib, and topically ruxolitinib. So mainly in our Indian market, tofacitinib is approved, and for in dermatology, little bit out of off-label only, like for alopecia areata.
Tell something. Yeah.
Actually, sir, tofacitinib is indicated mainly for psoriatic arthritis. FDA approved is for psoriatic arthritis and rheumatoid arthritis, ulcerative colitis, and juvenile arthritis also. But for us, it is for psoriatic arthritis. Whereas abrocitinib, now it is for atopic dermatitis, it is approved. But all others will be the off-label.
Very few indications in dermatology actually. JAK inhibitors. If you see here, JAK1, JAK2, JAK3, that is tofacitinib. It is usually used for rheumatoid arthritis, psoriatic arthritis, ulcerative colitis, and polyarticular juvenile idiopathic arthritis. JAK1 and JAK2 inhibitor, baricitinib, is rheumatoid arthritis, atopic dermatitis, COVID-19, and alopecia areata also. JAK1 inhibitor alone, upadacitinib, that is for rheumatoid arthritis, psoriatic arthritis, even for atopic dermatitis and ankylosing spondylitis also. So similarly, abrocitinib, it is approved in atopic dermatitis. TYK2 inhibitor, that is deucravacitinib, is approved in USA for psoriasis also. They are not available in India. And pan-JAK inhibitor is also there, delgocitinib, which is approved for AD in Japan. So these are the approved JAK inhibitors. But the thing is, there are only two JAK inhibitors which are freely available in India. That is, one is tofacitinib, other one is abrocitinib. You see the indication. Tofacitinib is not indicated in any dermatological condition. You just see rheumatoid arthritis, psoriatic arthritis, ulcerative colitis, and polyarticular, of course, juvenile idiopathic arthritis. And abrocitinib is approved for atopic. These are the only the JAK inhibitor which is approved in dermatology.
Sir, ruxolitinib is also.
Yeah.
Ruxolitinib topical.
Topical. That's
in alopecia areata. Alopecia areata.
So the thing is, what are the dermatological conditions for which the FDA has approved JAK inhibitor?
So only atopic dermatitis, sir, psoriatic arthritis. So the only thing is atopic dermatitis, nothing more than that.
Topical ruxolitinib in alopecia areata.
Yeah, that also will come. That is what he has mentioned. Atopic dermatitis, if it is a mild to moderate, ruxolitinib is not available in India, only topical form is available. Atopic dermatitis, if it is moderate to severe, abrocitinib and upadacitinib, but abrocitinib is available. For alopecia areata, baricitinib is approved, not tofacitinib. That we should remember. And the other things are there. For psoriatic arthritis, tofacitinib as well as upadacitinib, but psoriasis, deucravacitinib is approved, and for vitiligo, ruxolitinib is also approved, orally also. So these are the dermatological conditions where FDA has approved JAK inhibitors. But out of this, only we have tofacitinib as well as abrocitinib and topical ruxolitinib and topical tofacitinib also. Why is abrocitinib has been found to be very useful in moderate to severe atopic dermatitis, Sai Krishna?
Sir, Abrocitinib is a specific JAK1 inhibitor. So it blocks IL-4.
Even tofacitinib is also, but why abrocitinib?
No, it's a, it has a more potency, sir. One thing is, it is having a more affinity towards JAK1 compared to tofacitinib. Tofacitinib originally is JAK3 inhibitor, but it is found to have effect on JAK1 and to certain lesser extent on JAK2 and TYK2 also. But abrocitinib being more potent of all these things, it is JAK1 specific inhibitor, and the pathway it blocks is usually blocks the IL-4, IL-13 and 31, and then all these things which are associated in the atopic dermatitis.
Very, very effectively. That's what the rapid itch relief, sustained control, once a day pill, tolerable and consistent, and improvement in quality of life. That's why that scores over the others actually. But to be frank, more than that, the other drug, not abrocitinib, the other drug is more useful actually, but is not coming to India. So this is a few patients I will be showing. Don't think that I just please go through these photos.
Yes.
This is one case of acne reticuloid where you have treated, and you can see the improvement. This is another case of acne reticuloid. You can see the improvement after 6 months. This is another case of Parthenium dermatitis. You can see the improvement after 3 months. This is alopecia areata and totalis. Actually, you can see the improvement 150 days and 300 days. And this is alopecia, another case of alopecia totalis. You can see the improvement. And prurigo nodularis, you can see the improvement. And pemphigus foliaceus, you can see the improvement as a maintenance therapy. And then lichen planus, you can see the improvement here in these cases. And then lichen amyloidosis also used, you can see the improvement. Pemphigus nodularis, you can see the improvement here after 1 year. And then atopic dermatitis, you can see the improvement with tofacitinib. And of course, the side effect was acne here. And then the granulomanular, you can see the improvement after 4 months. And then vitiligo, you can see the improvement. And psoriasis, you can see the improvement. So now the thing is abrocitinib. Abrocitinib in 15 days, you can see the improvement, how it has responded. And then next is the hands, you can see the improvement in 1 month. And another thing is on the legs also, you can see the improvement after 1 month. So the thing is, this is on the hands also. The thing is, now after seeing these pictures, do you think that, am I right in prescribing the JAKs left and right?
Absolutely.
Why?
With caution, as a clinician, we know about the drug, we should know about the drug.
It is not indicated at all. As per the FDA, it is not, the tofacitinib is not indicated in any of the dermatological conditions. Then how do you say that I am right?
No, sir, it cannot be prescribed as left and right, sir. But it has to be, because there are several other medications which have been using. So these drugs are indicated when the other drugs fail, or when the natural course
you mean
of
to
the
say when other drugs fail, you are justified in using it as an off-label.
Off-label.
That's one point
Yes.
I can take it. Next.
So then
I want
the
some few points.
safety concerns, of course, are there with this.
Safety concern when compared to other immunosuppressants is better.
Yes.
Okay. Can it replace steroids?
It cannot, it's to certain extent, yes sir. Yes sir, abrocitinib, like for suppose in atopic dermatitis, yes.
For rapid onset also we may need.
Rapid onset also.
Sometimes we may need.
So the answer should be no, they are not supposed to be right and left, they are not supposed to be prescribed. I think Manmohan is there, I would definitely would have given an answer. Last time also we had a debate with Manmohan. We cannot prescribe them as we like. FDA indications are very few. Most of them were prescribing off-label. Hence, extreme caution should be followed without proper investigations, because we are seeing many doctors prescribing just like that without any proper investigation. That is very bad. When other standard therapies fail, that is what Dr. Sai Krishna has pointed, then only you can prescribe. And then otherwise we will be facing a medical legal problem which will be very, very detrimental to us. And be careful in prescribing to elderly above 65 years who are on polypharmacy. So these are the take-home points actually. Which are
there is a paper where I read where they are showing, I think it is a Dutch study on chronic hand eczema. So what they have studied is, out of all the patients they wanted to prescribe, 80% are unfit to be started, because even smoking, cardiovascular risk, so many other things are to be ruled out. because it has black box warnings.
Yeah.
So it has to be very carefully given.
Yeah, you are absolutely right. What are the off-label indications of JAK inhibitors? I think, Dr. Sridhar, I think you have just
covered almost all.
off-label indications.
You have shown everything, sir.
Now it is now for any disease which is not responding to our conventional therapy, like you said, actinic reticuloid, pityriasis rubra pilaris, or anything which is not responding to our
I pointed out initially, first you said autoimmune
inflammatory.
I want to add two more, sir. One is chronic non-venous ulcer. Other one is pyoderma gangrenosome. It works wonders. Plus lichen planopilaris.
Lichen planopilaris.
If you see the tofacitinib, there are more than 20 indications. And to be frank, I have tried in all the indications. These are the indications which I myself tried. I may be wrong or right, but when I failed the other therapies, then I started using in all these indications. All these indications I have used. And next comes abrocitinib. Abrocitinib also can be used as an off-label, not atopic dermatitis. In vitiligo, it has been found to be useful in hand eczemas, in prurigo nodularis, in hidradenitis suppurativa, in pyoderma gangrenosum, and chronic pruritus of unknown origin. There also we can try abrocitinib. Any topical inhibitors, JAK inhibitors, you know, Dr. Sridhar was telling? Topical JAK inhibitors.
Topical, it is useful in vitiligo, sir, segmental or
What
to
are
smell.
they? What are they?
Sir, no, tofacitinib topical. Tofacitinib is also there, sir, topical.
Any other thing?
There's something called Opzelura, ruxolitinib. It is with for non-segmental vitiligo.
You are right.
But,
so we have topical tofacitinib, we have topical ruxolitinib, we have topical delgocitinib, we have topical ochromycinone. Ochromycinone is a STAT3 inhibitor. I mean, STAT3 and STAT4 inhibitor. So the STAT inhibitors are also coming. They are topically. So chronic hair dermatitis, topical delgocitinib is very useful. In vitiligo, lichen planus and lichen planopilaris, topical ruxolitinib is very useful. Atopic dermatitis, vitiligo and lichen planus, topical tofacitinib is very useful. In psoriasis, topical ochromycinone is also useful. And this is one of the interesting conditions where this patient had a plasma cell balanitis, which is proved with this thing, biopsy-wise also. And I just tried tofacitinib topically for this patient. You can see the response of topical tofacitinib for plasma cell balanitis also. Of late, I am getting ruxolitinib. And this is just in 15 days, you can see the white one has come into erythema, and even at the border also you can see the pigmentation started coming up with the ruxolitinib. This is topical ruxolitinib is available in 1.5% cream. And the other one, this girl also, even though there is reddishness, but she was happy because the lesions are pigmented.
It is.
That repigment.
It is $5,000, sir.
Yeah. Actually, this is available in only certain, in one company, with one company. The original cost of in USA is 70,000 rupees for 100 gram tube. Now they are selling at 15,000 rupees in India. 1.5. What are the investigations you would like to do, Dr. Malera?
Like other immunosuppressive, like any other immunosuppressive, CBC, LFT, viral screening, lipid profile, renal profile, viral screening, TB quantiferon gold, oblique MON2, chest X-ray. They are the minimal investigations. Exactly. Like any other immunomodulator, baseline, first month, second month, and every third monthly.
So whenever,
They are in the childbearing age group, we need to rule out the pregnancy.
Pregnancy, yeah.
Lactation pregnancy.
Yeah. So these are the baseline investigations already as mentioned about CBP, LFT, serum creatinine, creatinine phosphokinase. After we are getting creatinine phosphokinase levels increase because most of the people are coming with myalgias and arthralgias. So we have to be careful about that. Fasting lipid profile, HIV, hepatitis B and hepatitis C, and tuberculosis. Screening for tuberculosis.
CPK.
After 1 month, you please get these tests once again. Complete blood count, creatinine, liver function test, lipid profile, and annually screening for TB. That is very important. But once in 3 months, the same thing has to be repeated. But important notion, I think Dr. Sai Krishna was telling last time also, if the hemoglobin is less than 9, yeah, if the absolute neutrophil count is less than 1000, if the absolute lymphocyte count is less than 500, please be careful. Don't start tofacitinib. So
CPK also,
that's
sir.
why the caution is, don't prescribe tofacitinib left and right without getting the investigations properly done.
And cardiac side effects also are there, so we need to see cardiac also.
We'll coming to that one.
Yes,
We'll
okay.
come to that one.
Sir,
What are the
CPK, one thing, sir, CPK is must, sir, or only if the patient is symptomatic?
Only if the patient, I mean,
symptomatic.
those who are on statins.
Okay.
Statins is what they're telling.
Yes.
What about the contraindication?
Sir, that is why in small cities like I practice, So it is becoming difficult to prescribe tofacitinib because it requires around 7,000 rupees per test.
But
in
if
cities,
the patient is having, I mean, with severe
yes, yes, sir, yes.
disease, and he doesn't mind. He
Yeah,
doesn't
that's
mind.
why. Yeah.
So what are the contraindications for JAK inhibitors? Sridhar, you can tell me.
Contraindications. Sir, any other immunotherapy are they going? And the smokers.
Rajalashmi, Dr. Rajalashmi, please.
Any infections, bacterial infection, viral infections, and smoking, and chronic infections, cancers.
You want to add anything, Dr. Indra?
Any drug-induced hypersensitivity, lactation and pregnancy, already hepatic impairment, and then renal impairment, and sometimes any immunocompromised state, the risk of secondary infections like zoster and all are more, so we need to check. And risk of even malignancies like lymphomas in particular. So we need to rule out and avoid it.
And also during vaccination, active vaccination should not be there around.
Usually 2 weeks prior, before giving JAK inhibitors, at least 2 weeks prior, the vaccination should be given. Yeah. And then what are the common side effects you encounter, Dr. Malala, in your practice?
So headache from the patient and drug-induced headache. Number one. Number two is sometimes distal neuropathy, nasopharyngitis. As you said, sir, anemia. So tofacitinib has something like steroid-like side effects. Steroid-like. They come with something like bloated face sometimes, and they gain weight. That's number one, what we observe in Indian scenario. And then one of my patient had an increased serum creatinine level. So that is the reason we have to be very careful while we give these drugs.
You encounter in your patients, what are the...
Dyslipidemia, mild hepatic changes. Apart from what he has told, there are cholesterol increase, LDL increase.
Because it is known to increase the HDL as well as the LDL levels, both. Yeah, any other drugs?
Sir, I have given,
acne, you are absolutely right, acne.
Sir, I have given to few because small city, but most side effect is Google side effect. They say they will study the drug.
Side effects.
They will study the drug and tell, sir, you have prescribed this, this is having so many side effects. But till now, I didn't get any side effects.
Any other side effects?
So apart from that, myalgias are most common, sir, what I have seen.
Yeah, one should be careful about these things. Herpes simplex and herpes zoster. These are the things which are in the long run. So you have to be very acne, and then urticaria sometimes, malignancies, as Dr. Rajalashmi has pointed out, hypersensitive infections, especially there was a case report of gastrointestinal perforation also in one of the cases. So upper respiratory infection, nasopharyngitis, activation of latent TB, activation of hepatitis B, and all those things happen, cryptococcosis and histoplasmas also. And hematological abnormalities, dyslipidemias, liver function abnormalities, general symptoms like pyrexia, fatigue, musculoskeletal like arthralgia, pain and the swellings, and nervous system and the vascular effects are also there. Sometimes purpuric lesions also can happen. We had one case of purpura developing in one of the patients, and of course that patient had ITP also, which we didn't notice. The solid organ malignancies like breast cancer, carcinoma lung, carcinoma prostate, and all those things happen. Any drug-to-drug interaction, this is very important. Because
sir, antifungals of fluconazole, ketoconazole, as per the book, but even itraconazole also I feel we're not supposed to give because of the renal and hepatic, because all act on the cytochrome P450. That's the reason even itraconazole also I feel is a contraindication. Statins, which increases myalgias when it acts together.
And then it should not be prescribed along with other DMARDs except methotrexate. Other DMARDs have to be avoided.
Very important. Usually, except methotrexate, other immunosuppressive drugs, especially cyclosporine, azathioprine, we are not supposed to prescribe.
Then there is one more important thing, sir. When there is positivity for tuberculosis or latent tuberculosis, then we tend to give prior rifampicin and INH. But when we are starting tofacitinib along with it, it's better to avoid rifampicin.
Yeah, exactly. This is what. So, suppose there is a latent tuberculosis, you suspected TB, TB gold test positive, and then you ask for the X-ray test also. X-ray test is normal, but at the same time, we have to be very careful because I had one case where the latent tuberculosis has come out. So that's why you have to be very careful, and you have to prescribe rifampicin and INH combination. But at that time, don't give along with rifampicin. Don't give tofacitinib. Let the patient take it for 1 month or maximum 3 months, and after that you can start. So tofacitinib should not be taken with DMRs or immunosuppressive drugs such as azothioprine and cyclosporine. It can reduce the effectiveness of birth control pills also. Rifampicin may reduce the effectiveness of dapagliflozin. Take care while prescribing with warfarin and aspirin because bleeding tendencies will be there. Rifampicin can be combined with methotrexate. And take care while the patient on these medications because the medications which interfere with the CYP, that is cytochrome P3A4 and cytochrome P2A19. So these two things, because these are the medications which interfere with these enzymes. So fluconazole, statins, aspirin, imitinib, isoniazid, HIV medications, and ibuprofen also. Even the isoniazid also, they say that along with tofazanib, don't try to give. So coming to the conclusion, you know that JAK inhibitors have found a wide range of use in dermatological disorders which are notoriously resistant to conventional treatment, and they are much safer than oral steroids and other immunosuppressives in short and long-term range. They have given the dermatologists the significant alternatives in treating diseases which are recalcitrant to traditional drugs when the later are contraindicated. Oral administration, the lower cost, largely favorable side effects. Few important areas where they can score over biologics. Topical JAK inhibitors have also shown encouraging results in dermatological conditions, especially atopic dermatitis and vitiligo, where their efficacy is similar to oral JAK inhibitors. More head-to-head trials are important. You have to compare JAK inhibitors with the head-to-trial trial, and then the other immunosuppressives also to know whether they are really quite useful or not. But I always tell to the practitioners who are prescribing both either tofazanib or abrocitinib, please do the proper investigations. And because India is a country where tuberculosis is endemic, rule out tuberculosis, then only you start JAK inhibitors. Otherwise, I have seen a few prescriptions just slightly coming psoriasis, JAK inhibitor they are prescribing without doing the investigations. Another thing is for psoriasis, even though it is off-label indication, it is 10 milligram BID that works well, not the 5 milligram twice daily. And I think probably in another few months we are going to get deucravacitinib, which is a TYK2 inhibitor, which is very good, which is very useful in psoriasis. That also will be a new drug to the armamentarium of the dermatological diseases. And I think we are finishing in time. And thank you very much for your valuable inputs.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you very much.
Thank you.
I thank the moderator, Dr. Anchulu Parthasarathi garu, and all the panelists for a very lucid description and discussion. Thank you very much.
Thank you, sir.
Thank you, sir.
After all listening to all the stalwarts, what I understand is when your armamentarium is complete, call the JAK.
Ultimately, without JAK, you can't change the car tire also, sir.
Oh yeah, Jackie.
Next, we invite Dr. Nanisetti Ramesh sir, Chief Dermatologist and HOD of Department at DVL, Railway Hospital, Central Railway Hospital, Lalaguda. To give his talks on perspectives on pustular psoriasis, challenges and treatment.
Good afternoon. Regards to judges and the audience. So next 10 minutes I will be speaking on need for looking for non-conventional therapy that we have left with so many options in the management of psoriasis and pustular psoriasis. Many situations we feel sorry and we couldn't do much with the patients because the disease psoriasis per se and the pustular psoriasis, generalized pustular psoriasis in particular, has a lot of exacerbations in its lifetime of no cure. So conventionally, we know the 4 varieties of generalized pustular psoriasis. The first one, acute generalized pustular psoriasis, one Buschke syndrome, then subacute annular and succinate pustular psoriasis, then acute generalized pustular psoriasis of pregnancy, and as well we were using the term impetigo herpetiformis. Another one, infantile or juvenile pustular psoriasis. So we had about 2 or 3 cases the last few months, very tough ones. She is a 55-year-old lady working as a healthcare worker right now, and in the past 10 years she has been having repeated flare-ups. So we have decategorized her from track working position to a healthcare worker dresser. So in November she came with acute exacerbation, erythroderma. We admitted her with pustular psoriasis, and she also had drug toxicity leading to acute over chronic kidney disease. And the histopathology, once again, this was the 4th time we did histopathology. I once again confirmed the typical generalized pustular psoriasis picture. So to see the drug history, the steroids was the bottom line drug she was getting all through, and to reduce its side effects we were introducing DMARDs in between, like methotrexate, cyclosporin and other drugs, but very shortly, very few weeks to few months she would have some control over the disease, then relapses. So last 1 year we were able to give her good stable remission by using secukinumab, but unfortunately she developed acute coronary syndrome, and the cardiologist treating her said stop secukinumab or any IL-17 inhibitors. So we had to receipt for cyclosporin, and within 6 weeks of starting the therapy she came down with acute or chronic renal failure. So the case 2 is a young girl, now 21 years, with generalized pustular psoriasis. You can see the abuse of steroid, signs of abuse of steroid on her face and abdomen. At the age of 3 years, she had her first flare-up, then repeated flare-ups and a few admissions in intensive care unit also. The steroids were the mainstay for her, and other DMARDs, the methotrexate, cyclosporin, azathioprine were given for some time, but again we had to resort back to steroid because there is no consistent response to these drugs in producing any lasting remission for her. So acitretin, we are able to maintain her with acitretin, but she is young. Her parents are requesting us to declare her fit for marriage. So sooner than later they would get her married. So although we have so many drugs in our armamentarium, sometimes we are lost for imagination what we can do to a patient, particularly with the case of generalized pustular psoriasis. We are prone for repeated episodes of relapses, and that too sometimes very critical with sepsis. The third case, she is a Muslim, young Muslim lady, already have a child, but she wants to go for another child. Again, we have a problem. We have started her on all the conventional DMARDs, and secukinumab also was responsible for remission in her case, but she couldn't come so often she has to come today, those 20 doses. So we put her on acitretin. Again, acitretin can't be given for long periods in a reproductive age woman. So here there is definitely, we all agree there is an unmet need for bringing in a specific targeted therapy which is safe and effective also, reducing the severity of relapses and complications that includes drug interaction and toxicity of the drug per se, and also organ damage. So here when we think of IL-36 pathway inhibitors, this will show the pathogenesis of GPP, and by the European rare and severe psoriasis experts network definition. So GPP is defined as primary sterile bacterioscopically visible pustules occurring over non-acral skin. Non-acral skin. So this can occur with or without systemic inflammation, and there may be episodic relapses or persistent. This condition may remain persistent for over 3 months also. That is the typical appearance of lakes of pus or erythematous scaly underlying patches. So it is said that GPP histopathology resides in IL-36 signaling cascade. This IL-36 signaling cascade has the innate immune system under regulation, and whenever it is dysregulated, that leads to the GPP. So if you see, you will find a typical IL-36 receptor, then IL-36 agonists, which are isoforms, alpha, beta, and gamma. When these isoforms go and unite with IL-36 receptor, some dimer is formed after binding with the receptor. Co-receptor also is there, IL receptor, RA co-receptor. Both bind together along with the isomers. Then the IL-36 receptor gets activated and leads to further immunological cascades, giving rise to all the cytokines and chemokines, which leads to normal immune response. So only when under normal conditions, these two IL-36 receptor and IL-36 receptor antagonists are functioning normally. This will regulate the IL-36 pathway to ensure a balanced immune response. But it gets dysregulated whenever it gets dysregulated with mutations happening at the genes which are responsible for coding the IL-36 receptor antagonists, and CARD14 and API S3, these genes get deranged. Then there will be excessive stimulation of IL-36 receptor. This leads to dysregulation of IL-36 signaling, leading to excessive production of cytokine and chemokine, which increase the inflammatory cell recruitment and keratinocyte proliferation. And this will promote chemokine expression by the keratinocytes and epidermal neutrophil cells, which is characteristic in GPP. This might induce even systemic inflammation also. So sometimes IL-36 agonists also might get increased in number. Then again that leads to dysregulation of IL-36 signaling, which promotes chemokine expression from the keratinocytes and epidermal neutrophils. Again, this might induce systemic inflammation. So the dysregulation of IL-36 inflammatory pathway is important, and this leads to inflammation in the skin when neutrophils get loaded there, with forming pustules, sterile pustules. This is the underlying pathophysiology of GPP. So in plaque psoriasis as well as generalized pustular psoriasis, these keratinocytes, neutrophils, and other immunological cells are important in producing chemokines, and that leads to a cascade of inflammation, which is a vicious cycle. So when we are managing such cases, we need to hospitalize all these patients, taking care of their adequate hydration and hospitalization. And initially we start systemic steroids with oral retinoids, either methotrexate or cyclosporine. And second line, as a second line said, we start biologicals. And even some attempted therapies are also there. I don't have any personal experience. The granulocyte, monocyte adsorption, apheresis, tocilizumab, atomoxetine. In fact, we have started this therapy in one young girl after we wanted to stop, make her eligible for marriage. So acetatin we have stopped, and we put her on tafasitinib, 10 milligram BD. We must see, it's only 2 weeks duration. We must see how the remission is going to last. So the role of IL-36 inhibition, GPP, this was studied a lot, and in North America, it has been, this drug is approved to be used in adults, whereas in Europe and Asia, it is limited. It has not been given free license to be used. In India, we are only importing. They are allowed for import and use on patients, but not the manufacturing license has not been given in India yet. Of course, it is very expensive, but still the processing for procurement of the drug has started. And in railways also, we have almost come closer to closing the purchase of this drug, IL-36 receptor inhibitor, which is called Spisomelab. It comes in 450 milligram vials, 2 vials, single dose 900 mg IV is advised. And within a week, in 90% of the cases, the remissions would be induced. Very rarely, we may have to give another second dose after a week. And after this, the remission is expected to last for at least 12 months to 60 months. Sometimes in some studies, FSL2 and FSL3, with phase 2, phase 3 studies have shown up to 60 months. Some of the patients received remission after taking single dose also, some of them. Some of them had to take second dose. So of course this drug is very expensive, and it remains to be seen. No one in India has any experience with this drug. Thank you for this opportunity.
Thank you, Dr. N. Ramesh, for the nice presentation. You made it very clear and simple. And thank you very much. And I thank the organizers for giving us an opportunity to chair this session. Thank you very much.
Thank you.
Thank you to our chairpersons and speakers for this excellent session. I request chairpersons to proceed to the memento booth to collect and present mementos to the speakers. I also request Dr. Naeem sir and Dr. Sudharani ma'am to kindly present mementos to the chairpersons. Next we have session 10, and we are privileged to have distinguished chairpersons Dr. N. Prasad Nayak sir, Dr. Shankar sir and Dr. Praneeth sir. I kindly invite you to the stage to preside over this session.
Dr. Madhulika, she will.
Very good afternoon to all. I'm Dr. Madhulika Gavala. Today I've been handed the mammoth task of decoding onychoscopy. So let's jump right into it. So onychoscopy is the dermoscopy of the nail unit. It is non-invasive, it's cost-effective, and it allows the in vivo real-time visualization of the nail and its components at the sub-macroscopic level. So it's a good in-between for the macroscopic and the microscopic. So let's zoom into the scope of possibilities. What can we use onychoscope for in our day-to-day practice? So first is based on the combination of different features. we can make the diagnosis, which can prevent, the avoid the histopathological examination, the nail biopsies, which are very traumatic for the patient and cumbersome for us to perform. So we can also assess the prognosis, we can monitor the response to the treatment, we can use it perioperatively and intraoperatively to delineate the lesion which we are trying to excise, or we can find the proper site for nail biopsies. So let's just brush up the nail anatomy. So we have the nail plate which covers the nail bed. We have the lateral nail folds, the proximal nail fold, the distal free edge of the nail, below which we have the hyponychium. I want everyone to pay a special mind to the capillaries in the proximal nail fold, which are longitudinally oriented and parallel to the skin surface. So when you put a scope on this, you can see hairpin shaped loops on normal nail fold capillaroscopy. So the technique of onychoscopy, is it any different from the normal dermoscope? Not really, but nail is such that it has a very peculiar anatomy, it has a curvature to it, it has a little smoother surface, so it makes the examination a little bit more complicated. So other than that, the process is pretty much similar. We usually start up with dry non-polarized examination, which will show us the surface irregularities more properly, and then followed by a dry polarized examination, which will show the subsurface features like the pigmentation, etc., and then followed by application of a linkage fluid like an ultrasound gel. So we can then do the wet non-polarized examination first, followed by the wet polarized examination. So you should always pay mind to examine all parts of the nail unit, including the nail plate, the bed, the matrix, the hyponychium, the nail folds, and the distal free edge of the nail. So first, before proceeding to the abnormal, we should know what a normal nail unit looks like. So it's usually pale pink in color, it has a smooth shiny surface, it has a transparent cuticle, it has occasional longitudinal ridging. Nail onychoscopy, it initially started out in 1971, where they wanted to decode the nail pigmentation and used it for the same. But now the scope of the onychoscopy has expanded much beyond that. So now we do it for infections, inflammations, tumors, connective tissue disorders, and also of course in pigmentary disorders. So onychomycoscopy, onychomycosis, this is about 50% of the patients of nail disorders who walk into our clinic belong to this category. So knowing what are the features of it is very important. So usually whatever features you see histopathologically, it is because the fungus is invading the nail plate, the nail bed from the distal to the proximal part. So the onycholytic area usually has jagged edges with spikes. So this differentiates from simple onycholysis, say in trauma or psoriasis, and this is the subungual hyperkeratosis. This causes indentations in the ventral surface of the nail, which is called as the ruin pattern. So within the infected part of the nail, you see different colors. Okay, this looks like northern lights, and we call it the aurora borealis sign. And then you have the fungal melanonychia, which is because of the pigment production by the fungus. So there you see a reverse triangular pattern where it is more wider in the distal end and thinner in the proximal end. Also you can see the nail subungual hyperkeratosis, and then you also see yellowish, whitish scales on the surface. This is more like a band-like melanonychia that is seen in fungal melanonychia. Again, same the distal onycholysis that you see, but here you have a smoother edge. So it's not always mandatory to find a jagged edge. And this you see the subungual hyperkeratosis with the ruin pattern. So we can also make an early diagnosis of peri or subungual warts. You can see thrombosed vessels which are visible like reddish or black dots and streaks. And as the warts progress, you can see a yellowish white hyperkeratotic surface. So it's not just for diagnosis, even intraoperatively when we are removing the wart, we can make sure that the entirety of the wart affected tissue is removed. So Pseudomonas nail infection, this I am observing more and more in my practice daily. So this is because of the pigment production by the bacteria. You see the irregular greenish brown discoloration which almost like faded margins. Okay. So this is important in distinguishing, the color is important in distinguishing between the fungus and the bacterial. Moving on to the inflammatory nail pathologies. First you have nail psoriasis, whether it depends on whether the matrix is involved or the nail bed is involved or both. When the matrix is involved and there's parakeratosis in it, we see pitting. So here the pits are more coarse, a whitish halo around it, and sometimes a little bit of scaling of the nail plate also is seen. Then you have the nail bed changes, where it looks like an oil drop has been placed beneath the translucent nail plate. So this is called as a salmon patch. Okay, this is because of the parakeratosis of the nail bed. And then you have the splinter hemorrhages, which are longitudinally oriented, reddish purple in color, and they are present at the distal edge, very close to the onycholytic border. And the onycholytic border itself has an erythematous hue to it. So this differentiated from an onychomycotic onycholysis. And then the same thing, distal onycholysis, and you can see the subungual hyperkeratosis here is different from the one with the onychomyces. So it is more compact and you don't see the ruin pattern. So next is nail lichen planus. Here also again the nail matrix can be involved, the nail bed can be involved by inflammation, and based on the severity of the inflammation you see the signs. So you can see tracheonychia, which is the rough nails, the longitudinal ridging, the crumbling of the nail plate, a little bit of the scaling, and you can see these longitudinal streaks and this reddish areas in the lunula. This indicate an intense inflammation within the nail matrix. And when this process of inflammation, the inflammatory insults, when they keep going on, eventually it results in a formation of pterygium, which is a very pathognomic sign of nail lichen planus. And then when this insult further continues, the inflammation further continues, you have destruction of the entire nail plate, and then you have anonychia. So next, nail striatus, similar to nail lichen planus, but the inflammation is less pronounced here, and only one nail is involved, and that too in the direction of the skin linear eruption, where you see the longitudinal ridging, splitting, and a little bit of the nail bed dyschromia. So next, moving on to nail fold capillaroscopy, there are certain terminology you need to understand to talk about the pathology. So normally the capillaries, like I told you, because of their orientation, they look like regularly arranged hairpin loops. And when they are dilated, they are double the size of the normal capillaries. What is tortuous capillaries? They are a little bit more curled capillary limbs. And meandering capillaries are when these tortuous capillaries have limbs crossing over the other side. Okay, this is called meandering capillaries. And bushy capillaries, when the distal loops have buds coming out of them. This indicates like a defective neogenesis that happens in late stages of autoimmune disorders. And a little bit of microhemorrhages also you can note in the same. Qualitative capillaroscopic features, we can't do it in a day-to-day practice, but you can at least measure the mean capillary density, which are the number of capillaries per mm length of the proximal nail fold. Usually on an average, this is 7 to 14 in normal individuals. The other capillary width, capillary length, arterial and venous limb diameter, apex width, and intercapillary distance are a little more cumbersome to do on a regular basis. So how does a normal nail fold capillaroscopy look? You have the nail capillaries, which are normal in size, they are U-shaped and they are regularly arranged, no dropouts, no avascular areas. So certain normal patterns also have been described based on the distribution of the number of loops per papilla. Okay? So they can be 2 to 5 or more than 5, but usually this is all considered normal. So what is abnormal with nail fold capillaroscopy? So say in scleroderma, you see the tortuous capillaries, the bushy capillaries, okay, and the neoangiogenesis that you see, ramified capillaries. So these also have been divided into stages, the early, active and late stage. In the early stage, only a few dilated and giant capillaries and hemorrhages are seen, but the distribution is pretty much preserved. But in an active stage and late stage, which is more commonly associated with systemic sclerosis, you see large number of giant capillaries, more number of hemorrhages, you see capillary dropout areas, and in late stages, these capillary dropouts are more in number, avascular areas are more within the nail fold. So NFC is not just going to be used in just autoimmune disorders now. They are trying to use it in diabetes to see microangiopathies, and then they are trying to use it in psoriasis. So multiple different indications of nail fold capillaroscopy. Coming to last but not the least, we have melanonychia. So when there is a pigmentation in the nail, first there's an algorithm where you have to differentiate whether it's blood or really melanin. So if it is blood, it is seen as reddish, purplish globules with faded borders. And in melanin, if it is melanin, you have to see because of the melanocyte activation in the matrix or because of the melanocyte proliferation in the matrix. But when there is melanocyte proliferation in the matrix, it can either be benign or malignant, and that's when the nail biopsy comes into play. So traumatic nail onycholysis, you just see a transverse onycholysis and you see the subungual hemorrhages with the reddish purplish globules. So this is, you can differentiate them from psoriasis or onychomycosis. It's quite different in the picture. And then you have melanocyte activation, which can happen because of multiple causes. Maybe it is because of the drugs, it's physiological, repeated nail biting. You see the gray colored homogeneous band, and you see thin, longitudinal, regularly distributed gray lines. Okay, this is just simple melanocyte activation and nothing to worry about, doesn't need much of an intervention. Melanocyte proliferation. It can be like a brown background with regularly parallelly oriented longitudinal brown lines on it, or like a simple homogeneous dark band. Okay, but you can see a pseudo Hutchinson sign where you can, through the transparent cuticle, you can see a little bit of the pigmentation of the melanocyte proliferation. But this is not malignancy. You can use the skin nail biopsy to differentiate between the both. And then you have the malignant melanoma, where there is a variation in the color, irregular blurred borders of the band, and micro Hutchinson sign, which is very pathognomic of malignant melanoma. You can also see other features like nail dystrophy and ulceration, but micro Hutchinson's is one of the most pathognomic. Then you have the glomus tumor with structural pink areas and inconspicuous vessels. So in summary, I just want to leave you with the thought that nail is one such unit which probably has a limited pattern of reactionary patterns to different kinds of inflammatory or infectious insults. So there are only certain limited, say the same pitting, the same leukonychia, same onychomycosis seen in so many of the nail disorders. So it's quite confusing. So always use a combination of different features to make an accurate diagnosis, and never depend on one single feature, standout feature. So that I leave you with that thought. These are my references. So thank you for your patient listening.
Nice presentation, ma'am. Next speaker, T. Sravya, by new and newworthy latest topicals in acne vulgaris.
Good morning, good afternoon everyone. I'm Dr. Shravya. It's a great honor to be here with many distinguished dermatologists. I would like to talk about latest topicals in acne vulgaris. So as you all know, acne vulgaris is the most common skin disease worldwide. It's a chronic inflammatory disease of pilosebaceous unit, primarily affecting adolescents and young adults, attributed to various factors like hormonal changes, genetic predisposition, environmental influences, dietary changes, significantly impacting both physical and mental well-being of patients, potentially leading to feelings of anxiety, depression, low self-esteem, and social withdrawal. So this is a comprehensive acne severity system. There's a clinical grading based on the severity of acne, mild, moderate, severe, and cystic. So conventional management used to treat acne can be categorized into antibiotics, retinoids, oral anti-androgens, photodynamic therapy, light therapy, and chemical peeling. So topical treatment, coming to our topic, topical treatment is used to treat mild to moderate acne. Factors to be considered for drug of choice are severity of acne, location and extent of the lesion, patient's age, individual preferences, skin type, potential side effects, drug interactions, adherence to treatment regimens. So these are the general topical agents that we use in our clinical practice, like topical antibiotics, clindamycin, erythromycin, minocycline, dapsone, but we prefer the combination because that would not lead to drug resistance. So topical retinoids like adapalene, retinoid, tazarotene. However, combination of adapalene and benzoyl peroxide is preferred. Salicylic acid, because of its chondrolytic activity, can be used as an adjuvant along with other topical agents. Azelaic acid, because of antibacterial, anti-inflammatory activity, and also because it's a category B drug, can be given in pregnant and also lactating women. Chemical peels like AHA and BHA, because of anti-inflammatory and antibacterial property, it can be used as an adjuvant with other acne treatments. So let's delve into our newer topicals, that is topical antibiotic, topical retinoids, fixed dose combination, and topical hormonal agents. Minocycline foam. This 4% minocycline foam has hydrophobic formulation approved in FDA 2019. It has a strong bacteriostatic and anti-inflammatory properties. It's used in moderate to severe acne vulgaris in patients above 9 years of age. Because of its strong lipophilic properties, it facilitates its preferential access to hair follicle sebaceous gland, leading to skin concentration that is 850 times greater than the systemic absorption. There was no photosensitivity, phototoxicity, and skin sensitization in one study. So one study showed efficacy and safety of novel topical minocycline foam to treat acne vulgaris, in which 1488 participants were involved, and at the end of 12th week, they've shown a very good reduction in inflammatory and non-inflammatory lesions. But however, there are some side effects like yellow skin, facial swelling, pruritus, dermatitis, erythema, hair color, and change, and also drug resistance. So coming to topical retinoids, we have tretinoin 0.05% lotion, tazarotene 0.045% lotion, adapalene 0.3% gel, and trifluridine 0.005% cream. So in one study, topical treatment of truncal acne with tretinoin lotion 0.05% and azelaic acid foam were used, and at the end of 12th week, there is a good clearance of truncal acne, facial acne, and also acne on the neck. One study has shown the efficacy and safety of tazarotene lotion 0.045% in treatment of truncal acne. At the end of 12th week, 89% of the subjects have statistically significant reduction in the inflammatory and non-inflammatory lesions. It was well tolerated with a mild erythema, dryness, peeling, and pruritus. Trifluridine, this is a topical retinoid approved in 2019 by US FDA. It's a selective agonist of retinoic acid receptor gamma. This is the most common RAR found in the skin. It's approved for once daily treatment of acne over 9 years and above. It is a negligible systemic absorption. The most common adverse effects being sunburn, application site irritation, pruritus, and transient topical retinoid dermatitis. So in one study, there is a safety and efficacy of trifluridine in treating facial and truncal acne. At the end of 52nd week, the trifluridine was well tolerated and it has seen significant reduction in the inflammatory and non-inflammatory acne lesions. So the first picture shows a complete clearance of acne lesions of facial acne and truncal acne. The second picture, the combination of trifluridine topical and oral doxycycline 120 mg per day were used, and there's a very good response. So a study has shown efficacy and safety of microencapsulated benzoyl peroxide and microencapsulated tretinoin in treatment of acne vulgaris. So this fixed up dose was FDA approved in 2021. It treats both inflammatory and non-inflammatory acne at the end of 12th week, and it can be given over 9 years and above. IDP 126 Cabtrio. So this is a new topical agent which is a combination of clindamycin, adapalene, benzoyl peroxide. It was well tolerated and shown a good efficacy. So concurrent application of all the three compounds may reduce the risk of antibiotic resistance. So there was a study which was conducted to know the efficacy and safety of this triple combination, and it's known to be well tolerated by the patients. 1% clascoterone cream, it's approved by FDA in August 2020. This topical androgen receptor inhibitor competes with dihydrotestosterone for androgen receptors in sebaceous gland. It quickly metabolizes to form an active form, thus limiting systemic activity. It significantly reduces inflammatory and non-inflammatory lesions. Adverse effects being erythema, dryness, scaling, adrenal dysfunction with high doses. So in this picture, it shows clearly when clascoterone is applied topically, it binds to the androgen receptor, competing with DHT on application site, thereby limits the effect of DHT on transcription of genes, and that modulates sebum production and inflammation. So the study shows the efficacy and safety of 1% clascoterone cream applied twice daily in the patient over 12 years of age has shown a significant reduction in acne vulgaris. Topical flutamide, this is a first generation non-steroidal anti-androgen, so it is viable, efficient, safe solution with fewer side effects. However, it can be used as an adjuvant therapy. Baclizin gel, it's a H1 histamine receptor antagonist. It's also called meclizone or meclizin. So this is an antihistamine in the management of motion sickness and also chemotherapy-induced nausea and vomiting. In vitro studies, it is shown to reduce the production of chemokine 8, interleukin 1 beta, and inhibits the phosphorylation of ERK, JNK, and MEPK pathways. So there's a study which is conducted to know the efficacy of meclizin hydrochloride, and at the end of 12 weeks, it has demonstrated a very good result in the 60 volunteers. Tranexamic acid, as we all know, tranexamic acid is used to treat melasma and post-inflammatory erythema. However, there's one study which has shown that 10% tranexamic acid significantly reduced the count of inflammatory acne and attenuated skin erythema starting from 4th week of therapy. Side effects being mild erythema and scaling. Topical metformin, this hypoglycemic drug improves insulin sensitivity. It's anti-androgenic, anti-angiogenic, anti-fibrotic, and antioxidant action, has a promising therapeutic action in acne, HS, rosacea, and AN. Its effect was not studied on molecular level, but topical metformin nano-emulsion gel, 30% gel, used in treatment of acne vulgaris over 12 weeks have shown significant reduction in the inflammatory lesions. 1% ivermectin cream. This mitigates the lipopolysaccharide-mediated inflammation caused by C. acne. A recent scholar study has revealed that topical 1% ivermectin cream can improve inflammatory acne. It has potential anti-inflammatory activity without any direct antimicrobial activity. So this picture shows the clearance of acne with 1% ivermectin cream used over 12 weeks. Topical probiotic, live microorganisms like Streptococcus thermophilus, Lactobacillus strain, Enterococcus facialis and Streptococcus salivarius have a strong antimicrobial activity against C. acne and decreased production of pro-inflammatory cytokines. The side effects are local erythema, irritation, xerosis and unpleasant odor. Applied topically, it serves as a protective shield by functioning as a competitive inhibitor of binding sites, preventing colonization by other potential pathogens. Clinical trials with pipeline, we have anti-sebum agents, melanocortin receptor 5 antagonist, it's in phase 2 trial. This MC5 receptor antagonist reduces production of sebum and also reduces the size of sebaceous gland. MTC896, it's a MSH mimetic, it's still in phase 1 and phase 2 trial. Topical synthetic cannabinoid, this 3% cannabis seed extract reduces C. acne concentration, inhibits flow pro-inflammatory cytokines and also reduces erythema with significant side effects, without significant side effects. VB1953, this is a 4th generation fluoroquinolone. So topical nitric oxide gel, it's an endogenous rapid acting gas, possesses immunomodulatory and antimicrobial activity. This nitric oxide releasing nanoparticles exhibit remarkable bactericidal activity and suppress the release of cytokines. It significantly reduces in acne lesions without any noticeable adverse effects. It's still in phase 2 trial. So my take-home message would be, triferitin is a 4th generation topical retinoid that confer improved efficacy and reduce side effects when compared to older retinoids. It's used both in facial and truncal acne. Clascoterine 1% cream, which is going to hit the market in few months, is an androgen receptor antagonist, well tolerated, effective in treating acne vulgaris, especially facial acne. IDP 126, it's a cap trio, it prevents a drug resistance, it has less side effects, well tolerated and can be used in truncal and facial acne. Meclizine can soon replace benzoyl peroxide and there's a scope of using it as a first-line topical therapy for mild to moderate acne, both truncal and facial acne. Tropical probiotics and tropical tranexamic acid is a natural therapy. Regarding treatment selection, considering the factors such as efficacy, safety profile and patient preference, collaborative efforts between clinicians and researchers are essential to address the challenges of acne management, including treatment resistant and psychosocial burden. These are my references. Thank you. Thank you for giving me this opportunity.
It's a very nice presentation, extensive.
Thank you to our chairpersons and speakers for this valuable session. I kindly request the chairpersons to proceed to the memento booth to present mementos. I also request Dr. D. Indira ma'am and Dr. Shahana ma'am to present mementos to our chairpersons.
Okay, thank you, ma. Thank you, organizers, to giving me this opportunity. Thank you, one and all.
I thank all the organizers for giving me this opportunity.
There is an announcement. Someone has forgotten their iPhone charger in Hall B. Can come forward and collect it. Finally, we move to session 11, the concluding session for this afternoon. The chairpersons for this session are Dr. N. Padmaja ma'am, Dr. Nirmala ma'am, Dr. Sudha ma'am and Dr. Faria Rashid ma'am. I kindly invite all the esteemed chairpersons to the stage to preside over this session.
Good evening all. Today's topic is in this session 11, harbingers of hurdles, markers of sepsis in autoimmune bullous diseases. Let me call upon Dr. Lakshmi Sudha.
Good
Good afternoon, everyone. At the outset, I would like to thank IIDWell Telangana State for giving me this opportunity, and also I express my heartfelt thanks to Department of DVL, Usmania Medical College, for their support. Sepsis is one of the most dreaded complications in patients admitted in dermatology wards. This is because the mortality is very high. 1 in 5 patients diagnosed with sepsis dies. We need effective strategies for early detection of sepsis. Any infection may lead to sepsis. We all know that the most frequent complication of autoimmune bullous disorders is infection. Often, it is the leading cause of death. It adversely affects the outcomes in patients of ARBD. The origin of sepsis in these patients may be either cutaneous or systemic. Cutaneous sepsis, that is infection of the lesions of AIBD leading to sepsis, is the most common type of sepsis. Why are these patients more prone to infections? We all know that skin and mucosa are the first line of defense in any person. In AIBD, there is barrier disruption predisposing these patients to infection. There is also immune dysregulation due to the disease itself. And the most important is immunosuppression due to the drugs used to treat AIBD. As I already told, there are many etiological agents which can cause sepsis in these patients. It can be either bacterial, fungal or viral. In most of the studies, the most common organisms are bacterial, Staphylococcus aureus being the most common, followed by gram-negative bacteria. This is very important to remember because when we start empirical antibiotics for these patients, we should include those drugs which cover both Staphylococcus aureus and gram-negative bacteria. Coming to the definition of sepsis. Sepsis is a dysregulated host response to infection leading to organ dysfunction. Post-COVID, we all know what a dysregulated host response to infection can cause to any patient. The havoc it has caused, we all know. So what are the screening tools for sepsis? All patients who are at a potential risk of sepsis need to be identified in the wards. So there are some scoring systems to identify sepsis. The first one is sequential organ failure assessment score, which is calculated using 6 organ systems: the CNS, the cardiac, respiratory, the hepatic, renal and blood. Each system is graded in parameters of 0 to 4 to calculate the score. The rest 3, that is the quick SOFA, the modified early warning system and the national early warning system. These are all scores which are calculated using bedside parameters. If you look at QSOFA, it is used calculating the blood pressure, the respiratory rate and Glasgow Coma Scale. So, when we are having a patient whom we are suspecting sepsis, what are the clinical markers? When we start treatment and the lesions are failing to respond despite adequate therapy, the lesions are covered with a necrotic slough or there is purulent discharge. Patient is also having fever, tachycardia, increased respiratory rate, or sometimes they may be hypothermic, especially elderly, altered sensorium and fall in blood pressure. Once we identify our suspected patients, we order for investigations. The most common investigation order is complete blood picture, which will show neutrophilic leukocytosis or can sometimes show leukopenia. We have to remember that steroids themselves cause neutrophilic leukocytosis. So we have to identify the number of bad forms in the peripheral smear. Bad forms are early immature neutrophils which are released into circulation in order to fight the infection. The other features are anemia and thrombocytopenia. To identify the causative organism, we can either go for a blood culture, which should be taken as soon as possible before starting the antibiotics, a skin swab or a biopsy for culture sensitivity, urine culture, and imaging studies like chest X-ray, ultrasound, abdomen. So we also have some surrogate markers of sepsis, which can help in situations when we are not very sure whether to start an antibiotic or wait for response with steroids. The most commonly used is CRP. It is very sensitive but less specific, and we have to remember that it can be elevated even per se in autoimmune bullous disorders. Then next is serum procalcitonin. A level of more than 5 nanogram per milliliter alerts us to sepsis, to suspected sepsis. The third biomarker is serum lactate. We all know that lactate is produced as the result of anaerobic respiration in the tissue, secondary to reduced tissue perfusion. So it can be a surrogate marker that patient is landing into septic shock. But it is important to remember that no single biomarker is available which can rule in or rule out the diagnosis of sepsis. So sepsis 3R bundle is the recommendation by experts. In a patient with suspected sepsis, whenever possible, measure the lactate levels, remeasure if the initial level is more than 2, obtain blood cultures before starting antibiotics, start empirical antibiotics which will cover both gram-negative bacteria and Staphylococcus aureus, and start fluid resuscitation. So we all know that blood cultures take about 72 hours to give the reports. If the blood culture is positive, then we shift from empirical antibiotics to the particular antibiotics obtained by culture sensitivity. Suppose it is negative, then what to do? Reassess the clinical condition of the patient. Consider the possibility of atypical infections. If the procalcitonin remains raised, continue antibiotics. If lactate increases, there is a high alert for septic shock. Consider adding empirical antifungals and antivirals. Repeat the cultures and imaging studies. So what are the clinical markers of viral infections? HSV can cause either a localized infection of the skin lesions or it can present as eczema herpeticum. It has been postulated that when there are fissures or linear erosions or erosions with angular edges or erosions covered by the hemorrhagic crust, we should always consider the possibility of HSV infection. Varicella zoster virus can present either as classic form or it can present as papules with central eschar, that is ecthyma gangrenosum like lesions. Another most important cause of non-bacterial sepsis is candidemia. Patients who are neutropenic and who have taken broad spectrum antibiotics are susceptible to candidal invasion. To prove candidal colonization, candida has to be cultured from at least 2 sites. We also order a blood culture. Beta-glucan test, this is a surrogate marker to identify candidal infection. Beta-glucan is a component of all fungal cell membranes, and a raised beta-glucan in a patient with suspected sepsis likely points towards candida. So sometimes the invasive candidiasis can disseminate to the skin and can present in the form of pink papules or nodules, most commonly on the extremities and trunk. So we have, this is the next step. When fever is still persisting, irrespective of adding antifungals and antivirals. So as we have ordered for repeat cultures, if they throw any light, change the drugs. Look for non-infectious cause of fever like autoimmune fever or drug fever. Consider reducing the dose of steroids. We have to remember that debilitated and immunosuppressed patients may demonstrate attenuated febrile response. Skin lesions, no matter how small or innocuous in appearance, should be carefully evaluated. So the take-home message is thorough history and monitoring of skin clinical signs plays a crucial role in the early identification of patients with suspected sepsis. Biomarkers can help in identification, prognostication and management. These are my references. Thank you.
Thank you, Doctor. So we'll go to the next speaker.
The next speaker, easy to diagnose yet difficult to treat. A lecture on recalcitrant dermatophytosis. I invite Dr. Satyapal Vengareddy.
Very good evening to all, and I convey my thanks to the organizing team for giving me the opportunity. So yeah, everybody knows that dermatophytosis is a very old and topic, but there is a need to discuss about this topic as such, because I think we are slowly losing the comfort and easiness of the treating dermatophytosis infections nowadays. So recalcitrant dermatophytosis is a persistent glabdystenia, generally in settings like chronic, recurrent, corticosteroid modified and resistance cases with poor or no response to standard treatment. But it doesn't mean that it's not always due to resistance, because most of the centers with multicentric studies showing that resistance is the last reason, not but the maybe the last and the minimal, I mean less percentage of cases are due to resistance, not the other way. And there we should differentiate from, I mean, reasons, when you're elaborating the reasons for recalcitrant dermatosis, we should look for whether it's a relapse or recurrence or resistance or tolerance. Recurrence means infection usually after 4 weeks of completion of the approved systemic therapy, and tolerance means in vitro there is a still sensitivity, but there is no mycological cure or clinical cure. And what are the factors implicated in recalcitrant tinea? We look at this. Basically, when you see the case, when the patient present to yourself with a history of persistence of tinea of many weeks or months, you should see which type of tinea is there and which sites are involved, and which type of fungal types or species you are expecting, and what is the barrier integrity, and what is the host immunity, and quality of drugs and compliance of the drug, etc. And what is the compliance of the patient, how is the patient is taking and following the instructions of the doctor, and any chance of resistance in that case. And what are the clinical type of tinea? The most common cause of recalcitrant tinea in India is steroid modified tinea, that is tinea incognito. This is the most common cause, and followed with the very rare and uncommon presentations like vesicular or granulomatous tinea or verrucous tinea. And there are very rare types also there, deep or subcutaneous dermatophytosis, which have been reported under the names like disseminated trichophytic granuloma, dermatophytic mystoma, tinea profunda cysticum, subcutaneous abscess. Practically, I never see one case of this actually. And another common are Majochi granuloma or tinea implicata. And coming to the types and locations where the tinea is presenting. See, basically we miss one thing is when the patient is presenting with various sites of fungal infection like tinea corporis at facies, tinea corporis at cruris, and sometimes we'll miss the association of tinea pedis. And that is very important. Sometimes, you know, when you treat the patient with the approved systemic therapy, the corporis and facial lesions may resolve, but we may forget sometimes the persistence of the tinea pedis due to anatomical factors and where the drug factors. We should always see whether the associated tinea pedis is there or not. And one should be think that the lesions, how the lesions are appeared. If the lesions are chronic, leathery, lichenified, that indicates that there is a protective immunity of Th1 type is going to depress, and there is activation of Th2, which indicates there is chronicity. Like, you know, you see atopic dermatitis, there is a persistence of Th2 type of immune reaction. And coming to that, and tinea manum and pedis, these both areas are very difficult and chronic to treat. Okay, and the other, not only these, there are other complications like complex diseases like presentations may be there, like non-dermatophytes infections like Neocystidium dimetadum and Neocystidium hyalinium, like they may present like mocassin and interdigital type of tinea pedis, but they are not the dermatophytosis. And there is presence of candida species, like especially in interdigital type, and there is a dermatophytosis complex, which is nothing but superimposed infection of bacterial invasion. And there is a new thing which is nowadays is becoming so popular, there is trichophyton tinea indotineae, which is a new one in the picture. And another thing is the presentation of the tinea on multiple and unusual sites. This is also one of the reasons for the recalcitrant tinea due to poor compliance and the, not advising the proper drug actually. There will be very rarely due to tinea rubrum, there is invasive dermatophytosis, especially in immunocompromised status, where there is a lowered immunity and the rapid spread will be there. And there are very few case reports are there, hematinous spread, which is shown at present as acute ulcerating and draining dermal nodules. And especially in cases where there is autosomal recessive capsaicin recruitment domain family member 9 deficiency, which can cause deep dermatophytosis. And fungal species and types. See, we should remember there is which type of fungal infection is actually the patient is presenting. Whether it is anthropophilic or zoophilic or geophilic. Typically, a given dermatophyte induces more severe inflammatory reaction in a host to which it is not adapted than does it in natural host. Generally, if it is non-anthropophilic, may be chronic, but may not be more severe inflammatory, whether compared to zoophilic or geophilic infections in human beings. And second thing is there is in anthrophilic, there will be more scaly and pruritic but less inflammatory. If it is more inflammatory, we should suspect it may not be anthrophilic. And sometimes tinea, nowadays, trichophyton rubrum to be the commonest cause as per the data, but slowly there is chance, there are reports that trichophyton mentogrophites and interdigital types are increasing in numbers. And this trichophyton interdigital, which causes support the immune system, leading to improved host adaptability of this species to humans over time, which is the local immunosuppression by steroids, making it easier to establish chronic infection and cause recalcitrance. So to do this, there is very difficult to slough off the fungus from the body. And which is the most common thing we'll forget in the patients of recalcitrant dermatophytosis, barrier defects, especially the steroid abuse and the scratching, which causes there is a compromisation of the barrier integrity. There will be epidermal proliferation increases several fold in tinea, in affected skin especially. And inflammatory keratins like K6, K16 and K17 and basal keratins like K5 and K14 will increase, and there will be decrease in the envelope proteins like leucerin, involucrin, acetylene protein decrease, and there will be reduced filaggrin expression, which correlates reduced skin hydration, furtherly leads to transepidermal water loss. And this is exactly what happens with atopic dermatitis, in which case we need a bland emollient or ceramide based moisturizer which can help us. And there are proven reports and studies that there will be significant lower cytotoxic effects of T cells against dermatophytes compared to normal controls in the patients of recalcitrant dermatophytosis. There will be suppression of lymphocyte proliferation also. And the notorious one is steroid abuse and the dermatophytosis. Generally there is rather than humoral immunity, cell-mediated immunity has a well-established role in the clearance of dermatophytosis. The Th1 response helps in clearing the infection, whereas the Th2 response makes the disorder persistent. Steroid reduces the Th1 response markedly and aggravates tinea. This usage of topical steroids suppress the local defense mechanisms and causes enormous fungal growth. And coming to drug factors, especially pharmacokinetics and pharmacodynamics, and along with that, the quality of the drug also very important. I would like to mention few points about the drugs actually what are we using routinely. That is terbinafine, which reaches actually by passive epidermal effusion through sebum, which reaches the stratum corneum, and through the incorporation of the drug from the migrating basal keratinocytes. The general routine dose is 250 milligrams OD for 12 days. When you continue for 2 to 3 weeks oral therapy, it will be persistence 2 to 3 weeks after the stoppage of therapy also. But the one thing is there is no pharmacological logic, because terbinafine has got 14 to 16 hours of action off-life, so that it's better to give OD or BD rather than single dose of 500 milligrams. And coming to itraconazole, which is the most commonly used first line of drug, many in dermatophytes, whether naive or resistant or recalcitrant, which is by passive diffusion from the plasma to keratinocytes with strong adherence to keratin. And it is detectable in 24 hours in the sweat. Despite early detection in sweat, excretion of itraconazole by the suit is very minimal. But this persists in stratum corneum for 3 to 4 weeks after the discontinuation therapy, which the presence of sweat may be early, but it may not effective as griseofulvin, ketoconazole, and fluconazole when compared to sweating. Fluconazole, which accumulates in the stratum corneum by sweat, by diffusion through the dermis and epidermis, excretion in the sebum may be more limited. After discontinuation of therapy, there will be rediffusion of fluconazole from the skin to the systemic circulation, but a rate lower than the elimination from the plasma. Implications: most antifungal drugs achieve sufficient high levels in the skin way beyond the MACs. MACs are not the holy grails here. MAC of the oral drugs is less than the topical drugs of the antifungal medication. Drug persists for 3 weeks after starting therapy, approaching beyond 250 milligrams, as I said, and more than 200 milligrams itraconazole has a little pharmacological value. It may cause asymptomatic liver damage.
Dr. Satyapal, time is up.
The ideal drug will be dependent on the secretion profile and site. And one I would like to conclude, and compliance, which is very important, and we should rule out recurrence and reinfection. How to approach? We should rule out history of steroid abuse, and whether skin and oily skin or dry skin, and how much drug previously she used, and avoidance of H2 blockers. And if it is dry skin, it's better to go for fluconazole. If it is oily skin, prefer terbinafine or itraconazole. And yeah, so complaints is very important. Every 3 to 4 weeks, the patient has to come, we examine, and we should look for the clearance, whether the drug is working, whether the patient is compliant. And there are precautions, as you know, I don't want to mention. And one thing is the family history also very important. We should rule out any family history. Otherwise, if you're not treating the family member, it's going to reinfect the other family members. It will spread to entire family. And avoidance of application of topical steroids is very important. Should counsel the patient. If you stop steroids, there will be over-counter phenomena and there will be flare-up of the fungus. Initially, we should counsel the patient for the better complaints, and we have to ask them to continue the medication for at least 6 to 8 weeks. Thank you.
We have one more talk left in this session. After that, we will move on to valedictory ceremony. I kindly request everyone to stay back and join us thank all those who made it a success. Let's now proceed with the next talk.
So I call upon Dr. Alekia Singapore for the session Sharing is Caring, a synopsis on social media and dermatology.
Good evening, everybody. Without wasting much time, I know everybody's tired. I'll try to finish the PPT as quickly as possible, also keep you entertained as much. I'm Dr. Alekia Singapore, and I'll be talking to you all on the current trending topic on how skin and hair has become not just between the dermatologists or among the dermatology fraternity, but is there everywhere. But we also see most of the dermatologists are also inclining towards the non-dermatic trends. That's causing a lot of havoc in our own fraternity as dermatologists, seeing these new skin and hair clinics without dermatologists being popped up everywhere in the city and in the state. But again, it's always important to save our own fraternity, so this is just my very tiny attempt to make sure that we all are in the right place first. I'll be talking about balancing professionalism and visibility, because we all need visibility in this generation for having our clinics at place. Social media could be a double-edged sword. One is it empowers the dermatologists to educate, like we give the awareness to the patients on what not to do and what to do, and it obviously takes our topics to the wider audience, and it promote skin health awareness. But also there's other side to it. When there is risk of spreading misinformation, like most of them are doing these days who are non-dermats, also who are dermats, which I'll be talking in the further slides. Eroding the professional integrity, which is a very important thing in our profession, and also encouraging unsafe practices when misused. When I'm talking this, I kind of mask the name of the dermatologist who's having 1 million followers, but she is a dermatologist. There is a rise of social media platforms like your Instagram, your TikTok, your YouTube, etc., where dermatologists connect with their audiences enabling them to reach millions with just a single post or video. And the growth has opened opportunities to educate people. Initially, it was to educate people on skin health and raise awareness about the conditions and also debunk these myths and facts most of us have in skin and hair health. Now when I'm saying double-edged sword again, there is still rapid expansion also that comes with these challenges. Dermatologists must balance the desire to grow the personal brand and also market the services with responsibility to provide accurate information. But also ethical concerns are something that we need to keep in mind, where where the focus shifts too much towards gaining followers and making money out of it, which leads to definitely misleading content. Striking the balance between these two is crucial, maintaining professional integrity and also leveraging the benefits of social media, which I personally think it's not that hard because I'm also in the same field. Now what does misuse look like? First thing is unclaimed, unverified claims. Most of the products that are there commercially and not medically, dermatologists use those products to portray it. This is one example. I asked the face of the dermat. She's saying how to use snail mucin, and this is from a dermatologist. I don't think, I can take different views from you all if anyone is ready to, but I don't think this is the right way that we want to approach a patient. And if my patient is watching me doing a snail mucin mask video, I don't think she'll respect me as a dermatologist. She might find me equally to her highly educated skin parlor lady than a dermatologist. There will not be difference between me and her. The next one is overemphasis on aesthetics. Since post-COVID, most of them have moved towards being skin conscious, hair conscious. So glorifying the beauty over skin health, creating unrealistic expectations has been the trend these days. The third one is patient privacy breaches. We randomly take videos of patients when we are doing procedures without masking. The basic ethics that we follow is to mask the eyes and mask the identity of the patient, which they don't do because they want to take pictures or do videos with celebrities in different industries, which I don't think is the right way because that is not ethically right. Another one is clickbait content. Sorry. Using sensationalized or misleading content to attract views. When I say this, here are 3 tips to make you glow skin instantly in 1 hour. Those kind of hooks most of them use just to attract patients and making us look differently, making us look similarly to those who are actually non-dermats as well. So these are few of the practices the dermatologists these days are using, and it is a concern to us because they are dermatologists. Why is it a problem? Definitely having a misinformation, this leads to public's distrust. That the same is happening now because most of the patients are not able to understand the difference between a dermatologist, dermatology clinic, or a parlor with a skin clinic, or anyone who says skin and hair are equal to a dermatologist and they're ready to take the treatment. Second one is erosion of professional integrity. It is completely diminishing the credibility of the field, as we all can agree to that. Another one is patient harm. Potential physical harm for unsafe DIY trends or unproven treatments. Most of the dermats these days are also open to telling them DIY treatments, घर पे ये चीज़ें हैं तो ये मिला के लगाओ, आपको जो भी treatment के बाद आएगा different, same thing you'll get it with the DIY treatments as well. I don't think, no matter what the scientific effect says, I don't think sharing DIY things into your own social media accounts is not as great as a dermatologist that you would like to be. Keeping in mind a very important fact, legal consequences. Breach of ethics or privacy laws is also something that we need to keep in mind. This is one of the examples that I've shared. On the left side is one of the doctors. I masked the names of all the doctors who's also sharing the name of the product, including the pricing of it, and writing this is supplements for glowing skin. And the second one is actually telling how to do 1 to 2 hours after meal, preferably with orange juice, add calcium supplements. What are we trying to be here? Are we trying to be dermatologists, doctors, or salesmen? Or trying to run a pharmacy, or trying to, I'm not sure what. I'm really lacking words when I see these kind of things. Another one is, there was a popular trend which says slugging a derm. Even if it is not a scientific backup concept, just because it is there, a dermatologist also wanted to try, and he put it up in his video. Seeing him, all the dermats started doing this. Not even once I think anyone have thought about the effects, side effects, working non-affecting works of the trend. And the other one which we see is, they also compare prices of the products. I don't think we are good at writing prescriptions, but I'm sure writing prescriptions is only the line where we have to draw and not be a salesman or a salesperson to the patients. Let everybody do their job. We're not some pharmacists or salesmen to do these kind of comparison and try to sell the products on, especially on social media. That is going to break your own credibility. The root causes of misuse is definitely the first one, pressure to gain followers. There's a huge, strong race to gain likes, comments, and followers on your social media. The more followers, the more money is what they all think. So this, just to get the number of followers, they're ready to do any trend, put up any photos of products, or do any kind of trends. Next one is monetization. Financial incentives from these brands for product endorsements is the main attracting feature for all these people who are doing it. Sadly, dermatologists also fall into that category, and that's also one of the reasons it's creating a problem. Another one is lack of regulation. There is a very clear-cut absence of guidelines for medical professionals on social media, what to share and what not to share. Overemphasis on aesthetics, focusing on cosmetic dermatology for visibility. All these dermatologists that we see, none of them, at least 80% of them talk only on cosmetic products or how to use this machine and what machine they bought in their clinic and how is it, and how is the handpiece doing, how is the intensity works, and how everyone is just talking about that. I think we're all forgetting clinical dermatology is the main building block of dermatology, and the other side of it is aesthetics. So people are using this and overusing it and reducing the credibility of the dermatology. Here are some ways I think should use social media right. One is to share evidence-based content and professional insights if the dermatologist knows the right evidence. Otherwise, let him or her not share it all. Prioritize patient privacy and obtain explicit consent. If you're sharing some person's video, make sure the consent is there. Avoid promoting trends without scientific validation. As I shared, there was a doctor who was talking about how petroleum jelly Vaseline applied overnight is going to give you a Korean skin. I'm not sure if Indian can become a Korean just by applying petroleum jelly, but if these kind of things are supported and promoted by a dermatologist, a senior most dermatologist who's globally known, then I wonder where dermatology is heading up to. The other one is to educate rather than sensationalize. It's always important that you do videos. We're not against anyone doing any videos on social media marketing, but please make sure it's educational and awareness videos rather than dancing and showing some kind of sensationalizations. The next one is to follow professional guidelines. We all have professional guidelines as dermats. We learn that before we come out of a college. So make sure we're sticking to the professional guidelines as well. Final thoughts would be social media too. Dermatologists must balance education, engagement, and professionalism. And by addressing misuse, the field can maintain trust and authority. And last but not the least, this is my page, which says I have 323k followers. I hope this comes out right. It is not to advertise my page, but if you all can go back to my page and see, there will not be anything that which I said is wrong. Because if I can do what is ethically right and gain so many, I'm sure everybody can do better than me. So I request all the dermatologists here and the future dermatologists and the dermatologists who are already doing this to set back the trend straight and make sure that we are doing it right and show us that we are dermatologists but not any other skin parlor ladies. Thank you so much.
Wonderful presentation, Dr. Alekia.
Thank you.
And by this, we conclude this session. And I thank Team Cuticon and Dr. Sudhavani for giving this opportunity.
Thank you all for giving us this opportunity to chair the session.
Thank you to our chairpersons and speakers for this wonderful session. I request our respected chairpersons to proceed to the memento booth to collect and present mementos to the speakers. I also request Dr. Venkatakrishna sir, Dr. Manmohan sir and Dr. Pratap sir to kindly present the mementos. Thank you everyone for your attention throughout all the sessions. Now we move on to the valedictory ceremony. I hand over the mic to Dr. JVDS Prasad sir, Telangana ADVL Secretary, to take it forward.
Good evening all. So we came to the final session of the day of the Cuticon valedictory. So we are so happy to see many chairs filled with our delegates. So usually we see less people and more chairs. But today is a great occasion where we see good number of the chairs filled with delegates. That itself talks how beautifully we conducted the conference, the ECF 2024. So in this process, I will invite our President, Dr. A. Venkatesh sir, to come onto the dais and occupy one of the marks. Dr. A. Venkatesh sir. Next, I invite our President-elect, Dr. V. Ramesh sir, to come onto the dais and occupy the chair. Dr. Ramesh sir. Now I invite our immediate past president, Dr. Anup Kumar Lahari sir, to come onto the dais. Sir, Randy, Ramesh sir. Sir, Anup Kumar Lahari sir, A.K. Lahari sir. Now I invite our two vice presidents, Dr. K. Sai Krishna and Dr. K. Lakshminarayana sir. Dr. Sai Krishna and Dr. Lakshminarayana. Now I invite my treasurer, Dr. M. Shahana, to come onto the dais. Now I invite my two joint secretaries, Dr. Tulasi Jaran and Dr. Vishwanath Raj, to come onto the dais. And more importantly, the person behind the success of the stage drama, the academic drama, and our scientific chairperson, Dr. D. Sudhavani ma'am, to come onto the dais. Dr. Sudhavani. Now we have a series of awards to be presented to the group of the people on various categories. Before the award presentations, I request our President, Dr. A. Venkatesh sir, to give his presidential talk to the people.
So good afternoon all. So today came to the conclusion of our conference, Cuticon TG 2024. So for these last 2 months we have been doing hard work. With all your help and coordination, cooperation, we could do this. I thank everyone, especially senior doctors and colleagues and delegates and junior colleagues and especially pharma companies and other supporting staff. I thank you all very much for making this conference very successful. Thank you all.
So I request our President and our scientific chairperson both stand together and distribute the awards in the line I called. So let me start the distribution of awards with our great honorable Dermatologist, Old Timer, Dr. R. Patnaik Thesis Award. Dr. R. Patnaik Thesis Award that goes to Muhammad Niyaz Ahmad of Usman Medical College. Dr. Muhammad Niyaz Ahmad. Is he there? Yes. Niyaz. Photos is not. Photos. A cash award and also a medallion. Now, I have a privilege, congratulations, calling in award paper winners. So, second award goes to Dr. Tummuru Lakshmi Hanish Kumar. He is from RVM College. Madam, it is second prize. Yeah, చూసుకోండి ఒకసారి. Dr. Tumush Harish Kumar. Is he there? రండి పరిగెత్తాలి. He is from RVM College. Medal le. Only cash award only. రండి. The first prize goes to, for award session, Dr. Pamu Bhavani from ESI Medical College. Dr. Pamu Bhavani. We congratulate Dr. Pamu Bhavani for winning the award in the award paper sessions. Do you have your HOD with you? HOD. Right, okay. Please accept our award. The first prize for award papers goes to Dr. Pamu Bhavani from ESI Medical College. Yes. Now we have 4 sessions of free papers, and each session is awarded with 2 awards, first award for paper and second best paper. And for session 1, the first best paper award goes to Dr. Rachana Narendrula from Gandhi Medical College. Dr. Rachana Narendrula. All medical companies are requested to sit in the main hall. All medical companies. Yeah, in the session 1, whereas the second prize was shared by 2 postgraduate students, they are Dr. Apurva Nagireddy from Apollo Medical College and Dr. Lucky Reddy from Gandhi. Dr. Apurva Nagireddy from Apollo Medical College and Dr. Lucky Reddy from Gandhi. They have tied the second best paper from session 1. So I invite both of them. Hey Badram. For session 2 of the free papers, the first prize goes to Dr. Prasanna from Gandhi Medical College. Dr. Prasanna from Gandhi Medical College. And the second prize goes to Dr. Rakshit from Usmania Medical College. Dr. Prasanna, please. Dr. Prasanna. Yeah. And for session 3, there are 2 awards. I invite the winner of that session 3 is Dr. Purnima Bouquet from RVM and Dr. Sriya Reddy, second place from ESI. Dr. Purnima Bouquet from RVM got the first place and Dr. Sriya Reddy from ESI got the second place, session 3. So I invite the both, please fast. Run baby run. Purnima, you are Purnima, come. Now it is for last session, session 4. There are 2 winners. So I call back the second winner first because they have the long name. Dr. Konala Bharati Satya Sai Nagalakshmi. Dr. Konala Bharati Satya Sai Nagalakshmi. She is second prize. And the winner of the session 1 first prize is Dr. Pallavi P from RVM. RVM. Dr. Pallavi, is she there? వస్తున్నారు పల్లవి వస్తున్నారు పరిగెత్తాలమ్మా పరిగెత్తాలి. So with this, the award papers and free papers have been declared, and the remaining is the posters. When it comes to the posters, we have selected top 5 posters from the 105 poster presentations. Out of 105 posters, we have selected 5 posters as the top best 5 posters. And I call upon Dr. Simran Fatima from SVS. I repeat, Dr. Simran Fatima from SVS. Sai Santan Reddy from SVS, K. Muthupriya from Gandhi, Dr. Papa Shravika from Chelmeda Institute of Medical Sciences, Chelmeda Ananda, KIMS, and Dr. Anjali from Gandhi. So I repeat, Simran Fatima from SVS, Sai Santan Reddy from SVS, K. Muthupriya from Gandhi, Dr. Papa Shravika from Chelmeda, and Dr. Anjali from Gandhi. All the 5 please come onto the dais, please. So there is a session for giving medals for the volunteers. So I have a series of volunteers. I cannot name them one by one. So I request all the medalists, all the volunteers, to come onto the dais to have a medal presentations. Medals for volunteers. Volunteers, please come onto the dais one by one.
We request all the volunteers to come on to the dais. I'll call out the names.
Manamna.
Okay, I call the volunteers in line. Oh, Dr. Pabba Shravika onto the dais, please. Dr. Pabba Shravika. She is from Chelmeda, posters. So the list of volunteers goes like this. I request all one by one to come onto the dais. From Gandhi, it is Lucky, Shivani, Sirisha, Rachana, Anjali, Lohita, and Akhila. Andhra okay, sir. The team from the Gandhi, the PGs who helped us in the Cuticon 2024, all 7 please come onto the dais. Lucky, Shivani, Sirisha, Rachana, Anjali, Lohita, and Akhila. Next, I request Usmani team to stand in the line. Dr. Rachana, Dr. Sampada, Dr. Deepika, Dr. Chaitanya Gopal, Dr. Sana, Dr. Pallavi, Dr. Harsha, Dr. Manju, Dr. Archana, and Dr. Anuradha. I request all these people to come onto the dais, please, as a group. I repeat once again. Dr. Rachana, Dr. Sampada, Dr. Deepika, Dr. Chaitanya Gopal, Dr. Sana, Dr. Pallavi, Dr. Harsha, Dr. Manju, Dr. Archana, and Dr. Anuradha. The Usmania postgraduates who helped for the Cuticon. So I invite the Bhaskara team, Dr. Shruti and Dr. Narayani from Bhaskara Medical College, who helped for the Cuticon 2024. Dr. Shruti, Dr. Narayani from Bhaskara. Unnarandi? Okay. Next I invite the postgraduate Dr. Kirti and Dr. Apurva from Kamineni. Dr. Kirti and Dr. Apurva from Kamineni. మీరు ఒకరే వచ్చారా? సార్ ఈవిడికి 2 ఇచ్చేయండి. యు ఆర్ ఫ్రమ్ కీర్తి అండ్ అపూర్వ. ఈ అమ్మాయికి 2 ఇచ్చేయండి సార్, వాళ్ళ కొలిగ్ కూడా ఇచ్చేస్తుంది. డాక్టర్ కీర్తి ఫ్రమ్ కామినేని. డాక్టర్ దియా ఫ్రమ్ కామినేని అండ్ డాక్టర్ అఖిల, శ్వేత, సాక్షి. Dr. Akhila, Dr. Sweta, Dr. Sakshi. Unnaready? Come, please. And from Apollo, Dr. Haindavi and Dr. Apurva. I invite Dr. Harshita Reddy, Dr. Saujanya, Dr. Karthini, and Dr. Shruti to come onto the dais, please. Dr. Harshita Reddy, Dr. Saujanya, Dr. Karthini, and Dr. Shruti, please. Thank you for conducting this session on the day 1 pre-lunch and post-lunch sessions and on day 2 pre-lunch and post-lunch sessions. Okay. Scientific. Okay. So, the success on the dais is because of the work done behind the screens by a team of doctors whom we call them as a scientific team. The team was led by Dr. Sudha Vani ma'am and consists of the following people as coordinators and members. So I invite Dr. Sudha Rani ma'am, who is the coordinator for the scientific team, and I invite Dr. Sudha Rani ma'am onto the dais. Dr. Sudha Rani. Rani. And I invite Dr. Sai Krishna, happened to be our Vice President also, to be the scientific coordinator, come on to the dais. Please, please. And third is Dr. Sudhir, Dr. Neelam Sudhir, we lovely call him as a blue boy of the Usmania. I invite Dr. Sudhir to come on to the dais, he is also third scientific coordinator. So 3 scientific coordinators we have, Dr. C. Sudharani, Dr. K. Sai Krishna, and Dr. N. Sudhir. And I invite the scientific committee members in the order: Dr. Gopinath from Gandhi, Dr. Tina Priscilla from Apollo, Dr. Madhavi Reddy, the practitioner, Dr. Swapna Priya, practitioner, Dr. B. Rakesh Kumar, civilization surgeon, Dr. Lakshmi Sudha, assistant professor Usmania, Dr. V. Manogna, assistant professor Usmania, and Dr. K. Sravani, assistant quiz master of the Telangana state from Usmania Medical College. So I repeat once again, Dr. Gopinath, madam? Okay, please. I repeat once again, Dr. Gopinath, Dr. Tina Priscilla, Dr. Madhavi Reddy, Dr. Swapna Priya, Dr. Rakesh Kumar, Dr. Lakshmi Sudha, Dr. Manogna, Dr. Sravani, and Dr. Kranti from Usmania, Dr. J. Kranti from Usmania. I invite all these people to come onto the dais and please accept. Yeah. And Dr. Lohita T. She is assistant professor Usmania. Dr. Kranti is assistant professor Usmania. And most importantly, the moment I tell her name, all you will go into the cloud 9. The Ghana Bajana. We call it as banquet. Yesterday's success of the banquet is because of purely one person, not one person but 2 persons. I invite those 2 persons onto the dais. I did not name them. By this time you will know that who is those persons. Dr.
Monita all-rounder. Please come on to the dais. Next, Rajalakshmi madam, dynamic one.
So Dr. Monita ma'am and Dr. K. Rajalakshmi ma'am are invited to Dr. Dais for success of yesterday's banquet. So andaru kudanu lechi nunchuni oogi taagi padipoyi. Okay. So we don't have background music, but still. And in the medallion presentations, I invite the greatest experienced person on stage management. And I happen to be the retired faculty from the Usmania Medical College. And I entered once again as a retired professor on contract basis, the senior most faculty of the DVL department from Usmania, Dr. Aruna Samarth. Dr. Aruna Samarth. Madam, Dr. Aruna Samarth. ఉన్నారా మేడం? Dr. Aruna Samarth. Next. Next batch. So I request all dignitaries to sit on to the occupy their chairs once again. And now, whatever the activity that we have done, we should know how it is. So we simply call it as a feedback, or few encouraging words, or few areas where we can improvise upon. Though we as a team may not have an opportunity to improvise, our next Cuticon team 2025 is here, and they will learn a few things how to do the best, the more better way than us in the year 2025. So I request some of the delegates, some of the faculty to give their feedback about the Cuticon 2024. So I request Dr. Manmohan sir. Sir, you have two teams here, 24 team and 25 team. 25 are observations and 25 advices.
So thank you, JVD, and thank you the team for giving me a wonderful conference. Initially, Venkatekrishna was my student, I know. A very casual going boy. And I know that he can take it so seriously and do such a big conference. You have done it. Congratulations. Everything was spick and span. The hall, I think third time we are doing conference here in this hall. Third time. And of course, Dr. Sudha, Vani, the scientific, they've done a wonderful job along with JVDS, the silent worker. He only comes, does things and go away. So JVDS is the backbone. I think I pushed him to become a secretary. I told him, so that way I think one thing is we are slowly coming on to become punctual. Otherwise, you know, our times used to go beyond 6 o'clock, 7 o'clock, and then they used to fight in the general body and go home. But yesterday, wonderful entertainment, then comfortably done banquet. So I think it's all hip hip hooray to the team. And I wish Ramesh another grand conference at Warangal, which we have attended once. So it will be a second for Ramesh. That was a combined one. This is for the other people, you know, along with him. I know, I'm sure that you'll do the best out of it. So wish you all the best, sir.
So I sent mic into the audiences. I request a few positive or negative feedbacks, whatever suggestions, whatever it is.
A very good conference on the stage, off the stage, and everybody has put so much effort, or else it will not come. It will not come to this level. The silent worker, as Dr. Manmohan put, JVDS has done a lot of work, and it is. Another thing is, you have used the technology to the advantage. By the time I went to chair the session of oration, on my phone it is there. So I didn't see that. I read that, I talked as if I know. It looks very good, but the credit is the background worker. So that is in 2006 we did not have this. So we were working for that at that time. So I know the importance of hard work and execution, cooperation, and beyond everything, no expectation. You haven't expected anything. You wanted to do it, you did it very well. And as Dr. Manmohan said, Venkat Krishna, when I joined as a professor and as in the unit, just left. So he's one of the very casual persons. He didn't lose his stint of casualty and thing, but what is serious, he has taken it as serious. And one more comment I say, some may feel bad, is creation of Usmania. The Usmanians there are many people who have inculcated, and Dr. Lakshmi Madam, Dr. Manmohan, all these people, they are grinding stones who have polished many people. So that is, I feel proud. I worked very long and I have a love for that institution. And I saw another two institutions, my mother, alma mater, Andhra Medical College. I worked for a short while in Gandhi, but they don't come anywhere near Usmania. So what we were imagining, now Bhumesh has made it true by giving. So every one of you have done a very wonderful work and a hard work and executed meticulously, each one of you. I cannot say. Only thing is, President, Organizing Secretary, and Scientific Committee Chairperson, Dr. Sudhavani, you are the leaders for it. You executed it. Hearty congratulations.
Thank you. Thank you. So, if I don't detail about one person, it is truly not good on my part. So, I will tell you small background. Actually, in the month of May or June, we thought of conducting this activity at the NIN. There is a new wonderful auditorium. So we approached the NIN authorities and we told the date will be in the month of December, and they said that it will be confident that they are going to complete the auditorium and they will give the auditorium to us. But in the last minutes of in the month of October, when we approached the authorities, they said that there is small pending work is there, and in the government protocol, without completing the total work and without getting the approvals, we can't give the auditorium. So the moment we heard that news, almost we shocked, both me and Venkakrishna sir. Then we looked toward 360 degrees and we saw the face of Dr. Nani Setti Ramesh. The moment we approached him, he took us to the railway Nilayam and he blocked the dates for January 4th and 5th, and he is the instrumental behind the success of this program at this venue. So I invite Dr. Nani Setti Ramesh sir onto the dais to have a medallion from our President and President-elect from our team. Dr. Nani Setti Ramesh sir. Sir, thank you so much. Because of you, at every step, this auditorium and this success is happened, and we reciprocate that in the form of felicitating you with a small medal. Sir, please accept the small medal.
My hearty congratulations to the present EC, led by Dr. Venkat Krishna, Dr. JVDS, Dr. Shahana, and the scientific chair, Dr. Sudhavani Madam, and all the other members of the EC. But for their grit and determination and innovation, this conference would not have been so successful. They have been very hardworking throughout the year. First few months it was cakewalk for them. They organized quite a few CMEs and public health activities like Chalo Pathshala. When they were suddenly disturbed, their habitus from Usmania and Gandhi, many of the EC members were disturbed far away to the city. So, but then still they managed to have a communication amongst themselves. They got along well, communicating and organizing things. The best part of their functioning is inclusiveness and having the right persons at the right job. So that is ergonomics. So that is the highlight of this present EC, and I really compliment them for having great understanding and self-belief and bringing it out this conference such a huge success. Both youngsters and veterans have been equally been impressed with the scientific content and the cordiality and brotherhood that we had last 2 days. Fantastic oration by Dr. Mercurial Bhumesh Kumar, who is the feather of our Telangana state. Last just 7-8 years, he has risen to the international standards, all because of the cooperation, coordination from the Telangana state IIDL members. And I wish I invite the incoming Dr. V. Ramesh, the president, his team. Also, I wish him shortly, the next 1 year, fantastic public health activities and CMEs during this next year, and next Cuticon also would be wonderful. And we are looking forward, Dr. Ramesh, to be held this Cuticon, coming Cuticon at Warangal. So, my best wishes to you all. Thank you.
రెండు మీరు ఒకసారి స్టేజ్ దగ్గర రండి ఒకసారి అర్జెంటుగా రావాలి అర్జెంట్ రండి. సో ఈ రైల్ కళారంగకి ఎంటర్ అవుతున్నప్పుడు ప్రిపరేటరీ యాక్ట్లో భాగంగా ముందు మేము చూసినప్పటికీ ఇప్పుడు చూసినప్పటికీ దెర్ ఈస్ లాట్ ఆఫ్ చేంజ్. అండ్ ద మూమెంట్ సమ్ ఆఫ్ ది పీపుల్ ఫస్ట్ రియాక్షన్ ద మూమెంట్ దే ఎంటర్ ఇన్ టు ది కళాభవన్ ఈస్ మనమేమి ఇంద్ర సభలోకి ఏమైనా ప్రవేశించామా అని ఒక మాట అన్నారు. వెనక్కి చూడమాక మేడం, ఇంద్ర సభ అది. ఓకే ఓకే. సో ఇటువంటి ఇంద్ర సభ లాంటి presentation ki and wonderful quality of audio and visual ki, there are 2 persons are responsible, and I invite those 2 persons onto the dais for the felicitation with the medallion, and it is audio visual Madhu. I invite Madhu onto the dais for medallion. So because of him only we could able to see wonderful audio visual presentation.
ఇంకే విశేషాలు వరంగల్ ఖమ్మం సార్, ఖమ్మంలో కూడా పెట్టండి, ఒక చీమి పెట్టండి. హైదరాబాద్ నుండి బస్ వేసుకొని పులమంట వస్తాం. 1 డే ఈవెంట్, పొద్దున 10 నుండి సాయంత్రం 6 hours, సింబాలిక్ 6 hours. ఇంకా మీరు లోకల్ రిసోర్స్.
సో మధు ప్లీజ్ వస్తాను ఫస్ట్ మధు. అరుణ్. So the Indra Sabha is because of one person, that is Arun. I invite Arun onto the dais for medallion. Now it is time to medallion to our sponsors. The sponsors of the Cuticon 2024, the pharmaceutical companies, right. So I invite the pharmaceutical companies in order. KLM Laboratories, ready? Andaru vachandi, దగ్గర ముందుకు వచ్చేయండి దయచేసి ప్లీజ్. అందరూ ముందుకు వచ్చేయండి ప్లీజ్. So this is K. Lakshmanana, our Vice President. So KLM Laboratories Limited, Dr. Reddy's Laboratories, Glenmark Pharmaceuticals Limited, Reddy's, Glenmark, Quanta System, Dermix Lasers, Skin Aesthetics, Monichem, Glenmark vachara, Glenmark, Skin Aesthetics, Monichem, Amnacitics, GSK Pharma, H&H Pharma, Hegde and Hegde, H&H, Parkas India Private Limited, Parkas, Skinska Pharmaceuticals, Regalis, Skin Aesthetics పిలిచానండి. Regalis, yes. Mankind, Dolphin, మనకి పిలిచాను కదా, అక్కడ చెప్పండి ఒకసారి మానిక్యం అని చెప్పేసి. డాల్ఫిన్ ఉన్నారండి. సూప్రాసిటికల్స్, అవునా, అయితే ఒకటి చెప్పండి.
GSK Pharma. Next end. Monichem. Quanta System. Dermix Lasers.
Regalis Medicare. అంటే అవి సిటీలో లేవు సార్. లేదు సార్ అక్కడ. GSK ఉంది.
Mankind. Dolphin.
Regalis Medicare. Regalis. Dermix Lasers. Are you there? No. Supraceuticals. Reveal Lasers Private Limited. Reveal Lasers. ఫోకస్ చెప్పారు రివీల్ ఒక్క నిమిషం
సన్ ఫార్మా ఆల్కెమ్
వచ్చారా ఆల్కెమ్ సార్ కింద గాల్డర్మా ల్యూట్రానిక్
Skinnovations, 3 stalls can come at a time.
GSK not there. Dermix not there.
Eris Oaknet Healthcare. Eris Oaknet. No.
Eris ఇక్కడ ఉంది. Oaknet Eris.
వాళ్ళు రావాలి కదా వాళ్ళు అయ్యా వస్తున్నారా వాళ్ళు ఇవ్వాలిగా
24C Derma Labs.
24C Derma Labs. 24C Derma Labs. ఇదో 24C. ఇంటాస్ వాటర్లీ హెల్త్ కేర్ నెక్స్ట్ ఇంటాస్ ఇట్రమ్
ఫాస్ట్ నో వెళ్ళేప్పుడు రిసెప్షన్
వాటర్లీ హెల్త్ కేర్
Nidus Pharma.
నైడస్ ఫార్మా నెక్స్ట్
Sir, Nidus.
చలో నెక్స్ట్ ఇంకోటి
సిప్లా
Skinnovation. Any skinnovations?
ఇప్కా టొరెంట్ ఫార్మా
లైన్ లో పిలవండి
అయిపోయింది
Dermix.
టొరెంట్ ఫార్మా నో
లైన్ వాళ్ళు దాంట్లో ఇచ్చి పెట్టు లైన్ లో పిలవండి అందరూ
నెక్స్ట్ అయిపోయింది ఇంకా
GSK. Panta లేదు కదా.
కెనెక్సియా కామేష్ కెనెక్సియా
అదే గ్రూప్ అందరికి ఇచ్చేసేయండి.
పిల్లలు అలాగే అవసరం లేదు
ఇవన్నీ
మెడల్ ఇవ్వండి
లేడా కామేష్ వెళ్ళిపోయినా ఎప్పుడు నేనేనా మీరు ఎత్తుకోండి ఓకే
మెడల్ తీసుకోండి ఏదో ఒకటి
నన్ను ఎలివేట్ చేద్దాం
కెనెక్స్ ఒక్క 5 minutes.
ఇప్పుడు ఇవన్నీ
మధ్యలో ఏంటి
స్పెషల్
ఇంకా ఉన్నాయి సార్ అన్ని సార్ అసలు
మధ్యలో కనెక్షన్ పిలిచారు
but we'll keep it like this 4 5 పిలుస్తాం you announce for this
saving the time that
you simultaneously no you can micro labs
నెక్స్ట్ మైక్రోల్యాబ్స్ ఈస్ట్ వెస్ట్ ఫార్మా Medmanor Organics. Medmanor.
East west. East west.
Medmanor. Medmanor.
Thank you, sir.
Simbamet. Simbamet. Unity Derma. Unity Derma. Bayer Pharmaceuticals. Bayer. Bayer. Gloderma. Gloderma. Lajora. 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 Dermazone Pharmaceuticals. Dermazone. ఉన్నారా టొరెంట్ ఫార్మా QR678 Neo.
Hold for 5 minutes.
QR678 Neo.
The new EC 2025 will be called onto the dais, and they have a small 2-slide presentation. Dr. Ramesh sir is requesting all the delegates to stay here only for EC 2025 presentation. Presentation is not a big presentation, it's only 2 slides. Okay, I request all delegates.
Prudence.
Sir.
GM Medicine Therapeutics Private Limited. GM Medicine.
GM Therapeutics, sir, actually.
GM Therapeutics, sir. That is different, this is different, or same?
No, GM Therapeutics, I have spelling mistakes, ma'am.
That's okay, that's okay, that's okay.
Yeah.
Derma India.
Derma India.
Derma India.
Madam. Skinova.
Skinova, please. Skinova.
ones?
Dermix lasers. Skinovations. Dermix laser.
Skinovations not there? Skinovations. Okay. GSK. QR 678. QR 678. Belisa. Primalase. Belisa. ఇంకా ఉన్నారు అక్కడ మీదేంటి మీ కంపెనీ చెప్పండి అజంతా ఫార్మా స్కిన్ టీలో ఫస్ట్ అజంతా ఫార్మా
Reveal Lasers Private Limited. Reveal. Skintilo. Yeah. Reveal Lasers Private Limited. Unity Derma. Quantum Systems. QR 678 Neo. Lutronic.
పాల్సన్ ఇచ్చాం పాల్సన్కి ఇవ్వను పాల్సన్ కంపెనీ తెట్టుకును ప్రైమలేస్ క్యూఆర్ 6 పిఎన్పి
It's okay.
Iberia Pharma.
Iberia.
Paulsons.
ఏదో ఒకటి ఇచ్చేయండి.
Dermix. ఉందా? Please come. Dermix.
Madhu. Stop it.
ఏ కంపెనీ? Dermix. Please. సార్ లక్కడి
పెద్ద అనౌన్స్ చేయండి
So now we have a Dermazone Pharmaceuticals Lucky Dip. All of you please witness it, please. Dermazone Pharmaceuticals Lucky Dip live. Babu, ఒకటే రెండా మూడా? ఒకటే లక్కీ డిప్ ఒకటే.
జీ తేజిత హైదరాబాద్. జీ తేజిత ఇప్పుడు లేదు. ఓకే
ఉన్నారా?
టీవీ
ఉన్నారా?
కంగ్రాచులేషన్స్. ఇంకొకటి ఉందా?
గోల్డ్ కాయిన్ అండి.
జీ తేజిత
24C lucky
32 inches LED TV. Thank you for your giving the opportunity, sir. Thank you so much.
24 inches LED TV. Dr. Next is Derma Labs.
M.A. Rahim.
Hyderabad.
So prize is gold coin.
Surprise winner is gold coin. లోపల గోల్డ్ ఉంటుందో లేదు తెలియదండి, బయట కవరింగ్ మాత్రం క్యారేజ్ గోల్డ్ ఉంటుంది. ఓకే, దిస్ గోల్డ్ కాయిన్ విన్నర్ ఈజ్ డాక్టర్
Next.
The gold coin has gone to Dr. M.D. Rahim. I'll just repeat the phone number 897-8466-666-98, Hyderabad. 24C Derma Labs.
So 24C Derma Labs lucky winner is Dr. M.A. Rahim. He is from Hyderabad. His number is 89784-666-98. He is the winner of the gold coin, please.
ఈ ఆర్డర్ మనం పిలవాలి, ఆర్డర్ కాదు. ఉండాలంటే మనం ఇక్కడికి కాల్ చేసుకుంటూ మాట్లాడాలి. అయితే అందులో ఉంది వచ్చేసి ఇవన్నీ లేకపోతే ఆయన అక్కడ పెట్టుకొని అదే
Next, I request and invite our President Sir, Dr. Venkateswaran Sir, to give the mementos to the Executive Committee 2024, IADVL EC 2024. First is President-elect Dr. V. Ramesh Sir. I request Dr. Ramesh Sir to accept the small memento given by our EC 2024. Andar munduku rendam andar. Next, I invite immediate past President Dr. A.K. Lahari Sir. Next is Vice President 1, K. Sai Krishna Sir. Vice President 1, Dr. K. Sai Krishna Sir. Vice President 2, M. K. Lakshman Sir. First. Vice President 2, K. Lakshman Sir. It is Secretary JVDS myself. Treasurer Dr. Sahana Ma'am. Treasurer Dr. Sahana Ma'am. And the two joint secretaries, Dr. Tulasi Jarang and Dr. Vishwanath Prem Raj. And we all the executive committee facilitate our president, Dr. Venkateswaran Sir. So the success of the scientific program is just because of one personality, that is called Dr. D.S.V. Dr. D. Sudha Vani. So we felicitate on this occasion Dr. Sudha Vani ma'am by all executive members of 2024. Right. So now I invite EC 2025 onto the dais. EC 2025 to start with Dr. Ramesh sir as president and Dr. Sudharani ma'am as president elect. And Dr. Rajalakshmi madam as vice president. And Dr. J. Anjibabu sir as vice president. Dr. Anjibabu sir. Dr. Ramchandra Dharak sir as honorary secretary. Dr. Dharak sir is a retired professor from the government and still working as a professor at some primary college. Dr. Ramchandra Dharak sir. And Dr. Premraj as treasurer. Dr. Ainam Satyanarayana sir as a joint secretary 1 and Dr. Hema Reddy as joint secretary 2. So the EC, I introduced the EC 2025 consists of President Dr. V. Ramesh sir, President elect Dr. C.H. Sudharani ma'am, Vice Presidents Dr. K. Rajalakshmi and Dr. K. Anjibabu, Honorary Secretary Dr. Ramchandra Dharak sir, Treasurer Dr. V. Premraj, Joint Secretary Dr. Ainam Satyanarayana sir and Joint Secretary 2 Dr. Hema Reddy ma'am. So these are our new EC 2025. I invite them onto the dais and I request Ramesh sir, a president, to say a few words about the EC introduction, and if you have some presentation sir, we can have the presentation for our people. Madhu, presentation please. Okay, sir, మాట్లాడతారు తర్వాత.
At the outset, I congratulate Dr. Venkatesh Krishna, Dr. Prasad and the team for their hard work, how they have put, I know, from the day one, and there were so many hurdles in their way. Still, they could cope up with the problems, and they have conducted a very nice conference. For the last a decade, I am seeing, particularly in Hyderabad, and this is definitely a memorable conference. Everything was flawless, academics were very good, and I should say all the things they have taken care very nicely. And luckily, he had a very good hand, particularly I should appreciate Mr. Dr. Prasad and how he has worked, and he was calling me. And of course, also the credit goes to Madam Sudha Vani, and she has taken up nicely scientific committee, and really appreciate the coordination between the volunteers and the organizers. I never seen anywhere before. I appreciate for this. And everything, there was no hurry, and everything was well placed, everything, even speakers, chairpersons, everybody was ready, and particularly that media also, they have done a very good job. I appreciate for that. And of course, as a president, now for the next conference, I have a very powerful team now, and I'm happy for that. See, 2007 we have conducted combined state conference at Warangal, and I was president, and again our honorary secretary was Dr. Ramchandra Dharak. Again, now he is also secretary, and of course he is my teacher and mentor in medical college, Kakatiya Medical College, and Dr. Prem Raj. Madam President Sudha Rani, now elected president, and she'll be president for next year. And we have a very good team. Rajalakshmi Madam and Hema Reddy, Dr. Prem Raj, and Dr. Anji Babu. And we are Dr. Ayanam Satyanarayan also in our team, EC team. And definitely we'll try to come up at least to this level. I'm thinking, actually now I'm getting scared whether I'll be able to do it this much or not. But definitely we'll try to put up good show at Warangal. And I request everybody to come to Warangal and appreciate our hospitality. We are known for hospitality. Definitely we are trying to get good speakers from other states. And already we have zeroed on very good speakers. And I definitely have very good academic feast. That much I can say. And the hospitality will be very good. We'll try to do our best. And we all welcome you for the next Cuticon at Warangal. Thank you so much.
Sir, thank you, sir. So your speech started interest in the delegates to come to the Warangal, and it is like a series, Pushpa 1, Pushpa 2 series laganu. So it is Cuticon series is going on. Yeah. Yeah. So I invite every delegate who has attended to these 2 days, they are very happy with the food. So I have to appreciate the person who is behind that catering. It is called Sangam Hotels. So I invite Chandu from Sangam Hotels to have the medallion. Chandu or anybody from the Sangam Hotels. Chandu? Chandu Uchara? Chandu or Chandu representative, anyone. Please come onto the dais to have the medallion. Thank you so much, Sangam Hotels. You have served us wonderful food. The yesterday lunch, yesterday banquet, and today's lunch. Come. Thank you so much. It's good food, no issues from the delegates or for the delegates. Thank you so much. Right. So thank you, sir, Ramesh sir, for your great remark, opening remark for the 2025, Cuticon 2025. And with this, I hand over the mic to our treasurer, Dr. M. Shahana ma'am, to say a vote of thanks for these 2 days. Before that, a small video about the 2025. Sound audio on the? Okay, no problem. Any light background music to pet and So, Dharak sir, I invite you to give your remarks or welcome address, something, whatever it is, because it is your second time you are going to conduct Cuticon.
First of all, I say thanks for the unanimous selection of TG25. And also I congratulate best wishes for the preceding team, 2024. I can say in one word, it's a fantastic conference. So, hope we'll also will do the same thing. We'll, as Ramesh said, we'll do everything academic, scientific, other ambience, other things, everything we'll do it in best manner. So we wish all the delegates to come to the Warangal in a good number to make it success. Thank you very much.
Sir, the Bhadrakali Cheruvu is Kali Ayipindi 2024 lo. We hope with the 2025 it get repaired and with full of water and full with a mini tank bund also. We wish that on the day 1 evening we'll have a wonderful boat ride in Bhadrakali Lake in 2025. Thank you, sir. Thank you so much for your invitation for us to the Cuticon 2025 at Warangal, and hope we do it in the month of November or December. December. Thank you, sir. Thank you so much, sir. Now I invite Shahana ma'am to say.
Good evening, all. I thank all the delegates who have been here yesterday and today, and without you this wouldn't have been a grand success. We thought it would be a successful event, but because of you it has become very grand event, grand successful event. I thank all the caterers who have been provided the good food, which is very much important in any of the conference. And the audio-visual system, thank you so much. And all the pharma companies who have been here with the stalls, thanks a lot. Thank you very much. And we wish Dr. Ramesh and his team for the next Cuticon. Thank you, sir. Thank you so much. Wish you all a happy Pongal in advance.